Jay, can you see me? I've lost.
Yeah, I just muted my mic. That's good. So we'll start in another 8 minutes.
You know something, when I have this on, I lose. Oh, I think I need to do this, don't I? Wait a minute. To get the controls. Yeah, there's the control. So I'll have it ready.
Yeah.
If you could tell me that, if you can see it.
Yeah, Yeah, the webinar is on live. Just make sure what you're talking. Mind.
No jokes, eh?
Yeah.
Okay. That's fine. That's fine. You can hear me okay?
I can hear you. I can see you very well. And
Brilliant. So I need to stop this moving for me because it moves too fast. I don't know how to do that. When I put it on the slideshow, it starts moving by itself. I need to stop the slideshow and move my own slides. Jay, can you see my slides as slideshow or as the PowerPoint?
no, you need to share your screen. You haven't shared your screen.
Oh, okay. I go back to share screen.
Yeah.
Share.
That's it. It's working well.
You can see it, and I go start from there. Okay, so just if you tell me start, I'll start straight away. So, do you see it as whole PowerPoint or just a slide?
Yeah, you need to make it as a slideshow. Yeah.
So like this.
Yeah.
Okay. So have you got everybody there yet?
We'll start anyway. So it's not full view.
Is it not?
Yeah.
So you can't see the whole thing. Okay, wait a minute. I know why.
The sidebar.
Just a second. I think I might have shared the wrong. Can you see it now?
No, we can see it, but it's on the sidebar is still seen.
Oh, it's because my sharing issue. Wait a minute. Can I do a new share?
Yeah.
Wait a minute. There. Is still.
You can stop the share and redo it again. Maybe. Yeah, it works well. Fine. Yeah.
Okay.
Yeah.
I can see face of Sheen there.
Yeah.
Okay, shall I start?
No, wait for another 5 more minutes there.
Okay, that's fine. Yeah, can I change my slides from your Zoom screen? No.
You will. It's already changed. Oh, you can't.
No, that's the thing. Okay, no problem.
My screen will go away anyway.
No, that's fine. It's just like, when it is on the second screen, you can't use your arrow to go up and down.
Okay.
So that's okay. So you ready for a big day?
Yeah. Yeah.
As you've done a very good job out here. So how many people are attending? I mean, beside the trainees, we got about 20 trainees, I take, or something like that.
Yeah, I think so. It's
About 500 people out there watching us.
Yeah, 500 registered. I have a feeling it's usually at least 200 people will be attending. Then other people will be kind of joining in and out, and they will be watching the recorded stuff as well.
We're good to see the stats at some point. I know you always give stats. But can you tell yourself how many people have joined? Oh, 27 I can see. Ah, it's showing up numbers.
And also there's people watching live in the YouTube. That will not be counted here.
Oh, people are watching on YouTube. I see. What's the channel on YouTube called?
Send a special link.
Yeah, it says you're screen sharing live.
That's right. Yeah.
Very exciting.
Just giving choices, making it more convenient for people.
Yeah, I think so. I think so. Yes. No, it's fantastic work. Honestly, I'm so pleased.
I like your photographs. That's really good.
Oh, you mean the one that I finally created? You know what? I took it from the big wheel. You know, remember that the big wheel?
I see.
I went to the top of that with my camera, kept going up and taking another picture.
That's really nice. Really nice. Okay, Sam, I'll just give a brief introduction, then we can
Okay.
start in 2 minutes. Okay. Good morning. Welcome to Scottish Head and Neck Summit. Originally, it is designed for a registrar's training day, and still we will give preference to those trainees, so other people will be watching more on the attendee as a kind of view only participant. We would like to take some questions as well, but more preference will be given to the trainees from Scotland. And the pandemic has made a huge change in the way we are working and the way we are interacting. But certainly, I like the pandemic. It has opened up the world and it has taught us many lessons. And I strongly believe education is the best tool which needs to be generalized and globalized. And that's why we have made this program and generalized to the whole world. I'm very keen to propagate head and neck knowledge, particularly head and neck cancer and rehabilitation to the world. And that's why we got fantastic speakers all around day today. And the first speaker, Mr. Majumdar, is one of my eminent colleague and great laryngologist in the UK, and he has delivered many international lectures around the globe. Sam, it's over to you. And Sam will take for 35 minutes. We do spend some 5 minutes for the questions, so you can use a Q&A channel to write questions. It will come to us directly. You can also chat by yourself, or we can pick up some questions from the chat as well. And once again, it is an educational meeting, and I really don't want any hate messages or inappropriate or abnormal message in this chat box or anything else, please. Thank you. Sam, over to
Thank you,
you.
Jay. Thanks, everybody. Good morning. Thanks for the very generous comments. I've been very lucky to work with Jay for many, many years, and I'm very privileged at this moment to work with him as a colleague too. It's an absolute privilege to talk to you guys. Now, I have prepared this talk for our trainees. So this is certainly not for a talk for the masters. It's not a talk for a master class. So I would take you through this in the next few minutes and hopefully share our experience with you too. Surgical anatomy and management of laryngotracheal stenosis. Now, breath equals life, and it's very important to understand that. Just hold your breath and see how long you can hold it. You could work out that how important it is to you. From the first breath to the last, one needs to breathe to sustain life. And you will see this as we grow. Now, from birth to adolescence, the length of the trachea doubles, the diameter triples, and cross-sectional area increases sixfold. And this is a very important thing to understand, because as the body gets bigger, the metabolic rate goes up, your energy demands goes up, our trachea gets bigger because we need more oxygen. We need to breathe. And this shows up when there is anything that reduces the diameter of the trachea. For trainees, it's important to have take note of this slide. As the trachea narrows, if the trachea narrows, it's reflected very exponentially, dramatically on the airflow. Say the airflow resistance goes up as the tracheal diameter goes down. So and it is proportional, inversely proportional to the fourth power of the radius. So you need a tiny bit of change in the tracheal diameter. There will be a exponential and very impressive change in the difficulty of airflow that one would experience. So when you look at the front of the neck, this is where your airway is. So laryngotracheobronchial airways is the area that we are concentrating on. There is also upper airway, as we know, from the nose to the larynx and the mouth to the larynx. At the front of the neck, you got the structures which are protecting the trachea, the muscles, the strap muscles. And behind that, you got the larynx and the trachea. And at the bottom of the neck, you got the bony structures where you are meeting in the sternum. And this area is quite complex. And as you'll see, as you look into it, you'll see as we go towards the sternum, major vessels appear on the sides of the trachea. Now, on the side view, or the lateral view, you can see in this cartoon picture that you got nerves and arteries. The most important nerve, as you all know, is the vagus nerve and its branches, the recurrent laryngeal nerve. What's missing here in the cartoon picture, you can see that we're not showing the esophagus just behind it. So whenever you're thinking about the trachea in the neck, please think about the nerve, recurrent laryngeal nerve, and the esophagus behind it. If you look at this picture on this other side, which is again a hand-drawn cartoon picture, you'll see how the recurrent laryngeal nerve comes right up to the cricoid and goes posterolaterally to enter the larynx. Now, if you are considering doing any surgery of the cricoid, stay at the front and the anterior part and anterolateral part in the third of the anterior part. If you go towards the back, you will almost certainly damage the recurrent laryngeal nerve. So when you look at this picture, you see how the recurrent laryngeal nerve continues down and the propensity of very major arteries out there. So if you are delving down behind the sternum, or if you're attempting to split the sternum, be aware where you might end up. So when you are pulling the trachea up, you have to be extremely careful and you have to fully understand the anatomy in this area. As we all know, that recurrent laryngeal nerve arches around the arch of the aorta, and the other side, it goes on the subclavian artery. Now, variations exist, especially on the right side. You may see different variations. And don't forget the presence of the thyroid gland. When you look at these hand-drawn pictures, the cartoon pictures, you can see the length of the trachea and how it divides and the angles between them. So it's important for one to understand the length of the trachea. Length of the trachea increases as someone gets taller. In tall person also, the diameter of the trachea is wider. So taller you are, wider trachea that you have. Now this is an important slide because when you are doing any form of resection of the trachea and you will come to the back and you see the tracheal rings are incomplete, you'll see the blood vessels are coming from the back. And in between the two, you have trachealis muscle, and the continuity inside is just the epithelium. One has to be very, very careful not to damage these areas that will damage the blood supply. And always remember the esophagus lying just behind. It is not difficult to make a hole in the esophagus while you're doing any procedures on the trachea, in the neck, or further down. So when you look at the thoracic anatomy, you see the closeness of the trachea to the esophagus again, but as the arteries crosses over. The one important thing for you to remember here is you won't be going there on your own. You will be going there with your thoracic surgeons. If you need to get a bigger pull on the trachea, this vein is something that needs to be ligated. So that's why you need your thoracic surgeon. So most of the surgery of tracheal stenosis that we deal with are cervical tracheal stenosis. Anything more than that, you must involve thoracic surgeons. Now, this slide is just to remind you, we all do tracheostomy. And be careful when you do tracheostomy, spare cartilage and maintain the geometry and the integrity of the trachea. One of the common causes of tracheal stenosis is badly done tracheostomy many years before. So it's very important to remember that when you're doing a tracheostomy, work out carefully. Do you really need to take tracheal cartilage out? It's best if you didn't. Etiology and presentations. Now, there are two areas that you need to look at. One is, why did they have tracheal or laryngotracheal stenosis? In children, in babies, in neonates, you'll see congenital causes are more common in terms of laryngotracheal stenosis. However, when you look at the prevalence of that, it is not congenital causes that gives rise to laryngotracheal stenosis. You'll find that how the larynx or trachea might have got damaged has caused laryngotracheal stenosis, especially if a baby has been in the neonatal unit for a long time and have been intubated. This talk is not about pediatrics. It's mostly, we are concentrating on adults. But you'll see when you look at the congenital causes, you'll find laryngomalacia is high up at 60%, then vocal fold paralysis, subglottic stenosis, and you can see that as the percentage goes down. Then comes the acquired variety, and I'll talk to you about the acquired variety in a minute. So most patients, again concentrating on the adults out here, will present with dyspnea, shortness of breath on exertion. Some may come with problems of voice too at the same time, some degree of hoarseness, depending on how much what's extent of involvement. Cough, throat clearance can be an issue too. Remember, if you are struggling to breathe for a long time, you might develop cough on the top of that because of the dryness effect of the harsh airflow through your trachea or through your larynx. Dysphagia really may be also associated. Tracheal stenosis is rare and potentially life-threatening. Clinical symptoms arise when the trachea or the laryngotracheal lumen is up to 50% obstructed. In the acquired sides of the problem, you'll see prolonged intubation, tracheostomy. In adults, you'll see a small number of cases with granulomatosis, with polyangiitis, and some cases where they had neoplasia and treatment with radiotherapy, etc., and surgery. The narrowing of the tracheal lumen is what determines the intensity and severity of symptoms. Not every tracheal stenosis needs surgery. So you can do forms of surgery when needed, depending on how much is the stenosis and what is the manifestation and the degree of severity of functional issues associated with it. Teamwork is the key. Never go alone. You must not do this form of surgery just on your own. You need a good team of anesthetists and surgeons with you. Remember, you have to always put your patients first. So keep your patients at the center and make sure that you fully understand the need of the patient and the outcomes that your patient is looking for. Of the patient's factor, please take note of coagulation disorders, short neck, obesity. Now, obesity, BMI over 30, uh, usually is associated with poor outcome and even mortality. Enlarged thyroidismus, infection of soft tissue of the neck, previous surgery. Remember, previous surgery is uh, always adds some difficulties and even complications. History of previous tracheostomy, even, and sometimes history of previous laryngotracheal resection. If a patient is needing high ventilatory support, that is more than positive expiratory pressure, more than 10 centimeter of water, they usually have more complications. Now, it is important that you become familiar with certain classifications. As you can see at the bottom, there are number of classifications. I have pointed out McCaffrey, Meyer-Cotton, Lano, Netterville, Cohen, and European Laryngological Society's classifications, of which the two of the pictures that I put on, which is Cotton Meyer or Meyer Cotton, whichever way you like to call it, and McCaffrey are the two that I find very useful. Um, in the Cotton Meyer or Meyer Cotton, you see that the grade of laryngotracheal, subglottic, and tracheal stenosis is graded about the obstruction in terms of the area. Uh, Now, if there is no obstruction, up to 50% obstruction falls in grade 1, as opposed to grade 3, where it's 71 to 99% obstruction. Now, this doesn't tell you about where exactly the obstruction is, which I find very useful if you look at the McCaffrey classification, where you can see the obstruction is at the level of subglottis. Then subglottis more than 1 centimeter, subglottis and trachea, and all three levels, subglottis, trachea, and the glottis affected. Now, one important point here for you to know that you need to know the degree of stenosis as well as the length of stenosis, which is known as the stenotic segment. And the third thing, you must know what are the structures involved: glottis, subglottis, trachea. So that needs to be very clearly identified. So here you can see some pictures of that. It's a very tight stenosis here, as opposed to less stenotic trachea and subglottis. You can also see that this top picture, top left here, is the congenital presentation as opposed to an acquired one, one who had intubation for length of time. You can see this is a long old slide of a pediatric subglottic stenosis. And you can see the difficulty here. You can see that tiny little aperture through which when the child is breathing. So in assessment and management, the history is crucial, especially when you're dealing with adults with long history of shortness of breath, progressively worsening. You need a very detailed history. Patient needs to be assessed very carefully and in detail with flexible laryngotracheoscopy, which we do in our clinic and in our intervention suite. I prefer having a good investigation carried out with CT scan and a 3D CT scan model to show us the detail of the stenosis. Laryngotracheal bronchoscopy is gold standard. So it can be done before you proceed, but it must be done for your understanding. Now, some of that, the clues will come from a very good or well-performed laryngotracheoscopy in the clinic too, which we do quite often. Pulmonary function test is very, very useful, because some of the patients that you'll see might actually come from respiratory physicians because they had been treated for chest problem for a long time. Some patients also have comorbidity, i.e. COPD, etc. in the past. One very important point to remember, that stay focused on patient-centeredness and be absolutely careful with your informed consent, because this form of surgery has associated mortality. Now, as a rule of thumb, you'll find that the grade 1 to grade 2 of Meyer-Cotton and Cotton-Meyer classifications, you'll find that you might be able to manage most of them with little treatment or endoscopic treatment or endoscopic surgery with balloon dilations and CO2 laser division of stenotic segment. This works well when the stenotic segment is short, but not long stenotic segment or not frequently recurring cases. If the grade is 3 to 4, you'll find that an open surgery and resection of the stenotic segment, cervical stenotic segment, with anastomosis, i.e. reconstruction, is the best way forward. So, to summarize, what are the measures of success? Now, to know what's the measure of success, you must know how to avoid what's not good. Poor selection of cases, poor selection of surgical intervention, poor perioperative care. So choose carefully, deliver precisely, and attend constantly. By that, I mean you need to attend the patient from the time you met them, and especially perioperatively, very closely. That's when complications can really bring in serious harms. Now, I haven't got the opportunity here to talk to you in detail of operating procedures, but I have mentioned here and highlighted some books, etc., that you might be able to read, and papers which will help you. Now, when you are contemplating surgery, go back to the classifications and work out the segment and involvement of the anatomical structure, i.e. the glottis, subglottis, larynx. If it involves glottis, subglottis, you are thinking about laryngotracheal resection and reconstruction as opposed to tracheal stenosis on its own. Take note of previous tracheostomy, because that will determine what form of surgery you can do to reconstruct the after resection of the stenotic segment. For all cervical stenosis, resection, after resection, you do an end-to-end anastomosis as described in this cartoon picture. You can use Vicryl. We often use PDS in our practice. Now, you might find that once you've done your resection, and if the resection is up to 4 or 5 centimeter, that there is a big gap, and you're starting to panic whether you'd be able to pull the trachea, distal and the proximal part together. Suprahyoid release, well known as Montgomery, described by himself, release is can give you 2 to 3 centimeter of length. But remember, this comes often with complications. And one of the complications, besides bleeding intraoperatively and postoperatively, is difficulty swallowing. You can also do infrahyoid release, described by Dado. In this, you get up to 2.5 centimeter of length. We often use this technique to get the length. You can also release the distal trachea by going further down around it, behind the sternum manubrium. Sorry about this. Now, this is a good paper for you to read. It's come out quite recently. it shows you that the common causes of tracheal stenosis is post-intubation. So a lot of ITU patients, you probably see a massive surge of that after the pandemic, a few years after the ongoing pandemic. Tracheostomy, as I said to you, is also an important cause, badly done tracheostomy. So the series that they looked at shows 228 patients with 80% post-intubation. Laryngotracheal resection they described out here, and you can see the success rate is excellent. They have 98.7% success rate on after such surgery. So if you carefully choose your patients and do it well, your success rate is very high. And this is a 2021 paper saying the how surgical techniques are ultimately improving outcomes, I would say patients' lives. This is another paper from a group in Italy, and you got the details here if you want to go and read it. And here you see laryngotracheal resection. In laryngotracheal resection, you involve the cricoid cartilage, and you often have to do a vertical incision on the midline on the thyroid cartilage to create the anastomosis, to create the space where you do anastomosis. After resection, you can see here the gap has been created, and you can see that both the lamina and on both sides you can see the trachea has been anastomosed to lamina right and left side. This is one of our cases. You see now we use a total thyroidectomy incision, like a collar incision, and expose the trachea. Here we have resected the stenotic segment. You can see the endotracheal tube at the back, and we are measuring it. Is about 3 centimeter defect. So you identify the segment, and you then resect it. Now, often we do an endotracheal examination first before we proceed to opening the neck, and we might dilate it at that point and pass the thin endotracheal tube, which we often pass it on behalf of the anesthetist. And then once we have done this resection and reconstruction is done by end-to-end anastomosis. As you can see that multiple sutures has been placed. One has to be extremely careful in the posterolateral parts. And the success of anastomosis and prevention of restenosis is directly related to how you do your mucosal anastomosis. Do not make these sutures too tight. And as you go posterolaterally, be very careful not to stitch in or put a suture around the recurrent laryngeal nerve. This is just almost complete. When we complete our anastomosis, we fill in the surgical defect with saline, get the patient's head down, the head end of the bed down, and we get our anesthetist to do Valsalva to see if there's any air leak. If there's any air leak, you see air bubbles coming up through the water, and you can identify the point. It's almost like you do anastomosis of bowel. And then you can stitch that area. We put tissue glue on the top of that and soft tissue from around on the top of that. We leave a corrugated drain there, E8s, and then close the wound with drains. Complications of tracheal resections and reconstructions. The most devastating complication, which is the commonest cause of mortality, is anastomotic separation postoperatively. This is why one has to be very careful about how you attend the patient. Granulation, descent, restenosis are other complications. Non-anastomotic complications involve damage to recurrent laryngeal nerve, tracheal fistula, tracheal innominate fistula, laryngeal edema, dysphagia, wound infection. So to summarize and come to conclude, you have to absolutely make sure at the beginning, do no harm. Never practice on your own. Always go with a full team, with other surgeons with you, a good, well-trained anesthetist. We are very lucky about that we have a fantastic anesthetic service. And make sure that your patient knows all along that what is he or she going to get. You need to avoid the issues that causes complications and focus on what delivers better care. Thank you. Any questions?
Brilliant. Sam, can you look at the Q&A session? There's two questions.
Can you read it out to me, because I can't see it?
That's fine. Okay. Hi, Mr. Majumdar. Would you ever offer and try a Madden procedure after multiple of balloon dilatation in idiopathic subglottic stenosis before moving the open reconstruction?
So do we offer this procedure? In our practice, we, for short segment tracheal stenosis, when we do not have a cause known, i.e. idiopathic, the biopsy, we always take a biopsy every time we go in. If it is recurrent, by recurrent, I mean someone is needing more than 3 endotracheal procedure with laser division and balloon dilation within a year, we consider, nowadays, we consider open surgery. Now, I must say that I'm still learning, and my learning is getting better all the time. But talking to many of the eminent surgeons, i.e. Guri, Sandhu, etc., nationally, idiopathic stenosis can only be dilated so many times. And so it's important that you start the conversation with your patients very early to say that after so many times, you probably need this. And also, if you start seeing it is actually getting more stenotic after more and more interventions of balloon dilation and laser division, etc. Does it answer your question?
Yes, I think so. Second question is from Michael Hopkins. Do you routinely identify the recurrent laryngeal nerves in your tracheal resection and reanastomosis?
You should not look out for the recurrent laryngeal nerve if that is at all possible. Your incision must be within the perichondrial. So when you're doing your dissection, stay subperichondrial. So you are avoiding that too. So if you look at the large series, which goes up to 300 plus, and the works of Grillo and Montgomery and all of the others, they always tend to avoid looking for it. However, this is the thing I point out to you. If you do not know where the recurrent laryngeal nerve is going to be, and if you don't see it when it's actually in front of you, that's where the problem is. And you see such things when you have trainees with you. They can't see it. They're not familiar with it. And so anatomy is pretty fixed. There are very small variations and less than 1% variations in the positions of recurrent laryngeal nerve, not at the tracheoesophageal groove, but at the point they turn back. So that's where the variation is. So no, I do not go looking out for the recurrent laryngeal nerve. I don't know what would be your answer. And I work with Mr. Manik too. I don't think he looks out for it either.
Yeah, absolutely correct, Sam.
Mm.
I don't really look for it, but I know where it is.
Yeah,
Uh,
you must know.
you have to be careful, especially when Sam said the first row, lateral part, where the trachea is a bit in groove, particularly on the left side. You have to be very careful while suturing. You don't want to take a bite and strangle the nerve as well.
That's the tiger territory. That's the tiger territory. Do not make mistakes out there. And don't think that if you put in a endotracheal tube, that will has a that will have an alarm and tell you that when you are about to cut it, that's going to save you. That's not going to work.
Brilliant.
You can use one of those tubes, but it's not going to help you.
Question from Victoria, it's our trainee. How long does the patient remain intubated or post-operatively?
Our patients nowadays don't remain intubated anymore. In the early days, I think, Jay, we had one patient, and then we moved on. So yeah, our patients go to high dependency unit. The reason is very simple, because we don't have a ENT wards anymore. We used to have ENT wards where the front bay used to be our high dependency unit. That has been disintegrated nationally, thanks to National Health Service and others and the managers. So otherwise, we are. I think that you can keep your patients with you if we have one nursing care available overnight who can monitor their breathing. It's
Good.
very important. And I didn't talk to you about the position of the neck. We like to have the neck slightly flexed, and we tell them not to extend their neck. And we have started also sending them home, discharging them with a soft collar, so that stops that movement. So your answer to your question, no, we don't send them to intensive care unit with that intubated. That doesn't happen anymore, and that's the practice of almost everyone I know.
Absolutely. And after the reconstruction or suturing, end of the procedure, we use fiber optic endoscope, which we pass
Yes,
through the
yes,
endotracheal,
yes.
and we assess the anastomotic site in with the anesthetist. If both are happy, we extubate on the table.
Yeah,
Uh,
yeah.
there's four more questions. One from Dylan Shetty. Is Cotton-Mayer's classification applied to subglottic stenosis or to the tracheal stenosis also?
The cotton wire classification was created for subglottic stenosis. So that's the reason I put 6 different types of classifications out there. It, I mean, to get a good understanding of what you're dealing with, you need to spend about 500-600 hours of reading and studying. So I would strongly suggest that you read what I put on the slides, the McCaffrey and Lano and all the other classifications. The answer to your question, no, it doesn't. It's subglottic. And so an answer for your FRCS, if you're meeting me as your examiner, yes, it's subglottic. So if I ask you what other classifications do you have, I would be expecting you to know how to look at the trachea too and classify it. And that's why McCaffrey is very important. It tells you where exactly, what is the site, subsite, and is there more than one subsite? So if you look at Lano talked about 3 subsites, the glottis, subglottis, and trachea. McCaffrey has kind of combined it together. So answer to your question is no. And I would request you to please look at all the classifications, because it's important not to memorize, but to do the job. Sorry, I just took too much time.
The next question is regarding tracheal stenosis. What is the maximum length of the tracheal stenosis that we can manage with resection and anastomosis? That's a very good question.
It's a very good question, but if you depends who you're talking to. If you talk to my guru, or my friend philosopher and guide Guri Sandhu, he would probably say 5 centimeters is fine. We'll just do that. A thoracic surgeon will probably do much more, depending on how far you're going to go. Uh, so I would say up to 5 centimeter, we could quite easily manage with uh, release up in above and below in the neck. I don't go into the chest to operate because we don't have thoracic surgery support. But thoracic surgeons can do a lot more of that because you see, in the part in the chest is quite a lot more mobile.
Good. One more question. Do you single stage or two stage LTR?
I would prefer to do, when I did my pediatrics, I trained in Sheffield. We always did single stage those days. And all my pediatric colleagues that I know, they nowadays do single stage. You may have to, in complex cases, do two stage. And if you talk to the Haytham and others are our local experts, or our GOS colleagues, Michelle, etc. You will find that most of these procedures, especially in pediatrics, are done that way. I don't do pediatrics anymore, pediatric laryngotracheal stenosis. We just concentrate on adults. So in adults, for me, it would be a single stage. And I would avoid any form of tracheostomy. Tracheostomy is an absolute no-no. So if you remember that, because that is the problem that eventually causes you tracheal stenosis. So remember, trache, you have to absolutely make sure that it's when possible and if possible, you're not doing anything twice.
Brilliant. A question from Leon Hamilton, our trainee. Is there less risk from percutaneous tracheostomy for stenosis in future? It's a really good question.
So sorry, I didn't quite follow it.
Is there a less risk from percutaneous trache for stenosis in future?
Oh, thanks, Leon. Good to have a question from you too. I think the risk is less. I personally think, but I can say these things at the coming to the almost at the end of my career, because I'm not worried if anyone else is doing tracheostomy. But the only problem we have is not doing tracheostomy is a huge amount of experience which will go away from our ear, nose, and throat trainees and future surgeons. If you do a tracheostomy carefully, so if you do compare carefully, there is now no problem. So I have another talk that I gave some time ago. So if you do a careful tracheostomy and compare with complications with percutaneous, in terms of the outcome of stenosis, there's no difference. And if you look at the Manchester study, I can personally share it with you, some of my slides, there's no difference. But if you look at tracheostomy done, where people have taken large parts of tracheal cartilage out, made big holes, etc., there's no comparison. Percutaneous would be 100 times better. So the answer to your question, carefully done tracheostomy, tracheostomy when it's done reversible or short term, just to get to secure airway, there's no difference in the long term. Of course, it's more surgery, but in terms of outcome of stenosis, no difference.
Brilliant. I think we have answered all the questions. Thank you very much, Sam.
Thank you for letting me speak. Thank you. Good luck and have a wonderful day. I'll join in as a as an attendee now. Thank you.
Yeah.
So how do I get out? Just switch off, leave.
Yeah, you don't have to leave. You can stay there. Yeah, good.
Oh, Panas.
Now we have.
Good morning, everyone.
Thank you.
The next speaker is Panas. He's one of my colleague from Scotland. He mainly practices head and neck cancer. He did fellowship in USA, and he's one of the fantastic speaker. And he's kindly actually he's online, but he has recorded. So I'm going to play that, but he's available for your questions as well.
Good morning, Jai. Good morning, everyone. Thank you for asking me to talk on today's study day. My topic will be on advanced laryngeal cancer. I'm Panos Smakopoulos. I'm a consultant ENT head and neck surgeon in Aberdeen Royal Infirmary. So obviously a pretty big topic, but I'll focus on a few areas here: anatomical considerations, classification, landmark trials that have affected our treatment regimens, guidelines that we use here in the UK, and things that we should be taken into account when selecting patients for treatment. Anatomical considerations. The laryngeal sides and subsides, the supraglottis, the glottis, and the subglottis. The supraglottis has the infra and the suprahyoid epiglottis. They are epiglottic folds. The arytenoids and the ventricular bands. The glottis has the true right and left vocal cord, including the anterior commissure. The subglottis has no subsides. Laryngeal SCCs predominantly affect the glottis, followed by the supraglottis. The preepiglottic space and the paralaryngeal spaces are quite important, especially when considering tumor spread patterns. The preepiglottic space is a potential space immediately in front of the epiglottis. It's bound by the hyoepiglottic ligament superiorly, the thyrohyoid membrane, the lamina of the thyroid cartilage anteriorly, the thyroepiglottic ligament inferiorly. This is a potential space which is made out of adipose tissue and is devoid of any lymph nodes. The preepiglottic space is quite oftenly referred as the periepiglottic space because it extends slightly beyond the lateral margins of the epiglottis, and it's often referred to as being a horseshoe-shaped. What's important to know is that there are fenestrations on the base of the epiglottis at the infrahyoid epiglottis that can lead directly to tumor spread into the preepiglottic space. The paraglottic space is a potential space bound by the thyroid cartilage and the cricothyroid membrane laterally. Medially is bound by the quadrangular membrane and the conus elasticus. And posteriorly you have the piriform sinus, the piriform fossa, and posteriorly the paraglottic space extends to the cricothyroid joint. The paraglottic space is made of primarily again of adipose tissue and also contains the internal branch of the superior laryngeal nerve. Transglottic tumors, as defined, are as tumors that encroach on both the glottis and the supraglottis, with or without subglottic component, and quite often the site of origin is unclear. These tumors spread usually through the paraglottic space. The barriers to tumor spread are the quadrangular membrane, the conus elasticus, the thyrohyoid membrane, and the Broyles tendon. Broyles tendon has been slightly controversial because originally it was thought to be a site of tumor spread. Broyles tendon is defined as the insertion of the vocalis muscle to the thyroid cartilage, and this is an area that is absent of any perichondrium. However, recent studies by Kirchner's group has shown that this is actually a strong barrier to spread of tumors, especially in the absence of any significant supraglottic or subglottic involvement. So enough about anatomy, let's talk a little bit about classification. The 8th classification system hasn't really changed compared to the 7th when we're talking about glottic, supraglottic, and subglottic cancer. So locally advanced is defined as T3+, T3, T4A, T4B, T3 in the supraglottis and the glottis, and also the subglottis involves fixation of the cord, at least one cord, obviously. The supraglottis and the glottis, T3s also involve the preepiglottic and the paraglottic spaces with minor inner cortex thyroid cartilage erosion. T4A tumors, on the contrary, involve involve the entire depth of the cartilage, of the thyroid cartilage, and also involve tissues beyond the larynx. E4B is defined as locally advanced unresectable tumors invading the prevertebral space, the mediastinal structures, or encase the carotid artery. So let's talk now about some of the landmark trials that have been around and have affected our treatment decision making over the last 20-30 years. The two major trials I would expect our registrars to be aware of when taking their FRCS exam is the Veteran Affairs Laryngeal Cancer Study Group, published in 1991, and the RTOG 9111 trial, published in 2003. Both of these papers were published at the New England Journal of Medicine. So the first trial is a trial that we all like to tear apart, but it's a very important trial. This is the trial that tested the standard of care at the time, which was total laryngectomy and postoperative irradiation, versus induction chemotherapy and radiotherapy, in an attempt to promote organ preservation in laryngeal cancer tumors. Both arms showed similar 2-year overall survival at 68%, and the chemoradiotherapy arm also shown overall larynx preservation rate at 68%. This percentage was much lower for cancers that were staged as T4 compared to cancers that were staged as T1, T3. And this is actually one of the criticisms of the study, that although defined as advanced laryngeal cancer, these patients were classified as advanced based on their nodal status, not as their not based on their tumor status. So there were quite a few patients, 9% of patients with only T1, T2 cancers, and only 9%, about 1 in 10 patients, had cartilage invasion. In addition to that, 44 patients had mobile cords. So you could argue that all of these patients, not all of these patients were actually overtreated with either total laryngectomy or chemoirradiation. It's also important in these studies that although the 2-year disease-free survival was similar, the 5 to 6-year disease survival was quite different. Then 12 years later, the RTOG 9111 study was published. This study compared the non-surgical arm of the laryngeal Veteran Affairs study, which was induction chemoradiotherapy, induction chemo and radiotherapy, versus concurrent chemoradiotherapy versus radiotherapy alone. So this study mainly looked at the timing of adding chemotherapy, and also whether adding chemotherapy would make any difference compared to radiotherapy alone. The 2-year laryngeal preservation rates were very similar, but significantly higher in the concurrent chemoradiotherapy group compared to induction chemo and also radiotherapy. The 5-year overall survival rates were exactly the same, more or less, in all 3 groups. But as expected, there was more toxic effects of chemotherapy when that was used either as concurrent or later on as part of the induction chemo and radiotherapy regime compared to radiotherapy alone. And these 2 studies have affected treatment paradigms throughout the world. This is a paper from the US in the mid-2000s, showing trends in patterns of care from the mid-90s to the early 2000s. As you can see here, radiation and chemotherapy was increasing, surgery alone or surgery with irradiation was decreasing. The long-term results of the RTOG 9111 were published 10 years later in 2013 in JCO. The median follow-up increased from 3.8 to 10.8 years. And as you can see here, laryngeal preservation was again found to be superior in the concurrent chemoradiotherapy group, But a new parameter, a new outcome measure that they introduced was found to be similar. And this new outcome measure was laryngectomy-free survival, which means being alive, as the name implies, being alive without a laryngectomy. Again, overall survival was the same among 3 groups. Local regional control was better in the concurrent chemoradiotherapy group. But what was very important about these studies that is shown that there were quite a significant amount of deaths at 10 years caused by non-cancer causes in the concurrent chemoradiotherapy group. And so overall, this study has shown that adding chemotherapy can make you preserve your larynx for longer. However, you could die from other causes. And this has been speculated to be the case with patients dying from non-aspiration or having a poorly functioning larynx. So let's look at our guidelines here in the UK. You probably all aware of this document, the BANO guidelines published in 2016, something that we use in all MDTs throughout the country. So I'm just going to focus on T3 glottis. Most patients with T2B or T3 glottis should be suitable for non-surgical larynx preservation therapy. Chemoradiotherapy should be the standard of care. TLM or open partial surgical procedures should be used in selected cases and in areas of availability of appropriate surgical expertise. Elective treatment of the neck should involve levels 2 to 4 in clinically negative disease, and if you have node positive disease, level 5 and level 1B could be considered. With supraglottis, pretty much a similar approach. Concurrent chemoradiotherapy, the standard of care. TLM or open surgical procedures could also be considered in selected cases. Levels 2 to 4 bilaterally in clinically node negative disease, and levels 2 to 5 should be considered at least on the involved site. The neck should be managed as per the PET neck clinical trial results. That means N2 or N3 neck disease should be operated only if the post-treatment PET CT is negative. So, excuse me, if it's positive. For larynx, again, larynx preservation with concurrent chemoradiotherapy should be considered unless there's tumor invasion through the thyroid cartilage into the soft tissues of the neck, in which cases total laryngectomy should be offered, as the outcomes are much better. Elective treatment levels 2 to 4, 5, and 6 should be considered bilaterally. So these are our guidelines that we use here in the UK and that are followed in most places around the world. Patient selection is very, very important. Treatment decision factors that I tend to take into account, and most people do in their NDTs as well, are the following. Functional assessment, performance score using the ECOG or the Karnofsky scores are very important. I tend to see my patient at least twice, sometimes even 3 times prior to surgery, whether that's on the ward, whether that's in the outpatient setting, or now as we tend to do over the telephone. I would like to know what they can do and what I feel they will be able to do after surgery or after a long course of radiotherapy. I quite often speak to the families or occasionally have spoken in the past to their GPs if they have no immediate family that they would like me to speak to. Patient factors are quite important, especially comorbidity scores, using the ASA classification system that we use perioperatively, or the Charlson Comorbidity Index, ACE27 questionnaires that are used in the academic setting. Nutritional status is of prime importance. You want to know what their albumin is, what their BMI is, how much they can swallow. Psychological assessment is also extremely important. You want to know what their cognitive function is. Are there any mental disorders that are underlying? Is there any evidence of substance abuse? Are they heavy drinkers, heavy smokers? All that stuff is extremely important. And there's been recently a few papers out there to show that head and neck cancer patients are quite frail compared to patients with other malignancies. This is a paper from the Netherlands. Another paper from the Danish database has shown that patients with head and neck cancer with 2 or more significant comorbidities, whether that's ischemic heart disease, liver failure, respiratory failure, drop their survival, their overall survival by 50%. And also what's important to know is that now we're seeing a lot of elderly people with head and neck cancer. This wasn't the case when all these studies, such as the VA larynx trial or the RTOG 9111 that I previously mentioned, were published. You look at people's median, study population's median age being in the mid to late 50s. Quite often in our clinics, we see patients in their 70s or sometimes in their early 80s with laryngeal cancer. Tumor factors, extremely important, whether that's staging or extent of resection. So I think it's quite important to know whether you have pharyngeal involvement, because this will determine the amount of surgery you have to do. You might have to do a partial pharyngectomy or a total pharyngectomy with a circumferential defect that will require reconstruction. And also that will have implications to non-surgical options that the patient might follow. For example, a patient with significant hypopharyngeal involvement is very likely to need gastrostomy, a tube for nutritional supplementation throughout their organ preservation treatment option. I also find that that previous radiotherapy does make a big difference to your resection, whether that's resection of the primary, reconstructive options, and also management of the neck. As we all know, patients with undergoing salvage total laryngectomy have a much higher chance of fistulization, neopharyngeal stenosis, and perioperative wound complications. And a study that I would expect our registrars to know for their exams, in 2014, a study led by Vin Polari has shown in a systematic review that the fistula rate reduces by about 37% when a free or pedicle flap is used for reconstruction. The extent of the neck dissection in the salvage laryngectomy setting has also been questioned in the past. We did publish some data from Edinburgh when I was a registrar there, and there's subsequently been a systematic review on the topic showing that the occult nodal positivity rate is only about 11%, and that positivity rate drops even further in the contralateral neck. So somebody could argue that you don't need to do the neck dissection in the salvage laryngectomy setting because the neck has been previously treated by radiation. And these are important things to keep in mind overall. I assessed patients with a CT neck and then thorax with contrast. I personally don't find MRI particularly helpful unless I think there's some mucosal involvement of the base of tongue, or there's any debate or any doubt about whether the cartilage is being involved in the larynx, the thyroid cartilage. In addition to this, MRIs are not, well, radiologists that are at the head and neck entity sometimes moan about MRIs because they're not as readily available as CTs. But there are other advantages with MRIs. You don't have that temporal artifact, which is normally not a problem when you're looking at axial imaging at the level of the larynx. An endoscopy under general anesthetic is of vital importance, and I think all surgeons considering surgery should be doing pan endoscopy themselves. You want to look at the base of tongue, you want to look at the pharynx, and you want to be able to have an idea whether you're going to need a flap as onlay or as inlay to facilitate your closure. Also, if the base of tongue is involved, you might have to consider a total glossectomy, which is a significant operation with very increased morbidity. Preoperative assessment. I always get patients seen in the pre-op clinic, even if they have no previous medical history of significance. Quite often I'll ask for neck or pulmonary function tests. Pulmonary function tests are extremely important if you're considering partial laryngectomy approach for patients. I always get patients seen by dietitians and SALT speech and language therapy colleagues. I think it's very important to know what kind of things they swallow, what their swallow, is their swallow safe, because these are important decision points that you have to make when you decide to go ahead with radical treatment, either surgical or radiotherapy. Patients that are having difficulty swallowing, that means the larynx is not working. So if you irradiate their larynx and their pharynx, you're not going to make those symptoms any better. So you might want to either avoid doing this by doing an upfront laryngectomy, or consider a gastrostomy tube for nutritional supplementation throughout their treatment. So now I'd like to speak about 3 cases that I've been dealt with over the last 6 months here in Aberdeen. First patient is, they're all T4A cancers, but I just want to show how some of them behave so differently. Just a snapshot. It's all anecdotal evidence, obviously. So the first case is a 63-year-old lady came in with hoarseness. She's a smoker and presented with a fixed right focal cord. Submucosal transglottic mass was identified on her CT. She had biopsies, and you can see here thyroid cartilage erosion on the right side. She underwent total laryngectomy, lateral neck dissections, postoperative irradiation, and she's doing very well. She went home on day 12 postoperatively, and she did that absolutely fantastic, like you would expect a primary total laryngectomy patient to do. Unlike this gentleman here, presented to the clinic back in November with an exophytic tumor, a fixed left vocal cord mass, and within 2 weeks he presented to A&E with acute airway obstruction, acute subacute airway obstruction. He underwent debulking in theater. You can see here a hand sac and tube was inserted using, we used cold steel techniques and suction diathermy. This is his pre-debulking CT showing an extensive laryngeal tumor, destroying the thyroid cartilage, invading the straps, and also the thyroid gland. So he opted for a total laryngectomy, bilateral neck dissections. He had a left-sided modified radical neck dissection. And he didn't do well. Within 2 months, he presented with an early recurrence coming from the base of tongue all the way down to the stoma and encasing his carotid here on the left, going down to the mediastinum. Unfortunately, he passed away within 3 months of his laryngectomy, so a completely different picture compared to the previous patient. And this kind of presentation takes me back to the days where people used to say, if you do a tracheostomy during a laryngectomy, prior to doing a laryngectomy, you're risking the chance of seeding. This guy didn't have a tracheostomy. His tumor came out with clear margins, but his biology was so aggressive that this tumor came back with vengeance, and unfortunately he passed away 3 months later. This is another gentleman, a 70-year-old ex-distant smoker, seen in our clinic with laryngeal dysplasia for many years. He came in with worsening hoarseness. He had a fixed right vocal cord. Biopsies confirmed squamous cell carcinoma. This is his CT here, extensive laryngeal destruction. And he was offered total laryngectomy, but he refused it. So instead, he had radiotherapy. He wasn't fit for chemotherapy. On his first week of radiotherapy, he required a tracheostomy because things got swollen. And you would expect that this man wouldn't do very well, but now he's 4 months down the line. I saw him in clinic the other week. He's decannulated and he's swallowing absolutely fine. So again, another picture, another scenario that shows that patient wishes sometimes take you to places that you don't expect to go. And all of these are T4As, but their outcomes are very, very different. So there's definitely limitations in the staging system. I'd like to close now with a paper from I came across in Head and Neck recently. It's from Tata Memorial in India. I really like this paper, not mainly for the results and their findings. It's only 100 patients with undergoing organ preservation protocols for advanced laryngeal and hypopharyngeal cancer. But what I really enjoyed was that they brought in the concept of a new outcome measure. They brought in the concept of functional laryngectomy-free survival. And this is larynx functionality assessed at each follow-up with a speech-language therapist using methods such as FEES or modified barium swallows or video fluoroscopy. And to me, that's a much better outcome than disease-specific survival or laryngectomy preservation rates when you're going to end up 10 years down the line from microaspiration. To me, this is a composite endpoint with that will provide an idea of what the overall impact on these patients' quality of life and meaningful organ preservation treatment options can be. And I'd like to thank you all for giving me the opportunity to speak to you. I'm more than happy and be delighted to take your questions. Thank you all.
Brilliant, Panas. Thank you very much. Absolutely very honest and the realistic of advanced head and neck cancer, particularly larynx. I think there are questions. Can you able to see the panel?
Yeah, I can see it. So the first question: how do you decide about neck dissection for end-node neck for transglottic cancers? So that was actually answered during the presentation. I think the question came in quite early. So if it's a primary laryngectomy, then you have to do bilateral necks, especially when the supraglottis is involved. I think that's the standard of care, levels 2 to 4 for end-node disease. I personally do a little bit of 5 as well, because I go posteriorly on the SEM and I take a little bit of anterior level 5. And of course, level 6, the paratracheal and paratracheal areas, which are essentially in your field. For the salvage setting, as mentioned earlier, you could consider not doing the contralateral side because that side has been treated before. Unless you need access for a flap from that side, then might as well do it. But when you mobilize the larynx, you almost have to do anterior levels 2 to 3 to 4, 2 to 4. So definitely to answer for primary disease, definitely bilateral. For salvage disease, you could consider unilateral neck dissections. Does that answer the question? So the second question, how long you will recommend follow-up after total laryngectomy for advanced laryngeal cancer, and how long for possible associated aerodigestive tumors, metasynchronous? So the guidelines say 5 years, but again, you're right. Sometimes these patients come back with lung cancers, hemoptysis, and esophageal cancers, metasynchronous tumors. For us, here in Aberdeen, I think most units in the UK, the head and neck surgeons is 5 years, and then they stay under speech and language therapy follow-up. So if there's any concerns, patients have open access to the clinic, either themselves directly or through the speech and language therapy colleagues. So I think 5 years is a minimum, but after that, they have open access. So they can always come back anytime. And the last question is, how do you decide on management of the thyroid gland when operating for T4 lesions? That's interesting. I personally tend to do the unilateral lobe, well, the ipsilateral lobe to the cancer always, but the pickup rate is pretty low, actually. The pickup rate is less than 20%, less than 10%, depending where you look at. Very rarely I do total thyroidectomy. The second gentleman I discussed, because the cancer on the scan was going through the thyroid gland and the straps, we ended up doing a total thyroidectomy, but surprisingly, his thyroid gland was not involved. So the pickup rate is low. I would recommend for gross destruction and extralaryngeal extension, I would recommend doing the unilateral lobe, the ipsilateral lobe to the disease. And that has implications, however. You have to think about hypothyroidism, especially even if you preserve half of the thyroid gland. Quite often these patients become hypothyroid following radiotherapy, post-operative irradiation. So you have to keep an eye on your TFTs, especially when they come to the clinic to see you a month after their irradiation. You have to make sure either yourself or the GP checks their TFTs, because that's very important with regards to healing, recovery from radiation, and also swelling. And the last question, after total laryngectomy, what is best time to start speech rehabilitation? So almost all patients, I mean, everyone that I know of will get post-operative irradiation as a minimum. Some people will get chemotherapy as well. So you do want to, our speech and language therapy colleagues get involved with them while they're on the ward. And if they pass their barium swallow, the swallow contrast in day 7 or day 10, depending on when you want to do it, then they insert the valve. So the valve, they leave the ward with the valve, the speaking valve, and they start practicing immediately. You find quite often that following irradiation, the valve does not become as good and they have to change it following completion of irradiation. But I think speech rehabilitation should start as soon as possible, either through a valve, either through esophageal speech, or even through an electrolarynx. The next question, how do you manage advanced laryngeal cancer invading the lumen of the trachea seen by bronchoscopy? So that's difficult when the disease is going very inferiorly, because you have to go down. And the problem by going down is that, anything below a level, 4th, 5th ring, you have to do a tracheal resection, which means you're going to have to do a mediastinal stoma. You have to resect bone. And these stomas, I've never done one, but from speaking to colleagues, they're very difficult to manage. They get a lot of crusting, and patients struggle. But quite often, you just have to follow the disease. So there's a question from Mr. Shakil that's come in. Can you please comment on primary versus secondary T puncture? So for T puncture, I always do it, and most people will do it for primary laryngectomy. In the salvage setting, it's slightly controversial, because if you have a fistula, the fistulization rate increases dramatically in the salvage setting, from 20 to like 50%, even in some series up to 75%. So if you have a fistula, especially if you haven't done a flap, then the fistula, the saliva could run into the, if you've done a puncture, then the saliva could run into your trachea, and then the patient will have problems with aspiration and pneumonia. So that's an argument for not doing the puncture primarily in the salvage setting. And I tend to do the same. I don't do a puncture primarily in the salvage setting. So I would wait for them to finish, to come back and start considering in about 2 to 3 months after they finish their after surgery. In the meantime, they can have an electrolarynx, cervix, or triesophageal speech. Does that answer the question, Mr. Shakil? I think it does.
Yes, thank you. And just a point, remember here we do insert a feeding tube through the initial puncture. So in the first 12 days, they're feeding through that puncture hole, and then you replace it with a valve, isn't it?
Yeah. I mean, in Aberdeen, that's what we do. In other places that I've worked, some people insert the valve primarily and then put a nasogastric tube instead of a stomogastric tube. Problem with a nasogastric is that first of all, it's very uncomfortable for the patient because they have especially if they fail their swallow test, they're stuck with this tube. And the other problem with that is that there's a theory, I mean, I don't think it's never been proven, like with most things in surgery, that having the nasogastric tube through the suture repair could predispose to problems with a suture repair. The other option, the other way to overcome this is to do a rig, a gastrostomy tube for these patients. Yeah, this is what we do in Aberdeen, but most people are moving away from this. They're putting they put a valve, a speaking valve primarily, rather than a stomogastric tube. I don't know what, Jai, what do you do in Dundee? Do you put a valve up front, or you do a stomogastric?
I'm a big fan of primary valve.
You are.
It very much depends upon the tissue in the bottom of it. Actually, if you think it's fully vascularized, there's no previous wild field radiation, and then you could consider speech valve. Even with the flaps, I do put the primary speech valve as long as you think the vascularity is good. The second thing is, argument against it because of the reconstructive procedures, and the position of the valve will change in 3-4 months' time. That might make the valve change a bit challenging in future. That's one is the one argument. That's why they say, why don't you do it 3 months later, where all the healing process completed. Exactly, you can design your stoma and also a TEP puncture that will be useful for life. There are arguments for and against. Ian Nixon is there actually, or Sam is there.
Can I quickly say something from someone who looks after people's voice and etc. It's a part of my job. I sometimes have to look after patients as well who do not have a larynx, and it is vitally important that they speak as they wake up or in the early postoperative days for their psychological health. So when possible, where possible, it is most highly recommended that the valve is there, primarily there. Jay and I trained in the same place, so we were always putting valve on the same day, same time of surgery. But there are situations, I understand, when you can't put a valve in. But not putting a valve in always causes a lot of complications afterwards. And also depends on who is putting the valve in afterwards through a secondary puncture. Thank you. Just wanted to add this bit. Thank you.
Panas, there's one more question. Can you share your personal experience regarding partial laryngectomy, especially outcome-wise?
Well, sorry, I missed that. Personal experience regarding?
Partial laryngectomy.
Partial laryngectomy, yeah. So I've only been involved in 2 cases. I think in Scotland we don't do it that much. we tend to get in even in America. I only saw one case that was involved, and it's interesting. It was a salvage case, and the patient failed and had a laryngectomy within a month, actually. So the problem with the partial laryngectomy in the salvage setting is that it's very difficult to get good margins. Even if you get good margins, then the function of the larynx is really poor, because this is a larynx that's been irradiated before. So from what I've seen and from what I've heard, most people end up having either a dysfunctional larynx or a larynx left with cancer, and they end up having a total laryngectomy in the future. It's quite popular. It used to be very popular in this country in the past, prior to the advent of organ preservation techniques, but in the primary setting. But I don't have much experience in that, so I cannot really speak. I'm sure Sam or you, Jai, or maybe Ian has done a few of these, but I haven't done that many.
I mean, as Panna says, the gold standard is total laryngectomy for salvage treatment. However, if you think if the tumor is like T1 or T2, involving the vocal cords more on the one side, not involving the cricoauricular joint, transfer laser type 5 laryngectomy is actually still considered as a partial laryngectomy. This is endoluminal partial laryngectomy. That's actually been proven as good as total laryngectomy. It's again a systematic review and meta-analysis by Professor Pellery, which showed partial laryngectomy, particularly with laser, is a good option. But we are talking about two types of partial laryngectomy. One is endoluminal and laser. The other one is open partial laryngectomy, which is very popular in Europe as well. That again, they do provide good results, but to provide a good results, you should be in a center which performs the procedure in a significant amount. So they have a good skill, which is actually unique. The second one is rehabilitation and the patient mindset, and also geographical area in terms of further follow-up and treatment. So it is not a bad option. I would particularly advise that, particularly for certain countries. But for UK, I would advise transforaminal laser partial laryngectomy. We had 3 patients which were kind of, or we gave option of total laryngectomy as well as transforaminal laser by quadrectomy, which you will see one of this in my talk at the end of it. Yeah, I hope that answers. I think Mr. Nixon is not here. Anyway, that's good. We're doing very well. I think Sam has got something to say.
I agree. I think Panos, JD, you guys are all saying the absolutely right things. Partial laryngectomy hasn't quite taken up. That's the surgical, open, etc. But endolaryngeal laser partial laryngectomy, it can work. Now, I want to just quickly say to these all of you young people out there, when you are setting up a big center, head and neck center, set this center with 3 teams: resection team, reconstruction team, and rehabilitation team. These 3 R's. All these 3 R's need surgeons. So you need a fantastic, very active laryngology rehabilitation setup to be able to do partial laryngectomy and that kind of procedures. Thank you.
Brilliant. That's fantastic. I think we are doing very well. So we'll have a 20 minutes coffee break. We'll be back at 20 past 11. We have 2 more speakers. Thank you.
Everybody, thank you for joining. Thank you, Jay. Over next half an hour or less, we'll be done. Hi, Jay. I'm back. Is that thing working?
Working very good.
Awesome, man. We're going to be awesome.
Yeah.
Thank you. Thank you.
Nice.
Fine. So I was waiting outside for a drone to drop me a coffee, but nothing came.
Always do that. You always do that. One fine day it might come true.
Nah, I think next time you hold the session, we expect some coffee, man, through the drone, please.
I'll try my best next time.
Thank you. Thank you. Excellent. So I'll be keeping here. I think if you put the screen on display, people can see the speaker as well. So I think that should be okay. Yeah. About dealing with a neck lump, focusing on neck nodes and neck levels. Joining, thank you.
Can you hear well?
Yeah, looks good, and I could hear myself, which sounds weird, hearing yourself.
It's clear.
But,
good, clear.
Looks good, actually. It projects well, and I made it. I made it in PowerPoint, and I copied it onto a Word document to run it more smoothly, so it doesn't cause any glitches.
Right. Okay. That's interesting. Yeah.
Okay.
And can you see the Q&A?
Hey, where is it? Yeah, there is. Let me see what happened here. So when I click Q&A, it doesn't open. Maybe it's because it's your screen I'm seeing.
Yeah, you're seeing my screen.
So when I click on my Q&A, nothing pops up. Let me see chat. I can see chat. Yeah, I can see chat. I can scroll it up and down, but not the Q&A. So let me minimize the window. Oh yeah, I can see the Q&A section as well. If I just kind of make your screen a little bit smaller, I can see the other one.
There's no question at the moment. It will, we'll wait for another.
Yeah, I think we'll just give another 4 minutes. And I looked up YouTube. It's presenting really well, and there are a few comments there. So it's surprising how you manage all these things. Do you actually work at all?
You're on live, yeah.
Oh, sorry. I mean, it's amazing. It's appreciable. Guys, don't listen to this yapping.
Making it simple and accessible.
Oh yeah, definitely. I mean, it's such a valuable resources for exam preparation. And I think the thing that go on YouTube is always accessible. So if I can't join live for your session, I just go back and watch things there.
A lot of people are very keen for recording nowadays. They work in multiple
time zones.
So that's important thing, isn't it? So.
Yeah. No, I think I myself have watched your previous head and neck study sessions that you very kindly uploaded on YouTube. Same with ERS, European Rhinology. Their webinars are available as well.
Yeah.
So I think out of this pandemic, this is the great thing that we learned, that you can do so much remotely.
Absolutely, including the MDTs, meetings.
Yeah.
It works well.
Missing link is the drone delivered coffee break. Yeah.
Right. Welcome back. After the coffee, we have Mr. Mohammed Shakil. He's one of my good friend, another fantastic head and neck as well as thyroid surgeon from Grampian, and he has got a lot of experience in head and neck, and he's going to talk about very practical applications of head and neck in terms of lumps and the nodal distribution. I have seen his talks before. This is actually one of the amazing, useful talk. He has actually kindly recorded that. He's also available, but I'm going to play the recording. Okay.
Jai, over next half an hour or less, we will be talking about dealing with a neck lump, focusing on neck nodes and neck levels. This is Mohammed here. Very happy to be contacted if required. Some of the content in my presentation comes from online resources which are freely available, and I hope there is no copyright issue. So at the end of the session, we should all have a clear understanding of neck lumps, how to deal with a patient presenting with one, and we should feel comfortable describing cervical lymphadenopathy in relationship to neck levels. Some of this stuff may appear very basic. I apologize for that, but we have got junior colleagues attending the session, so it is to help them prepare for the exams. So you would all agree with me that this is a very important topic to deal with, because majority of the conditions, surgical conditions appearing in the neck, present as a lump. These are common in all age groups, and reassuringly, most are benign. Some of them may be malignant, and neck is a very complex region. We should have a structured approach when dealing with a neck lump, and that will come from having a sound understanding of normal anatomy, how the lymphatic system works in head and neck, common pathologies arising in the neck, how to assess a patient with a neck lump, and going through the differential diagnosis. In terms of normal anatomy, we have got structures in the neck which are readily palpable, but for some patients, because they became aware of that, it may become abnormal, when in reality, this is a normal structure like thyroid notch. There are certain structures in the neck which become palpable when they are abnormal, like thyroid gland, which shouldn't be palpable in normal situation, but it can become palpable when enlarged. We have got a number of lymph nodes in the neck. We'll learn about some of the terminology later on about neck triangles. If you look at the list of the normal structures, you would agree with me that we have got in the front part of the neck, hyoid bone, thyrohyoid membrane, thyroid cartilage, cricothyroid membrane, cricoid, trachea, thyroid gland, esophagus behind this structure. We have got nerves, vessels, arteries in the neck. We have got sliding lines, parotid, submandibular, sublingual in this region. So this is important to understand these normal structures, and only then we will be able to identify if there is any disease process in them. Commonly describe these structures in relationship to the triangles of the neck. I'm sure we're all familiar with that. Anterior triangle bounded by mandible, midline, sternomastoid border. And within that, of course, we got some smaller triangles like carotid, submandibular, submental, and muscular triangle. Posterior triangle is bounded by trapezius muscle, sternomastoid muscle, and clavicle. There is another way of describing the neck nodes, and once again, I'm sure we're all familiar with those. Submental, submandibular, preauricular, postauricular, occipital. And then we got anterior cervical, posterior cervical, and supraclavicular lymph nodes. We will have a chance to go through these again later on to the talk. Very important to understand what's the drainage pathways for some of the head and neck regions, and then these neck nodes become very important. And we will be dedicating a lot of time in the latter half of the presentation about lymphatics, lymph nodes, and how these are important when dealing with patient presenting with possible malignancy. And this will be the most important topic in my presentation, talking about neck levels, primarily for our junior colleagues. As we heard, there are a lot of important structures in the neck, so
we need to be aware of various pathologies which could arise from these number of structures. Like any other part of the body, in the neck, lumps can be divided into various subheadings as listed here. So we will briefly go through the lists of these conditions, and then we'll try to look at some of the photos and possible videos as well. Congenital neck lumps, more or less, we're very much familiar with these. Common ones being branchial cyst, thyroglossal duct cyst, sometimes laryngocele, plunging ranula. In certain parts of the world, this is a relatively common condition. Then, of course, teratoma, dermal cyst, lymphangioma, hemangioma, thymus-related cyst, and sternomastoid tumor of infancy. So at this stage, I would like to show possible video for you, if it works. So you could see this is a young boy. Look at the image here.
And stick your tongue out, please.
Something like here.
That's good, thank you. Relax.
Then
And
focus
swallow
here.
last time, please.
And something like here.
Fine, thank you.
So there was a thyroglossal duct cyst, and if we look at possible thyroid gland swelling,
And see if you can swallow, please.
so that means thyroid swelling.
Swallow again.
So the left lobe of
And
thyroid.
the last time.
Okay. And while we are here, we can also look at huge swelling. I'm going to perform Pemberton sign testing on him in simple sense, raising your arms, basically looking for any superior mediastinal compression of the vasculature. So quite wide swelling, doesn't move much, but
Swallow again, please.
and pay attention to the
Now,
veins.
would you mind raising your arms for me?
Look at the veins. And his face went red when he raised his arms. So we'll continue with basically differentials of the possible neck lumps. So after the congenital one, we got a big heading about infective, which could be related to bacterial, viral, fungal infections. Lately, we have seen cases of tuberculosis, and we often get referred patients from a respiratory department about lymph node biopsy for suspected sarcoidosis. HIV-related infective neck lumps are commonly dealt in certain parts of the world as well. So third big heading is inflammatory neck lumps. Some people may have more experience than me dealing with these conditions, but I have dealt with Kymura's disease and Castleman syndrome. Again, these are neck lumps related to lymph nodes, and they are inflammatory in nature. Neoplastic is a big category, and we worry about metastatic squamous cell carcinoma in head and neck region. It primarily could be related to lymph nodes, lymphoma, and non-cancerous lumps like lipoma, thyroid cyst, benign parotid masses, and of course paraganglioma can be seen in neck lumps. And vascular neck lumps are not many, but carotid body tumor and aneurysm involving the carotid artery and subclavian aneurysm are the ones to remember. So, based on such a long list of differentials, how do you try to narrow it down? I think this is a very important slide to look at, if you could. So if we get a neck lump and it's in the anterior triangle and it is solid, it could be a lymph node, carotid body tumor, or thyroid-related swelling. Three things mainly. If it's cystic, again, it could be branchial, dermal cyst, plunging ranula, or tuberculosis abscess. And thyroglossal duct cyst is a relatively common finding. And it does move up with swallowing and tongue protrusion primarily. Posterior triangle, if we get a solid lump, most likely it's a lymph node, possible cervical rib. If it's a cystic swelling, maybe a cystic hygroma. I haven't seen any pharyngeal pouch presenting as a cystic swelling in the posterior triangle of the neck, but book says it can happen in normal brows. Pulsatile, we need to worry about subclavian aneurysm. So these slides will be available to you, so don't worry about memorizing it. You can go through these later on. So once we get this background knowledge, how do we apply that into clinical practice? So this follows the same basic principle of dealing with a patient, taking a good detailed history, and here we'll be focusing about a history of the neck lump. How did it start, duration, any changes since first noticed, any related symptoms like pain or discharge from the neck lump. Then this is a box focusing on important relevant symptoms to ask for. And if we look at each symptom, it has got some potential relationship to the eventual diagnosis, like recent sore throat tonsillitis could be related to the active cervical lymphadenopathy. Red flag symptom like dysphagia, autoanophagia, referrotalgia, hematemesis, hemoptysis. So these are like worrying symptoms, and looking for primarily for a lymphoma, let's say, night sweats, weight loss, malaise. These are important red flag symptoms. If relatively elderly gentleman presenting, let's say, with a carotid clump, you worry about any previous skin cancer excised. So very important to ask this history. Then social history about smoking, drinking, chewing betel nut, recent travel abroad, and exposure to animal ticks, bites, etc. So this is another important slide to remember. Now, like with any other patient, we will perform a detailed examination. In ENT, we'll include laryngoscopy as part of our examination, and I think this should be done in majority of the neck lumps. We'll be focusing on the lump per se, looking at the number, the site, the size, the shape of the lump, the relationship of the overlying skin, any relationship with the deeper lying structures, and of course in certain structures you would be able to hear bruit. Completing examination with cranial nerve and scalp and skin of the head and neck. Of course, you would do the systemic examination. So as I said, in ENT, laryngoscopy is part of our examination. So just for refreshing our knowledge about laryngoscopy, I'll just run this video. I won't spend too much time on it, but it just gives you the idea that it is so important to look for any hidden problems in the upper aerodigestive tract. And here we're just trying to see what's going on in a patient who presented with a right neck level 3 swelling. So straight away you see a big tumor here. It's a hyperpharyngeal cancer, distorting the laryngeal anatomy. You can't see the airways, you can't see the true chords. And this is the importance of carrying out laryngoscopy in patient presenting with neck lump, in whom you worry most about cancer. So I'm sure we all do this procedure in our clinics all the time. So let's go back to our aim of dealing with the neck lump. So how do you, after going through the history examination, how do you investigate? Well, we of course do certain investigations, and certain blood tests are helpful. Then we decide if the lump is big. We could, at least in our practice, we do freehand FNSC. We are very fortunate to have such a helpful pathology department, and FNSC is essential in making the initial kind of point in terms of further investigation. If you've got a facility of ultrasound guided FNSC in neck lump clinic, this is brilliant. Chest X-ray should have been done by the time the patient is referred to you. And then we decide about MRI, CT, and barium swallow. So as I keep saying, FNSC is the most important thing, and get some idea whether the lump is a lymphoma or carcinoma. So this is what we do in our neck lump clinic. So this is my colleague demonstrating how we do FNSC. Patient tolerated it really well. It's under no anesthetic, and this is a common practice in over neck. Well, it's not a full neck clinic as we don't have radiology, but sort of a neck lump clinic. So once we done this FNA, then the pathologist, they got this facility. Just for information, this is what happens with FNAC. You get the material sucked out into this range and it goes on a slide. They spread it like this, and then this is the finished product, and it will be analyzed under the microscope. So you get some information whether this is lymphoma, carcinoma, benign, parotid lump, etc., etc. So far, this is our generic overview of the neck lump. Now, as I said, we'll be focusing on neck nodes and neck levels. So why? Because majority of the neck lumps are actually enlarged lymph nodes, and reassuringly, these are benign. In terms of how you describe them to your colleagues in a scientific kind of communication level, it is important to have some terminology, some nomenclature, and we use neck levels for requesting FNAC and radiology. So let's moving on to lymphatics and lymph nodes. So I'm sure we are all familiar, but for exam purposes, remember this Waldear's ring, very impressive. Again, sorry, it's taken from online resources, so I don't claim any ownership for this picture, but thanks to whoever published it freely online. So looking at the inner ring, we've got lingual tonsil, parietal tonsil, tubular tonsil, adenoid tissue called pharyngeal tonsil. Then we got outer rings of lymph nodes. We have already discussed some of these. Another way of describing the same, maybe a little bit more easy to understand, the concept of inner ring of Waldear's lymphatic tissue, and you will see they are related, are connected to the lymph nodes on the outside of the neck. So again, some mandibular, some mental, and jugular chain. And then it's important to know retropharyngeal nodes, very important in nasopharyngeal carcinoma and sometimes in thyroid cancer as well. So this is the important slide showing the concept about lymphatic drainage, lymphoid tissue, their connections, and of course that leads to cervical lymphadenopathy. We describe them in terms of neck levels, and I would say this is very important to have a terminology, and when you're requesting investigation, it's important to say I want FNAC of this neck level, right neck level 2 lump, so everybody will understand which area we're talking about. So let's continue. There are 5 levels we commonly deal with, and I will show these levels boundaries by looking at the next slide. And level 6 and 7 are in the anterior midline. So what is level 1? Level 1 is basically segmental and submandibular region. Level 2 corresponds briefly to the sternomastoid muscle. The upper 1/3 is level 2, middle 1/3 is level 3, lower 1/3 is level 4. Posterior triangle of the neck is level 5. In the midline, you got level 6. That includes paratracheal lymph nodes. And if it goes beyond suprasternal notch area, lower down in the pyramidostinum, that's level 7. So what's the importance? Well, if we have a enlarged lymph node in a particular level, we will be able to look for the primary cancer in the relevant drainage area. Like preauricular, you would look for scalp, anterior half, and upper part of the face, skin malignancy related problems. Postauricular and occipital lymph nodes, you will be looking for back of the scalp, postauricular region for any cutaneous malignancy sending metastatic deposit into the postauricular lymph nodes. Retropharynx, important in nasopharyngeal carcinoma and some other areas here. Then, of course, level 2, you would worry about tonsil-related malignancy. If it's oral cavity, it's level 1 mostly. Level 3, 4 related to hypopharynx. And level 5, important to look for skin and scalp and postnasal space areas. Level 6, commonly involved in thyroid cancer. So again, another way of describing by this beautiful picture. And thank you to online resources. So here we see these are the drainage pathways. So once again, as I said, you will be able to see these slides later on. So not to worry. Just to understand the concept that lymph nodes in neck levels, we need to look at primary site of possible malignancy. So for exam purposes, it's a very favorite question, how you kind of describe the size and site and stage them. So again, this is older classification, and I will briefly mention direct colleagues to refer to TNM 8 for updated classification in certain areas, because exam question arises what are the differences between TNM 7 and 8. So just a generic concept, if there is a neck node on the same side where you suspect the primary, it is 3 centimeter less, it's N1. N2 is divided into A, B, C. It depends if there's a single ipsilateral node less than 6 centimeter is 2A. If you got multiple nodes, none is more than 6 centimeters, N2B. And if it's bilateral or contralateral node, none more than 6 centimeter is N2C. And N3 is, of course, a lymph node more than 6 centimeters. Just remember that, and then you can always modify it depending on the area of primary cancer. And of course, we need to look at TNM 8. Label modification, if there's an esophageal carcinoma, it goes into N1 to 3, but again, just for exam purposes, please read through the classification, and this has changed in TNM 8, and I will show you that in a minute. So N1 is basically less than 6 centimeter. And of course, there's a very important aspect here in the older classification about supraclavicular fossa involvement or not. So we'll look at the TNM8 in a minute. And this is another descriptive way of describing the TNM. So N1 less than 6 centimeter, one-sided but above supraclavicular region. And if you got bilateral but above the important landmark here, less than 6 centimeter nodes, and 3A, big node, 6 centimeter, but not involving the supraclavicular fossa, and N3B, if the lymph nodes related to nasopharyngeal carcinoma are involving the supraclavicular fossa. So just is something that we need to remember. I don't expect people to memorize it, but I mean, important to remember for exam, but in every MDT you would have help available to look at the criteria for stating your patient's cancer. Thyroid cancer has got a little bit different way of describing the metastatic lymph node. If there is one in the midline, it is N1A, midline means level 6. If it goes beyond that and there are lateral neck nodes involvement, it becomes N1B. Another way of describing thyroid cancer, no lymph nodes involvement, N0. You got paratracheal Delphian node involved in thyroid cancer, N1A. If it goes into deeper or lateral neck, it becomes N1B. So again, from exam point of view, very important to remember. I just do neck dissection for melanoma patients. I don't particularly deal with it, but we need to have some understanding about their N classification, and I will let you read through the slide later on about it. So as I said, things have changed over the last few years. So thanks to this International Union Against Cancer freely available resources, they have looked at TNM 7 and 8. And I will let colleagues to go through these slides later on and understand the differences between older and newer classification. And the important aspect is there is a impact of P16 positivity in oropharyngeal cancer and how that impacts the overall staging. As you know, these cancers have excellent prognosis. So that has changed the oropharyngeal P16 positive tumors nodal staging a bit. The other classification that has changed are nasopharyngeal and thyroid cancer and unknown primary cancer of the neck. So very briefly, you can have a look, but I don't expect you to read through the slides. You will be able to read through later. So here in N classification, there has been a stress about extra nodal extension, clinically or pathologically. In that sense, there is a stress about involvement of the skin or deeper structures in a pathological enlarged node. So just go through these ones for your viva. As I said, now things have changed from 3 to gone like a 6 centimeter or less, but in oropharyngeal P16 positive tumors. And again, this is important to remember. And in our MDT, we're using TNM8, but help is available to go back to this criteria and assign a number to our patients' MDT Profarma. In nasopharynx, things have changed slightly because previously there was a lot of stress about supraclavicular force, and now we're talking about caudal border of cricoid cartilage. So it's important to again memorize this difference and be able to talk about older and newer classification of nodal metastasis in nasopharyngeal carcinoma. And on non-primary, again, this is a key. Depending on if it's HPV positive or P16 positive, you would stage them according to their relative nasopharyngeal carcinoma and oropharyngeal carcinomas classification. So important, but as I said, MDTs will have access to these documents, but important to memorize and remember these things. Thyroid, again, big difference between 3 now, A and B. And prognosis-wise, used to be 45 year of age cutoff, but now it's increased to 55. So important to focus on T3 for differentiated thyroid cancer staging. So that brings us to the last section of my presentation, and I would say is primarily aimed at colleagues who are preparing for exam, but I would say it's important for all of us because it makes life easy in communicating among a team dealing with neck lump. So let's look at this picture. So this is neck level 1 swelling, primarily on the left side, submental and submandibular region here. This is another left neck level 1 swelling, submental and submandibular region, right? Agree? Looking at the same swelling from a different angle, this is submandibular region swelling. So level 1, so we suspect cancer in this kind of scenario where we would look for primary cancer. We will go into the mouth and look at this one, and this is the tongue cancer here. And then look at this one, level 1 lymph node, and we got tongue cancer here. Another patient presenting with floor of mouth cancer. So very important to look at the level where the lymph nodes are enlarged and look at the possible primary cancer area. Another one, cancer. It's not infection, it's not something granuloma, it is cancer. So moving on to level 2 swelling. Patient presenting with left neck level 2 corresponds to the upper 1/3 of sternomastoid muscle, right? Another view of the left neck level 2 lymph node is elderly gentleman. It's not a branchial cyst. Yes, possible, but you would worry about metastatic cancer. And level 2, you would look at possible primary site into the mouth and oropharynx. So this is another example. The patient is about to undergo canendoscopy, tonsillectomy, level 2 swelling here. Corresponds to the upper 1/3 of the sternomastoid muscle. So when you look into the mouth, big tonsil on the left side, left tonsillar malignancy. Right is normal. It was hard on palpation. You would excise it for primarily biopsy, and most likely this patient will need chemoradiotherapy. But important to understand level 2, look into oropharynx tonsillar malignancy. This is the right-sided level 2, corresponds to the upper 1/3 of the sternomastoid muscle. You would look into the oropharynx. Big cancer eroding through the soft palate, quite big. This is not quinsy, not tonsillitis. Yes, ulcerated, but cancer, so please pay attention. Okay, another tonsillar swelling, big thing. Right-sided tonsil is big. Turned out to be lymphoma for this patient. But again, he had level 2 swelling. Okay, so moving on to level 3 here, which is a big bulge. It was actually occupying level 2 and level 3 together. This patient is about to undergo panendoscopy and left tonsillectomy. So where would you look for primary? Tonsil, big tonsil. Hard, and level 2 and 3 look into oropharynx for tonsillar malignancy. Okay, so this patient has got level 3, middle 1/3 of the sternomastoid muscle. This is the swelling. It was moving up with swallowing, stuck to the thyroid. Turned out to be thyroid lymphoma, actually. Level 3, right side, or look at the middle 1/3 of sternomastoid. This patient had hypopharyngeal carcinoma. Remember, it will be the same as we see in the flexible laryngoscopy earlier on, primary tumor. So another one involves level 2 and level 3. The lowest 1/3 of sternomastoid is free. So this is the cancer. Level 2, level 3 swelling, and you will look for into the pharyngeal, like a hypopharynx, oropharynx area. So this is right-sided neck, level 4. Big bulge, sternomastoid, lower 1/3, and this is the swelling. Another way of looking at it, you look at the hypopharynx, but you will also look for thyroid-related malignancy. Okay, so now we're moving on to level 5. As I said, level 5, lump in the posterior triangle, sternomastoid, occipital bone, trapezius, clavicle. It doesn't project well, but I have taken a photo to show you. This is the big lump in the posterior triangle of the neck. And this patient had melanoma excised previously from the right side, similar. So look for the skin problem that drains into the posterior triangle of the neck. So big one, right posterior triangle, whole neck is replaced by this big lump. Yeah, and this patient needs investigation and laryngoscopy, FNAC, CT scan, neck and chest. Okay, so level 6, as we said, this is the anterior midline of the neck. This is the lump. It could be anything, but in this patient, I think it was low-lying thyroglossal duct cyst. Could be lymph node if it's related to thyroid cancer. Need to be aware of that. So just trying to raise the kind of more awareness about neck level. Thyroid isthmus nodule, level 6 here. Okay, so moving on to some other neck levels. And if we look at this one, level 2, possible 3, and level 5. And a few years after previous laryngectomy, this patient presented with this lump, had investigations, including history examination, laryngoscopy, FNAC, core biopsy, sarcoma. You just need to be aware of that as well. So the mass is covering the level 3, 4, and 5, and cancer eroding through hypopharyngeal cancer on the right side. So very important to be aware of this possibility. It is not a simple thing, it is cancer. The patient needs to be referred to urgent cancer clinic, head and neck cancer clinic. Okay, big swelling occupying the parotid tail, level 2, maybe 1, 3, and yeah, just sitting in the border. So a lot of areas it's kind of sitting in. So need to be aware of possible problems in the primary area. Another patient, bilateral lymph nodes here, there. So a lot of triangles and levels involved. Nasopharyngeal carcinoma presenting with a bilateral cervical lymphadenopathy. Must have post-nasal space examination. Of course, FNAC as well. Okay, so coming to the end of the presentation, quite big neck swelling involving more or less all level, rock solid when I felt it. That's a high-grade Hodgkin's lymphoma. So this brings us to the last slide to acknowledge some of the resources I have used. And instead, I'm grateful to these resources. I just shared this pictures that have been taken from my own patients, and they're consented, so okay for educational use. So thank you. I'm happy to participate in any question you might have for listening.
Absolutely fantastic, Shakil. That's so many photographs, high quality, very informative, and it's a pictorial representation. You're spot on. Thank you very much for the wonderful talk. We'll look for
Thank
any.
you, Jay. That's very good. I thought it's very important, although it's very basic. But this is the thing. When I was a registrar, I struggled to kind of prepare myself properly for exam. So purely talking about this thing for my registrar colleagues, basically.
That's absolutely good. We'll check any Q&A there. That's good. No questions, but I'll ask some questions. I find it sometimes the level 2 is actually confusing with a parotid lump. What's your experience?
You are absolutely right, Jay. Parotid tail, especially if it's a low lying, and I think Panos will agree that he has lately suggested that if you got a low lying parotid tail or level 2, you basically take some of the lymph nodes with that lump out as well, right, Panos?
Yeah, so I mean, the ultrasound guided FNA should give you an idea whether it's parotid tissue or a lymphoid tissue from a gland. But if you have a parotid gland that is very low and you think it's cancer, then at the time of surgery, you should sample level 2 because it's right there during the parotidectomy incision. The advantage of that is that if you go to your MDT and there's a low-grade cancer in the parotid, you can see that your lymph node sampling was benign and the patient doesn't need any further treatment and you're done. But yeah, it can be very difficult to determine, and that's why ultrasounds are extremely important. One-stop ultrasound clinic is the way future for all units.
Good.
Thank you.
There's a question, at which point do we do co-biopsy in the neck lumps as part of the investigation?
I think overpractice has been to do ultrasound. I mean, normally what we do in Aberdeen, we do a freehand FNAC at the time you're seeing a patient. If that gives you clear answer, lymphoma or carcinoma, you stage them accordingly. If that comes non-diagnostic, you would have requested ultrasound-guided FNAC. In our radiology department, they could also do core biopsy, but only if the 2 FNAs have been non-diagnostic or not helpful. And to be honest, we at that stage will be doing the core biopsy ourselves in our rapid access clinic in the ward.
That's absolutely a brilliant answer, but I would add a few more things. For example, some centers diagnose lymphoma with a core biopsy. So if your center is happy, if you suspect clinically that's more lymphoma, you would consider a core biopsy straight away, but there is no harm in doing freehand FNA to start as a starting point. That's a gold standard because any head and neck tumors, 80% of the diagnosis can be achieved by good FNAC. Sometimes thyroid tumors, some centers prefer core biopsy. Probably Omar will point out at some point as well in his talk. Okay, we'll move on to the other question. There's a lot of questions.
Let me open the question session. Yeah, myself here.
Unilateral tonsil malignancy, do you remove both tonsils?
So up until now, and with the recent PET study, I think our practice had been to do ipsilateral tonsillectomy, but growing consensus is to do a bilateral tonsillectomy because it makes not only the diagnosis 100% there, you're not missing a smaller second cancer in the contralateral tonsil, but also make prognosis, follow-up a bit easier. So currently we are swaying towards bilateral tonsillectomy.
That's right. I would slightly disagree with that. If there is a clear tumor there, histologically and radiologically proven, just a tonsil biopsy is actually more than enough, or maybe unilateral tonsillectomy. For unknown primaries, for example, MRI is negative or CT is negative, even PET is negative, then the guidelines recommends bilateral tonsillectomy and tongue-based mucosectomy for unknown primaries. But the pragmatic approach varies from centers to center. I respect that. The next question, how will you manage secondary node with the overlying skin eroded?
Yes, so I think it's a very important question. Mr. Majumdar was saying that you should be working as a team. So at this stage, I think depending on the primary type of the cancer, I think if surgery is the chosen kind of modality, then you will be working in collaboration with your plastic surgery colleague, because I and Panos work with them. So we will excise the skin. We will try to do a primary local advancement flap reconstruction. But if it's a secondary salvage surgery, then of course they need a more kind of healthy particled flap reconstruction. So to answer your question, I think you have to deal with the skin surgically, and better to do it in conjunction with plastic surgeons.
Agree. And what is your opinion about a recurrent intraparotid lymph node in 6-year-old child, excluded by histo and immuno, no lymphoma, but still recur and about 2 to 3 centimeter in biggest diameter? What is the needed plan? Complex question.
Oh yeah, I think I would say I'm not the best person to answer, but I fully appreciate this is such a difficult situation, because whatever you say to family, they are not going to settle down. So I would put it to anybody else to handle this question. Is Ian or Panos?
I would excise the. I would excise it, because you need to exclude the mucoepidermoid carcinoma in a child, so it needs to come out. And sometimes the FNA. I mean, was it an FNA or a core done before? What was it done? Quite often, 5-year-old kids won't let you go near an FNA. You need to put them under anesthetic, so might as well excise it. So very careful superficial parotidectomy or a partial parotidectomy even, but I would excise it to exclude mucoepidermoid carcinoma.
I think Mr. Hilmi is here. So in Glasgow, I'm sure when I was there were a lot of lymphadenopathy in children. So Mr. Hilmi, what would you suggest here?
Yeah, I mean, it depends what you think the underlying etiology in this situation is. As you know, I don't do pediatrics, but for the pediatric cases, you've got to be concerned this could be an atypical TB as well as anything malignant. So I think I would want more information. I would certainly consider a general anesthetic core biopsy in this sort of case, and we have done those in kids both for thyroid and for other lesions. I wouldn't jump in straight to surgery.
Yep, I totally agree. Anything more than 2 centimeter, according to Hedam Kuba's article, needs to be kind of some kind of intervention is needed. You can't just discharge the child. That's the bottom point. That's great. Thank you very much. And we have Mr. Omar Hilmi, is one of my friend and friend in need. Sometimes comes and helps me in complex surgeries, including a few days back we were operating together for a 10-year-old child with the thyrotoxicosis and neutropenia, and he's very experienced thyroid and parathyroid surgeon. He holds a high position in BATS, as well as he organized many meetings, and he's also a chair for Royal College of Surgeons of Edinburgh Specialty Board. I'm happy to introduce him, and also he's going to talk about thyroid cancer. It's a big topic, but he will entertain you for next 35 minutes, and he can take some questions at the end as well. Thank you. Omar, yeah. You can unmute and share your screen, please. Perfect. We can see your screen.
Okay, can you hear me?
Yeah, absolutely fine.
Fantastic. Okay, now, I'm just wondering which screen of mine you can see at the moment, because hopefully that's the one. So, yeah, thyroid cancer. Now, I'm going to limit what I talk about today, because as Jay has said, thyroid cancer is a very big topic. I'm not going to go into significant features of the diagnosis. Basically, what I'm going to talk about are the principles of thyroid cancer management. And then I'm going to split it up into 3 sections. We've got early thyroid cancer, we've got management of the neck and thyroid cancer, and then management of advanced thyroid cancer. And after each of these sections, I'm going to ask you guys if you've got any questions, because trust me, you don't want to be waiting till the end of the talk to ask them. Now, this is a bit of a difficult situation because I really like the bit of interaction and the bit of chat that goes through with face-to-face meetings. So doing it completely online, I'm a little bit out of my comfort zone, so please bear with me. So what do we know about thyroid cancer? Well, it can be classified as a rare cancer because it's only responsible for 0.6% of cancer deaths. But in the UK, it overall has an incidence of roughly anything between 1,600 to 2,000 cases per year, with a prevalence of around 3 per 100,000. So this is a cancer that you will certainly see in your clinical practice. And although the cancer deaths are rare, the actual disease itself is not that uncommon. And it's been increasing. Now, this is the incidence of thyroid cancer in Scotland from 1986 to 2008. And you may ask yourselves, well, why are we interested in those dates? Well, some of you may remember that there was a little bit of a fire at a power station in Russia at the time, just before 1986. And we were predicted that thyroid cancer was going to increase because, of course, radiation, iodine 121 being released, people being given iodine tablets as anti-radiation tablets to try and prevent thyroid cancer. We were anticipating a rise in these cancer deaths. And sure enough, we've seen it across the board. But does this represent a true rise in cancer, or is it simply that we're getting better at detecting it? And this is something we don't know. Now, if you take a look across the world, this is the European figures. And as you see, the UK is well down at the bottom of the league on this one, as with so many other things. But we're happy about that. We don't want to have a high rate of thyroid cancer. But the interesting thing is, you see all those Eastern European countries that we're going to have these really high rates. They're not at the top. Southern Europe, what's going on in Malta and Cyprus and France? These are areas that shouldn't have been affected by Chernobyl. So there's obviously something taking place there. Now, when we talk about Chernobyl, we also think this is still affecting us. There are parts of Scotland where you still can't farm the sheep because of the risk of radiation exposure. So this was a very real risk, but we're not necessarily seeing it in terms of thyroid cancer in the UK. Now, you all know this. There are, roughly speaking, 4 types of thyroid cancer and lymphoma, as was mentioned earlier on. Now, the ones that we're most interested in, the papillary and the follicular thyroid cancers, often known as differentiated thyroid cancers, make up 90% of the workload. Medullary thyroid cancer, 5%, and anaplastic or undifferentiated, the rest. Now, medullary thyroid cancer, a lot of said about this. And the reason is that you've got a blood test to detect it, and physicians love a blood test. Plus, there's a genetic predisposition, and physicians love genetics. And there's a cancer syndrome, the MEN2, MEN2A and MEN2B, where you've got an association with genetics. So you can get all sorts of questions in your exams on this, and they're fair game. Now, the thing to bear in mind, medullary thyroid cancer, yes, there's a genetic predisposition to it, but not all patients with a genetic medullary thyroid cancer have MEN2. There is just genetic incidence for it, but it can also be sporadic. Derived from the parafollicular or C cells, these are concentrated in the superior pole of the thyroid. So if you're doing thyroid surgery for a medullary thyroid cancer, you need to be careful about that area, up near Barry's ligament and beyond. They are not TSH dependent and they're not iodine avid. So as we'll discuss later on, you can't use some of the adjuncts that we have for differentiated thyroid cancer. Anaplastic thyroid cancer, this is just a horrible disease. I mean, it's very aggressive. Most patients present with incurable disease, often with airway obstruction or swallowing problems at the time of diagnosis, and most are dead within 6 months. At one time, they used to say the only operation you should do for anaplastic thyroid cancer is a biopsy or a tracheostomy. Certainly, I agree that a biopsy may be indicated. I'm not convinced about a tracheostomy because actually, are we changing things for the patient, or are we just making their life hell in the last few weeks by keeping them trapped in hospital with a tracheostomy that can't be managed? So that was the feeling. Things may be changing now, though, and we'll discuss that later on. The ones I'm really interested in to discuss today are the differentiated thyroid cancers, the papillary and the follicular. And these have got some specific features that make our life easier. And the first thing is they're TSH dependent. So you can affect potential metastatic growth of these by putting them on suppressive doses of thyroxine because they do retain the host characteristics of normal thyroid cells. Because of that, they also take up iodine, which means you can use radioactive iodine for either scanning to look for early signs of disease or ablation to destroy any potential metastasis at higher doses. And they also produce thyroglobulin in common with the thyroid. Now, if you've taken the thyroid out, you shouldn't be producing much or any thyroglobulin. So therefore, if you see the thyroglobulin level increasing, you can use that to assess whether there's any metastatic disease, and it gives you early warning to maybe do further scanning, uptake scans, see what else is going on. But you can only do that if the thyroid's been removed. Now, there is one caveat to that, and that is that if the patient is producing antibodies to thyroglobulin, you can't use thyroglobulin to assess that, in which case you need to do the antibody titers to see if they're increasing or decreasing, and that will tell you the disease behavior. Okay? How do we stage thyroid cancer? Well, everyone knows TNM. This is it for papillary and follicular. I've taken out the things for the others. You've also got the final staging. And the important thing to take from this slide is that age is important. Because actually, if you're young, you can't have any more than stage 2 disease, even with very advanced disease, because you're going to do well. You've got a survival rate of 85 to 95%, even with distant metastasis, as long as you're less than 55. It's one of those figures that's bandied around, is that young women with a diagnosis of thyroid cancer are supposed to have a life expectancy that's greater than young women without, simply because, well, we don't know. Why should they live longer if they've got a thyroid cancer than not? And there's various theories, all of which, of course, are rubbish because they're just theories. Doctors maybe simply the presence of having come near a doctor has somehow enabled them to live longer. Maybe lifestyle changes by the patients. They don't drink, they don't smoke, they look after themselves a bit better. Maybe doctors pay a bit more attention to them when they come up with non-specific symptoms, simply because they've had a cancer and so will investigate earlier. The simple answer is we don't know. But for whatever reason, these patients are going to do very well. And even in the over 55s, you can see that really with quite advanced disease, T4A, nodal disease in the neck, you've got quite a high survival rate. And this is mimicked in the other staging systems. You've got MACIS and you've got AIMS. You don't need to know the accurate details of this, simply that they exist. And you can go online and there's various calculators which will tell you, given your patient's clinical findings, what their life expectancy is. So it's got a really good prognosis. It's also really good for surgeons because it is a surgical disease, and surgery is the most effective, least morbid and cheapest treatment for most cancers. I'll give you lymphoma, you don't want to do it, but for almost anything else, if you can operate, you've got the potential to cure. And we like that. That's what we do this job for. Now, when we're talking of thyroid cancer surgery, we've got to bear in mind what are our aims of surgery. Now, we want this, the top one, a surgical cure, the removal of all cancer-bearing tissue, not needing any other treatment. The patient can be reassured you are cured of your disease. The problem is we're never quite certain if it's anything more than the earliest of disease processes. And so therefore, most of our cancer operations, I'm talking about all cancers here, not thyroid cancer, is the removal of all macroscopic disease with a view to cure. But you know what? We'll also use something else, something to make sure there's no metastasis, to reduce the chance of local recurrence. And then finally, the one that we don't discuss much really is the surgical palliation. And in this situation, we don't hope to cure the patient. We simply want to ensure that they maintain as good a quality of life for as long as possible while living with their disease. Okay, so when you go into any form of cancer operation, it's especially important in thyroid cancer, think about which of these you're going to do, because you can cause an awful lot of morbidity and not necessarily significantly improve things for the patient if you choose the wrong option. Now, most head and neck cancers that we have, our adjuvant treatments are going to be external beam radiotherapy and or chemotherapy. Now, these carry significant morbidities. You know, the patient's got to come in 6 weeks getting their radiotherapy, their throat is going to get increasingly sore, the pain's going to last for several months afterwards, they may have difficulty in swallowing, they may have breathing difficulties, they'll certainly get the reaction, and even moving forward, there are long-term complications of it. We don't like giving our patients these treatments. We want to try and get that surgical cure so we don't need to use the adjunctive treatments. And so head and neck cancer surgery is very much aimed at that. We accept that a lot of them are going to get this, but we do try our best to get that cure. But thyroid cancer is different. Our adjuvant treatment is radioactive iodine. Now, for radioactive iodine, you come into hospital for a couple of days. You stay in a lead-lined room, and technically anything that comes out of your body becomes radioactive waste as long as it doesn't enter a toilet. So you need to throw everything away. Everything needs to get sent away. As long as it's in the toilet, that's okay. Apparently it's diluted, but you've got to keep away from everybody else. Now, 2 days of isolation, yeah, we're kind of getting used to that at the present time, but people can cope with that. It's not like the 6 weeks of external beam radiotherapy. And because it has very little morbidity, actually, why would we hold back on it? The metastases that we have, as we said, are TSH dependent, so therefore you can suppress them with suppressive doses of thyroxine. And we've got that tumor marker, so that once we've treated the patient, if there is sign of the tumor marker increasing, we can then go in early to intervene before any significant damage has occurred. So we've got an awful lot of things on our side. But all of these things do rely on there being very little functioning thyroid tissue present. So we do still need to do surgery. But the question is, how much surgery do we need in any given situation? And this is where we start talking about how advanced the disease is. Now, the basic operation, the minimum operation you should realistically do for anything related to the thyroid is a hemithyroidectomy. And this is the complete removal of one lobe of the thyroid, including the isthmus. Okay. Complication of that, well, they may require hormone replacement, although most won't, and vocal cord palsy. These patients generally do really well. Yes, you can get bleeding. Yes, you can get excessive scarring, but the real complications that we worry about would be a cord palsy. The other operation, of course, is a total thyroidectomy. Now, in this case, everything's removed. Therefore, you've got to give thyroid hormone replacement. You may get a cord palsy, and that may be bilateral, may need a tracheostomy. Hypoparathyroidism, we often underplay this, but hypocalcemia is a significant complication of thyroid surgery and occurs in quite high figures. If you take a look at the Bates audit, about 20% of patients will get short-term problems with hypocalcemia, and about 5 to 8% will actually need long-term medication for this. And actually, that's far more of a big deal than needing thyroid hormone replacement, because if you're hypocalcemic, if you miss your medication, even for a couple of days, you will start getting problems. Your fingers will start to tingle, your legs, you'll get periorbital issues, and you could get severely unwell fairly rapidly. So do not underestimate hypoparathyroidism. Now, historically in the management of thyroid cancer, every patient got a total thyroidectomy. They all got radioactive iodine ablation. They all got TSH suppression, and they all got their thyroglobulin estimation done annually. And if you say that in an exam result, you probably will pass it. It's not a good answer, but it's an answer that will get you the marks to come through. But even these treatments are not without their issues. Radioactive iodine ablation, although it is safe, very easily given, you do get some dryness of your mouth, and patients don't like the idea of radiation. TSH suppression, yeah, not a problem in the short term, but in the longer term, as patients get older, it can put more pressure on their heart. They can get issues with AF. More importantly, they're going to get issues with osteoporosis and osteopenia. So that can cause issues as they get older with their hips and other joints. And thyroglobulin, well, not much complication related to that, but it's still a cost that patients incur. And in the States, one of the commonest causes of medical-related bankruptcy is from the treatment of thyroid cancer. So costs do have an implication. So do we really need to go that far in every case? Can we rein back from doing absolutely everything? And this, of course, is part of the problem, is that these days, this is an ultrasound. This is a very small thyroid cancer. It's about 2 or 3 millimeters in size, but it is a thyroid cancer. And if you're diagnosing that, if you're then going to go on and do all that to the patient, well, are you doing the patient a service or are you over-treating them? So let's go back to that surgical cure. Can we cure patients with thyroid cancer by surgery alone without using these adjuvant treatments, and how much surgery do we need? Well, by definition, surgery for early thyroid cancer, there can't be any local or distant metastasis. All the cancer has got to be removed, and there can't be any local invasion. You don't want any of the more aggressive histologies. This is for papillary thyroid cancer, but not all papillary thyroid cancers are equal. There are some which have worse prognosis, such as your tall cell, your columnar cell, things like this. And if you've got one of the poorer prognosis ones, we do generally tend to treat them a bit more aggressively. Size does matter. At one time we used to say size up to 1 centimeter. We're now pushing that and saying maybe size up to 2 to 4 centimeters in one lobe of the thyroid. You can technically do a hemithyroidectomy and be reassured that you've probably cured that patient. Tumor markers, we're not sure what goes on with those yet. There was a fad, certainly in the west of Scotland for a while, that if patients were BRAF positive, then we should be more aggressive in our management. But actually, we're now identifying that patients with BRAF positivity, probably the tumor doesn't behave any more aggressively. It's just that the more aggressive tumors present with BRAF earlier. So for early disease, we now generally recommend doing a hemithyroidectomy with the caveat that if any of those features are present when we do the final histological analysis, we may need to go back in and do completion surgery. In the same way as we said that for our follicular lesions, which are Thy3F, which you'll already know about. The problem is that as surgeons, we do know that we understage disease based on our preoperative findings. And so there is a tendency for us to just sort of, well, I'm a little bit worried about this. I think it's probably going to be okay. But we always tend to err on the side of caution. So we've always got to consider and rein ourselves back and think, actually, are we treating the patient or are we treating ourselves? And make sure that we don't try and push to do a total thyroidectomy, where actually a hemithyroidectomy is probably the appropriate management. But this then brings up another question. If this tiny papillary thyroid cancer is only a few millimeters in size, we know from cadaveric studies that anything from 12 to 30% of people who've died from unrelated causes, if you look at their thyroid, will have small thyroid cancers like this. So do they need any treatment at all? And if you're in Kobe, this is Kuma Hospital in Japan, they actually go for an active surveillance on these patients. Now, the cutoff point about when you should consider active surveillance depends. In Kobe, they reckon about up to 1.5 centimeters in size. You can simply keep an eye on these patients with serial ultrasound scans, assuming that it is a solitary nodule, that the gland is otherwise normal, that it's not near any other structures. Assuming that you've got a medical team that's willing to do this and facilities to follow up the patient with ultrasound. And generally speaking, that the patient is motivated to do that. Now, they've said older patients, because older patients are likely to be more stable. If you've got someone who's younger and wanting to go all the way around the world, they may not be able to attend for regular follow-ups and regular scans for this sort of regime. But if you've got someone who's stable, like myself, in their 50s, unlikely to move anywhere in a hurry, there's no reason why you can't simply keep an eye on these patients. And what they found is that a significant number of these patients with biopsy-proven papillary thyroid cancer, the cancers actually get smaller over time. They don't get bigger. And the vast majority of them can continue on this regime. Now, of course, if the tumor starts to increase in size, you're going to need to convert onto surgery. If you notice any metastatic disease during the period of follow-up, you're going to need to go for surgery. And if there's signs of local invasion, so if they developed a cord palsy, that would push you towards surgery. Similarly, if the patient doesn't want it, you're going to go for that. But over 90% of these patients are successfully managed simply by keeping an eye on these and therefore avoiding all the morbidity associated with even a hemithyroidectomy. To facilitate this, we also have a better assessment system. In the UK, we use the U system for assessing our thyroid nodules. This is the ACR TIRADS. And this is a system for ultrasound classification of nodules that they're using in the States, and they use similar things in Europe. Originally developed by the Koreans as the Korean TIRADS, what it does is it actually gives a physical score to any of the features on ultrasound. So, for instance, taller than wide gets a score of 3 as opposed to 0 in the shape of it. Echogenicity, composition, margin, all these things come together to give an overall point score. And depending on those points, they then decide, does this patient need a biopsy? Does this patient need a follow-up? So a TR5 is one where you're pretty sure this is a cancer, but if it's less than 0.5 centimeter in size, you don't even need to follow that patient up. You can leave it alone. Similarly, TR3, analogous to our U3s, you would only sample it if it's more than 2.5 centimeters. Otherwise, you do a simple follow-up. If in any given 12-month period it increases by more than 3 millimeters, well, that's a change, and you would then sample that. Similarly, if there's any other features, you would then sample it. But what this enables us to do is a period of active surveillance before we've even proven that these patients have got a cancer. Now, this isn't used routinely in the UK at present, but I'm sure it will come over here. And it's really helped rationalize things in the States. Anyone got any questions about that?
I think there is one question.
Go on.
What is the difference between the suppressive and replacement dose of thyroxine? How are these?
Okay, a replacement dose of thyroxine, you're aiming to get a TSH level of within the normal range. So that's between sort of, I mean, generally speaking, we aim for between 1 and 2. But anything below 5 is reasonable for that. A suppressive dose of thyroxine, you're aiming for below 1, and in some cases make TSH undetectable.
And for how long do you follow up microcarcinomas?
Okay, under the TIRAD system, you follow them up for 5 years. And if there's no change at that period, they can be discharged. It depends. The system actually is fairly categorical about what you can and can't do. But certainly, if it's less than 0.5 centimeters, then you don't need to follow it up at all. If it's larger than that, you go for 5 years. And if at the end of 5 years there's no change, you can discharge that patient with advice.
What is the frequency of ultrasound examination in those patients under active surveillance? Is anyone in the UK currently doing this?
We're doing this in Glasgow on select patients, yes. And I think there are other centres. I think they're doing it in London as well.
Next question, significance of anti-thyroglobulin levels. Please, if you could repeat.
Sorry, I didn't hear that.
Significance of anti-thyroglobulin levels.
Okay, the significance of, I take it you're meaning thyroglobulin antibodies. The significance of antibodies is you can't use thyroglobulin as your marker because it will all get sopped up, in which case you use the antibody level as your marker. The absolute value is not important, it's the trend that is important. So if the antibody level is going down, that suggests there's no disease present. If the antibody level is increasing, that suggests there's potentially increasing disease presence, and you would want to investigate that.
Brilliant. Next question, beautiful presentation. For post-operative care of differentiated thyroid cancer, do you do both radioactive iodine and the TSH suppression, or what determines your choice?
It depends on the extent of disease. A lot of patients now we do not give radioactive iodine to at all, and we simply go for normal levels of thyroid replacement. I generally aim for a thyroid replacement regime of less than 2. Because if it's more than that, then sometimes patients are mildly hypothyroid. Routinely, we discuss all these cases in MDT, and it is an MDT discussion overall. But unless there's worrying features, most of these patients, we simply keep an eye on them.
Next question, how do you pick up thyroid cancer? All thyroid lumps should be scanned.
Okay. Pick up thyroid cancer, that's a neck lump assessment question. Most thyroid cancers will present with a lump in the neck. you do not need to scan diffuse thyroid swelling unless there's a very short history. Diffuse thyroid swelling suggests either a thyroiditis or a goiter. If you've got a discrete thyroid mass, that is when you would get your ultrasound scan and your biopsy. You can't rely on freehand FNAC for thyroids, simply because size doesn't necessarily matter, and frequently, certainly in a multinodular goiter, you need to sample the most worrying appearing nodule on ultrasound, which may not necessarily be the largest. The other presentation you sometimes get is, certainly with follicular thyroid cancer, they can present with bony metastasis, and so pathological fractures, and they do a scan and notice, oh, there's something going on in the thyroid and it can have spread there. But we'll go into that in a short time. I've not finished my presentation yet.
Brilliant. I think we'll wait for, yeah, carry on, please.
Okay, so that's early stage disease, but do we need to worry about the neck in thyroid cancer? Well, there are two schools of thought in days gone by. You probably don't recognize this individual here because he wasn't real. This was an actor who played the part of Sir Lancelot Spratt, and he was a general surgeon. And the general surgeons used to do the majority of thyroid surgery up until relatively recently. Now we've rationalized it into specialist endocrine surgeons and ENT thyroid specialists. But at that time, anyone would have a go at it. And in days gone by, before you had all the scanning that we've got these days, the ultrasounds, the CTs, and that sort of thing, basically they'd have a feel of the neck. And if there were any obvious lymph nodes, the general surgeon would just take those lumps out. Now, of course, as ENT surgeons, we knew better. You don't treat necks like that. You do a radical neck dissection. You'd clear all the nodes from level 1 to 6. You'd take sternomastoid muscle out. You'd take the internal jugular vein out and the accessory nerve. That was how you cured cancer. But of course, the simple answer is we were both wrong. The general surgeons were basically sampling it, and the ENT surgeons were being way too aggressive. We're far more selective in what we do now. Hence the term of selective neck dissection. Now, we do not go and do radical neck dissections. We don't even do modified radical neck dissections in the majority of cases. These days, we'll do a selective neck dissection. If nodes in a given basin are involved, we will take that nodal basin away. But there's no reason to take away structures that thyroid cancer doesn't metastasize to. It doesn't generally metastasize to the sternomastoid muscle. It doesn't metastasize to nerves. And yes, follicular thyroid cancer can travel into the internal jugular vein, and if there is direct invasion, you can take it, but there's no need to routinely do it. Now, for the purposes of thyroid cancer, you need to load the levels of the neck. I'm not going to go through that because that's already been discussed. I'm Mohammed. We've got the central compartment and the lateral compartment. Bear in mind that there are over 100 lymph nodes in the neck, more than 50 each side. So taking a few out is neither treating a cancer or satisfactorily sampling it. Okay, so if you're going to do anything, do it as a level, but do it comprehensive for that level. Now, when we assess the necks, we do our ultrasound, and we may or may not get a biopsy. Should you do a CT scan? Well, yes, if you've got an extensive disease in the thyroid and you're concerned about metastatic disease in the neck, or in level 6 extending down into the mediastinum, of course get a CT scan. Now, some people say you shouldn't give contrast. It doesn't matter as long as it's before the surgery. The rationale behind not giving a contrast for a CT for a patient with thyroid cancer is that you could potentially stun any metastatic thyroid cells, and so they wouldn't take up radioactive iodine post-operatively. But if this is pre-operatively, they've already got very high circulatings of thyroid hormone replacement that are going to have to come down anyway. By the time they get radioactive iodine, they're going to have had a period of washout. So the contrast iodine that you've given is not going to make any difference, but you will get much better images than with a non-contrast scan. So these days, you do not need to worry about giving contrast for thyroid cancer preoperatively. We will do a selective neck dissection directed by the disease rather than just let's take everything out. Okay, now the central compartment is from the hyoid bone all the way down to the innominate vein, including the thyroid. The lateral compartment, you don't generally go above the accessory nerve unless there is presence of disease up at level 2B. So below the nerve, these are the areas that you are. So lateral compartment, central compartment. And roughly speaking, this covers most thyroid neck surgery. problems arise when there aren't any nodes present in the neck, because we need to bear in mind that different versions of differentiated thyroid cancer behave differently. Now, follicular thyroid cancer, this is the one we diagnose on the basis of our Thy3Fs from our biopsies, is normally diagnosed after a hemithyroidectomy. You'd think I'd be able to spell thyroid correctly, wouldn't you? But clearly I can't. It metastasizes late and it spreads via the bloodstream. It doesn't go via the lymphatics. So these are the ones that can present with your pathological fractures, but there may be nothing in the neck. So there's absolutely no rationale for doing a neck dissection for a patient with follicular thyroid cancer unless they've got obvious disease there. Okay, so no role for a prophylactic neck dissection in follicular thyroid cancer. Papillary thyroid cancer is different. Now, this is the commonest cancer. You get 80% of all thyroid cancers are papillary. It's got an excellent prognosis. These patients are going to do really well. But we do know that they can metastasize early to regional lymph nodes. Now, if you have a patient with a papillary thyroid cancer and you go and actively sample the nodes in the neck, up to about 20% of them are going to have micrometastasis present at the time of the original diagnosis. But that doesn't mean that they're clinically significant and doesn't mean that that necessarily needs treated. They do have a predictable pattern of metastasis, and certainly they start off in the thyroid, they go to the ipsilateral central compartment, they then go to the ipsilateral lateral compartment before going to the contralateral lateral compartment, and then distant and down into the mediastinum. And we do know that if the central compartment is completely clear of metastasis, that the risk of there being any lateral compartment disease is very, very low. And so because of this, in certain areas, people suggest that whenever you have a thyroid cancer that's more than, say, 2 centimeters in size, you should do a central compartment clearance. This is very much dependent on what part of the world you live in. It was very popular in the UK for a while. It still is very popular in China. And in fact, in China, I think even patients who get a hemithyroidectomy get a central compartment in some cases. But what this means is basically you've left with a patient who you've got the strap muscles, you've got the carotid sheath, you've got the vagus nerve, the recurrent laryngeal nerve, hopefully a parathyroid left behind there, but essentially nothing else. Even the thymus is frequently removed in this. What's the advantage to this approach? Well, those people that say this is a good idea say it reduces local recurrence, and there is good evidence that this is the case. That in experienced surgeons' hands, it adds little to the surgery. And that's always a bit of a double-edged sword, because it kind of suggests if you're not doing it, maybe you're not experienced. And as surgeons, we generally like to think that we're shit hot at what we do. So hang on, if I'm not doing this, does that mean I'm not experienced? They identify that there's equivalent long-term vocal cord palsy rates, but there is an increase in the short-term cord palsy rates. And they can argue that it accurately stages disease and it may obviate the need for radioactive iodine if they don't find any evidence of metastasis in that area. So all of those are potential advantages. What are the disadvantages? Well, this disease is going to do well no matter what we do. It doesn't affect the survival. Local recurrence does not mean mortality. It does increase the risk of hypocalcemia, and as I've already said, that can significantly affect a patient's life. And there is certainly at least a short-term increase in vocal cord palsy rate. So there are more complications. You can also argue that it rarely alters the treatment plan, because yes, if you don't find any metastasis in the central compartment, you could argue that they don't need radioactive iodine. But radioactive iodine is given on the basis of the primary tumor's characteristics. So there's very few patients that you can say categorically, no, I'm not going to give radioactive iodine because I've done the central compartment clearance. And actually, most of them get it anyway. So these days, can we really justify the morbidity of a central compartment clearance unless there is clinically or radiologically obvious disease? And in the UK, we've basically come on the line that you don't routinely do it unless there is significant clinical concern. But that does change in different parts of the world. Any questions on that?
I think, would you advise patient with a 2 millimeter small malignant thyroid to keep under review?
2 millimeter, yes. I mean, I wouldn't even sample it. We wouldn't sample that here in Glasgow. You don't. The policy has changed recently. I think 2018 we decided that there should not be routine FNACs done on any nodules less than a centimetre in size. So we don't routinely sample them. Even if they look 5'5", we wouldn't sample anything less than a centimetre in size. We'd simply get a follow-up scan, and simply because it's no real advantage.
Great. Next question from Victoria. If fetal nodal disease in central compartment, would you do a lateral compartment within brackets papillary?
Only if there was clinically or radiologically obvious disease in the lateral compartment. So you do not need to use the principle. I mean, in head and neck cancer, you use the principle of going one step beyond. Okay, so if you've got disease in the central compartment, you would take the lateral compartment. Now, that's the sort of approach you would do in medullary thyroid cancer. But papillary thyroid cancer, because it is so treatable, because you've got the radioactive iodine, you need to take the disease out that you can see. You don't need to go and do prophylactic clearance.
Good. And if you're going to do a central compartment, what you will do with parathyroids exactly?
Preserve them. It's very difficult to do a central compartment properly and preserve the inferior parathyroids. Even if they're anatomically intact, their blood supply is generally significantly impaired, but you do try and preserve the parathyroids as much as possible. The superior parathyroids are easier to identify and preserve with a blood supply. So always take special care about the superior parathyroids, because the inferior, you're unlikely to get it properly.
Brilliant. I think that's it so far.
Okay. Now, advanced disease, the bad stuff, the stuff we don't like. So I've given you the definition of early disease. So advanced disease is thyroid cancer in which there is invasion of surrounding structures that can't be macroscopically cleared, or if there's evidence of distant metastasis. Now, that doesn't mean the game's a bogey. There is still stuff we can do. We've still got the radioactive iodine. We've still got the TSH suppression. These things work best when there's very little or preferably minimal disease present. So radioactive iodine works really well when you can't see that there's any obvious disease, which kind of makes sense, but maybe they're putting the wool over our eyes. So what structures can be involved in the area, and what can we do about them? Well, the one that we always worry about is the recurrent laryngeal nerve. Now, the recurrent laryngeal nerve can be involved in these sort of cancers. And this is where it's very important to know what the function of it is preoperatively. If preoperatively you've got a functioning vocal cord, and during the operation you find there's superficial invasion of that nerve, you should preserve that nerve and leave disease behind, because the morbidity you're going to create by sacrificing that nerve is not justified. The radioactive iodine, the other treatments can get good disease control. If, however, it's not functioning, then feel free to sacrifice it, because you can't break what's already broken. This is the case for papillary and follicular thyroid cancer. It's different for other forms. If you've got metastatic cancer to the thyroid, if you've got medullary thyroid cancer, that's a different question. But for papillary thyroid cancer, follicular thyroid cancer, superficial invasion with a functioning nerve, leave a bit of disease behind and keep that nerve functioning rather than sacrifice it. Parathyroids don't get invaded, okay? I'm not actually pointing out the parathyroid here. This is a non-recurrent recurrent laryngeal nerve, which always sends shivers down your spine. This is the parathyroid here. And as you can see, we've got its blood supply and preserved it. This is actually an inferior parathyroid because it's below the recurrent laryngeal nerve, but that's only because it's a non-recurrent nerve. Otherwise, this would have been the superior. Now, you do not need to routinely sacrifice these. Often the inferior ones do go as part of a central compartment clearance if you've got significant nodal disease present. You should try and preserve it, but the vascularity is going to be impaired. That may change because we've got newer technologies now. We've got some of these sort of immunofluorescence and ICG monitors that will hopefully help us do things better. But you need to pay attention to it. If they're directly involved, it's reasonable to sacrifice 1 or even 2 parathyroids, but you would not routinely clear all of them out unless it's very extensive disease that's involving the whole area. And hopefully then they've got a 5th one that you knew nothing about. Tracheal invasion is always a cause for concern. This is superficial tracheal invasion. You need to know about this before the operation. Something like this you can treat. Something like this causes a bit more cause for concern. This patient presented with airway obstruction and a thyroid mass, and this is direct invasion through the trachea of a papillary thyroid cancer. And she'd been told she had asthma for about 2 years before she eventually came to see us. Now, obviously, airway obstruction of this type is not really compatible with life, so the immediate treatment is to try and improve the airway. Now, you can't do a tracheostomy in this case, but what you can do is you can debulk it. And here, this is us debulking it using a suction monopolar in the same way as you do for an adenoidectomy. And you can gradually just buzz the disease down, clear it out, debulk it, improve the airway. And then a few weeks later, we went on and did a total thyroidectomy, tracheal resection, and this is the result. This is about 3 months down the line. Here's the scar from the tracheal resection. Just do an end-to-end anastomosis. That is not recurrence, despite what it may look like. That's actually just granulation associated with this suture. When I do these, I always use a non-absorbable suture anteriorly, because that's the position that's going to be under the most pressure. The other sutures are normally use dissolvable PDS. And as you can see, you actually get a very good result, much better result than if you do a resection for subglottic stenosis. They always tend to get a degree of webbing in these positions, but the ones for cancer do very well. So you can manage tracheal disease as long as it's not too extensive. If it is extensive, as in this case, this patient's got disease directly invading over a wide area, you can still stent the patient. This is one of these expanding stents. You need to use a coated stent in this case to just push the disease around, otherwise the disease will grow through into it. And then you address the thyroid, give the radioactive iodine, and you can get decent quality of life. Now, you're not going to cure this patient with surgery, but you are likely to get good long-term palliation. And here you see this is a nerve monitored tube that we're using to do his thyroidectomy. Veins, do we worry about them? Well, I mean, the internal jugular vein, we routinely used to resect those when we were doing our neck dissection, so that doesn't concern us. But what about this? This is the innominate vein, and this is direct invasion. Now, you may think that this then becomes irresectable. It doesn't, but you do need to have the backup of cardiothoracics. Assuming the IJ on the left-hand side is intact, you can actually just resect this whole section and sew up the innominate to get disease control. The problem arises if the internal jugular is involved on this side as well, and then you have to get creative. You can't, apparently, according to my cardiothoracic colleagues, actually do a vein graft of this. Apparently, in the presence of malignancy and a stenotomy, they just fall apart. So they don't do that, but you can resect it as a low pressure system. What can't we remove? Well, the carotid artery isn't really something you'd want to remove. Now, it's a very late stage before the carotid gets invaded, so you're not going to see this much. But how about the larynx? Are we actually prepared to do a laryngectomy as a primary surgical procedure for a patient with papillary thyroid cancer, given what we've said, that actually they're going to do well almost no matter what we do? And we have got all these adjuvant treatments. And we can, of course, still use external beam radiotherapy on top of everything else. Similarly, would we be willing to resect the esophagus? I personally have significant problems with doing either a primary laryngectomy or a laryngopharyngectomy for papillary thyroid cancer. I would always do my best to reduce the volume of the disease down to a minimum and then see how they get on with the adjuvant treatments, because this is slow growing disease. And even if we don't get rid of all of it, we can always go back in at a later stage. We need to be very careful to consider, are we altering the disease process or simply increasing the short-term morbidity for our patients when we're treating these very advanced disease processes? And bear in mind that local recurrence is not mortality. We can go back in and treat these. So small volume residual disease, we can control, but don't leave big volumes behind. You don't want to leave 4 or 5 centimeter lymph nodes just sitting there because it was a bit tricky to get it out in the first instance. minimize the amount of disease, give the radioactive iodine the best chance of working, and then if necessary, you can consider external beam radiotherapy. That was the situation up till about 3 years ago. But we're now seeing things coming through. Now, the TKI inhibitors, a lot's been said about that. You've got syndetimib, lanbetamib, and these are starting to have a real effect on some of these advanced thyroid cancers. We're getting patients who are BRAF positive with significantly advanced anaplastic thyroid cancers now surviving 2 years. This was unheard of previously. Similarly, papillary thyroid cancers and undifferentiated thyroid cancers do respond to the TKI inhibitors. And certainly our experience here, and I know Ian Nixon's experience, he's going to discuss with you from Edinburgh about carotids later, is that you can downstage these patients with the use of TKI inhibitors. They seem to get you a window of about 18 months where you get disease response. After that, they may break out, and we're still not sure the timing of when we should do operations in these cases, but certainly we have successfully used them now as neoadjuvant treatments to try and improve our ability to operate on these patients moving forward. And similarly, they can be used for recurrent disease and advanced disease at the other side of things. So there's all sorts of things that are coming up. This is quite an exciting time. So in summary, I still say that the key treatment for thyroid cancer is surgery, but I've got to accept you may need to consider active surveillance. MDT's discussions are very useful for early stage disease and for advanced stage disease. For the disease in the middle, actually, it's pretty obvious what you're going to do for a thyroid cancer. You take the disease you see out, you clear any nodes out, and you then go on for other treatments. But at the early stages, it's very useful to get the validation of an MDT that either active surveillance or doing less surgery is a reasonable option. And at the extremes of the disease, you've got to be thinking about how much morbidity are you causing. Is there any real need to do a laryngectomy on a patient who's probably only going to survive 2 years, no matter what you do? You might as well give them a good quality of life than subject them to an extended period of time in hospital, and be realistic about your expectations. Thank you very much. Any questions?
Great. I think our training Maya has asked fantastic. Would that be a two-stage operation or can be done in one go? Thyroid and tracheal resection.
Sorry, Jay, you broke up there. Something about a two-stage operation?
Would that be two-stage operation or can be done in one go? Thyroid and tracheal resection, I mean.
Oh, no, you do that in a single stage.
Okay, that's good. And the next question, Victoria, in case of recurrence, why do we see a disease becoming less radioiodine responsive?
Okay. The point is that cancers do change, and the cancer cells are different to their host cells. So as you go further away from the host cell line, the more effective any given treatment is, the more chance of other things breaking out. With any infection or bacteria, if you've got a very good way of suppressing that, you are going to get some cell lines that are resistant to that treatment. And it's the same with thyroid cancer, same with infections. Is that if you've got an anti-penicillin sensitivity, at one time, most bacteria are penicillin sensitive, but because we were so effective with the penicillin, we get resistance building up. It's the same with thyroid cancer. It's just that those that get killed off by the radioactive iodine get killed off. And it's those that don't or are less sensitive to it that continue to grow.
Brilliant. Next question. Kindly comment on superficial invasion of trachea.
Okay, superficial invasion of the trachea is, as long as it's not through and it's just on the cartilage itself, I normally would just do a local shave and then rely on the radioactive iodine in the first instance. I wouldn't do a tracheal resection for something like that. If I'm concerned about tracheal invasion, I will always do a tracheoscopy preoperatively, and as long as there's no mucosal invasion, either of the trachea or the esophagus, I'm happy to simply take it off the surface. If at time of surgery it's a bit more extensive, I may take some cartilage away, and you can swing flaps into the area to support that area. But radioactive iodine works in these cases. As long as you're not leaving a volume of disease behind, it is very effective.
We got in our MDT quite a few cases with sub-centimetric primary cancer,
Mm-hmm.
with significant lateral neck disease and aggressive pathology. So I'm a bit skeptic about leaving such nodules if they are U4, U5. What's your view, please?
If you've got lateral neck disease, then that suggests a disease activity that's aggressive. And I agree, you need to treat the lateral neck and you need to take the thyroid out to use the radioactive iodine. But that's a different disease process to an incidentally found small nodule that's sub-centimeter in size. And there's no suggestion, and the evidence from Kobe is that these patients generally don't progress on to have aggressive disease. So you've got to treat the patients as an individual and not make group decisions simply on the basis of one thing. I myself know, I've recently had a patient who had a fairly extensive cystic metastasis from a papillary thyroid cancer, and the primary tumor was only 1 millimeter in size in the thyroid. So yes, this disease does happen like that, but that's the exception, not the rule.
Brilliant, Omar. Thank you very much. That's a fantastic talk with loads of useful information at higher level. It's really high standard. Thank you very much, Omar.
You're most welcome.
And we will have a 30-minute break. We'll be back at probably 1:25. Thank you.
Excellent work, Jay.
Thanks, Sam.
Fantastic. It's going on so well, and all the talks are very, very good.
Standard.
I have very rarely hung on to the whole day like this, and I'm still here. My friend Shahrukh talking.
Yep.
He's coming next, I take, yeah?
Coming.
Yeah. Are you at the university, Jay?
The medical school building.
Oh, I see. See, you need a break yourself.
Yeah. I'll just go and take a break.
Do you need any help with anything? You okay?
I'm fine. Thanks, Sam. I'll come back.
I could bring you some food.
No worries. I'll go and get it. It's fine. Before I go to, I just need to do it back. So before I go to lunch, I'll do that. Yeah, you can try, Shane. You want to trial it?
Yes, Jay. Let me just have a look and see. I can't see the poll function yet.
Oh, yeah, just one moment. I have to do that. Yeah. You see now?
Perfect. Yes, it works. Okay. That's great. Perfect. I'm just going to go off just now then. Thank you.
So, right. That's good. You know how to install that. Yeah, that's good. I will go and come back.
Rely on the fact that they've got workers in two different places in order to avoid paying them equally. It's made very clear judgment that the purpose of the legislation is to allow these types of encounters to happen rather than to try and avoid them.
Their next legal hurdle is to prove these roles are of equal value and that there's no material factor which justifies their differences in pay. Arguments which may take several years to reach a conclusion.
Well, Emma joins us now. You make it clear there this is just one step.
Sam, are you there?
Hello.
Dr. Majumdar, how are you doing?
Good to see you, eh? It feels like you are just in the same room.
Yes, exactly. I never moved from this room.
No,
And I think Jay's on, or at least he's got something going on.
no, Jay's there. Jay's just moving in and around. He's been sat there since early morning.
Oh my God. Yeah. Thank you very much.
Thanks so much for joining in.
Oh, absolutely. Pleasure. Thank you for inviting.
This is going to be many of your talks and stuff in this country. You're started in cutting edge laryngology in College of Surgeons. So,
I know. How's the COVID situation in Scotland right now?
Scotland is pretty good. I think we're going to be going out of lockdown probably end of April.
Wow, that's crazy. Yeah, over here things are coming back to normal. It's kind of nice.
But then again, our population is just half the size of London.
Oh, I know. London, is it bad over there in London?
Now, London is good too. I think overall, I think UK is looking good.
Oh, that's awesome. Good for you.
But it's good to see that you guys are. I mean, you got a massive population out there in many states, and but you guys are doing okay, aren't you now?
Yeah. We're doing fine. I got COVID. You know that, right? I nearly died back last
I didn't
year.
know that.
Yeah, back in April. Yeah, I got it from actually a robotic case.
Oh.
We weren't doing testing on patients. It was horrible. It was a horror show here. It was. I hope this never happens again.
You're a tough bloke. You can cough it out.
Yeah, but Sam, we got to sit down sometime. It's a different feeling. It's not a good. I'm glad the vaccines are here. Everyone should get a vaccine. I think it's very important.
Have you had yours yet?
Huh? Oh yeah. I had mine. We got the vaccine back in December.
Yeah. So
that's because we had the Pfizer vaccine in December. Then Moderna came out end of December. So a lot of people. We were now into vaccinating the common public is getting vaccinated now. Anyone age 18 or more.
Yeah, that's pretty good.
How about you guys? You guys are vaccinating now?
I think we have more than 50% of the population vaccinated.
Oh, so we're not even close to that. I mean, the population is very big.
We got small number, so that's an advantage.
Yeah.
And we've been very good at starting early. And I think we did Pfizer, and now we got Pfizer, AstraZeneca, Oxford, and Moderna.
Yeah. So is the admissions in the hospital going down because of the vaccination? Have you guys seen that?
Oh, our hospital here, we got one patient left, if I'm right.
Wow, that's amazing. That's what we're hoping with these vaccines, right? Yeah, we went through a second surge here in Boston, and we went through a second surge in January into beginning of February, and then now it's sort of petered out. So all our COVID ICUs, everything has been improved. It's gone. We disbanded them. Hello, Jay. How are you?
Thank you very much.
Thanks for inviting.
Good.
Okay, let me see if I can share my screen to make sure it's working. Because what's the time over there? We're like prime time in what, 10 minutes?
It's actually 14.
14 minutes. You want me to share my screen just to make sure it works? Is that okay? It said this will stop other screen sharing. Do you want to continue? I'm going to hit yes. Okay. Hold on. Yeah, share. Okay, can you guys see my screen?
Perfect. It looks fine.
Let me just make sure I can do.
It looks good.
Slideshow. Hold on. From beginning. Can you see this? Perfect. Is it advancing?
Yeah.
Yeah. Okay. Good. I'll stop sharing then.
Yeah.
All right. That's great.
Good.
So Jay, where are you at? Are you at Dundee as well?
Dundee, just sitting next to Mr. Majumdar.
Next to.
Oh, you're the. Oh. The beauty of Zoom backgrounds nowadays.
Yes. You can add anything. I could add, Boston.
I know you could, or some beach resort.
Yes.
That's right.
No, what I did was I was doing a secret. I was doing a lot of meetings from home, so I had my office bag as my background.
That's nice to know.
But this is not a. This is a real deal. Anyway, so Jay, what do you like to do? What's your interest?
I'm a head and neck.
Oh, nice, excellent, very nice.
Even though I want to do other things, but I'm just limited myself with the head.
That's wonderful. That's great. Yeah, no, that's wonderful.
He likes doing otology and rhinology.
Oh, nice. He does everything. That's great.
He's a versatile surgeon.
Yeah. And then Sam helps us all make people feel better.
Yes, I've taken the homeopathic approach to life. Yeah. To keep people happy, keeping preserving functions.
I know it is too short. It is too short.
You know, you guys are too busy cutting things out and throwing it in the bucket.
Oh, we do preserve some for research, so that's the important thing.
That's very kind of you.
Yeah. That's great. All right.
We'll wait for 8 minutes.
Oh, okay. We got 8 minutes. I'm going to go use the facilities and I'm going to make a phone call. Is that okay with you guys?
Fine.
All right, perfect.
Yes.
Shahrukh, do you want to share your screen?
Yes.
Great. Welcome back after lunch. This afternoon, we have a keynote lecture, which is going to be delivered by Shahrukh Jalsi. He's a robotic and head and neck surgeon from Boston, and he's a key teacher and trainer in the Harvard Medical School. And he has got an excellent experience in transoral robotic surgery and also head and neck cancer. Shahrukh, it's over to you. Thank you.
Thank you, Jay, for Dr. Manik and Dr. Majumdar for inviting. Really excited to be here. I had looked at your agenda today, and it's a very terrific agenda for all those attendees, and really congratulations on setting this up. Obviously, we're in a different world now, COVID pandemic. Hope this goes away soon, and all of us and our families get through this in a safe manner. But I think with the vaccines coming out, I think, and people getting more and more, I think we'll be fine. Obviously, my discussion today is robotic surgery as a tool for de-intensification of oropharyngeal cancer treatment, as my title. We're going to go through this. I think there's a lot of things, a lot of newer data that keeps on coming out around this technology and the techniques and stuff. So I really have no disclosure in this talk. I think the most important thing for everyone online today is that it is not the strong, Charles Darwin said, it's not the strongest species that survives, nor the most intelligent, but the one that is most responsive to change. So I think continuous adaptability is critical for all of us, whether we are surgeons, non-surgeons who manage diseases, that we got to understand what the new things are coming, the new frontiers, and to adapt them. De-intensify is a terminology which is to reduce the intensity of strength or something. In our world, I think as we've seen over time, historically, we have gone from maximally invasive surgery to more and more minimally invasive. I think the big turning points came when we went from laparotomies for abdominal surgery to now laparoscopy, and so on and so forth. And I think that the pendulum has continued in otolaryngology, where we went from open sinus surgery now being the standard, being endoscopic sinus surgery, and beyond. And then some amazing things that we as a community of surgeons have achieved in terms of swallowing and dysphagia, what Dr. Majumdar does, some amazing stuff out there, which is all endoscopic and minimally invasive. So this is just an incidence from the United States for pharynx and oral cavity cancer. And you can see about 50,000 new cases of this disease in the United States. There's about 10,000 deaths and about 10,000 new oropharyngeal cancers. Dr. Manik, if my voice is echoing or doesn't sound good, please let me know. We can adjust the audiovisual over here. Oral oncogenic potential of HPV infection, because that's a new thing now, between the ages of 14 and 69 has been recognized. And 95% of these cancers are squamous cell, as we know. About 80 million Americans get infected with human papilloma virus, and it has now been shown to be a distinct causative agent for oropharyngeal cancer. There has been an increase in HPV prevalence in this country from about 16% in the mid 80s to about 72% more recently. Again, as you know, this epidemiological data lags behind by many years, so we go with what's most readily available. And then it has been associated with genital warts in HPV 6 and 11, but more so now in cancers such as HPV 16 and 18 for head and neck cancers, and 31 and 45 for other GYN and colorectal cancers. The profile of the HPV patient has changed as well, because we're seeing younger and younger patients as compared to HPV negative. I think HPV is an important causative factor for head and neck cancer now, at least oropharyngeal. Incidence is higher in men compared to women. People are less likely to smoke. So although the smoking and the tobacco pandemic is going down, but this HPV is taking off, and I think it's pretty endemic in most parts of the Western world. higher socioeconomic status compared to the non HPV negative counterparts, and a high lifetime number of vaginal and oral sex partners. So this all points to why I'm bringing this up is it's important to take a good social history on your patients just to understand where they're coming from. Some of these questions are uncomfortable. How do I ask my patient how many partners they have? But I think it will help you guide long-term therapy and hopefully surveillance on these on such patients. Having said that, the oral oncogenic potential, that means if you have HPV, the chance of actually getting HPV-related cancer is not that high. It's about 6.6% in men and about 1.5% in women, and the gender difference is statistically significant. Histology is usually poorly differentiated, non-keratinizing with basaloid features, and then partners of patients with HPV do not seem to have elevated oral HPV infection as compared to general. And that's an area of active research. It's a research interest of mine, and I would encourage if there are trainees or even surgeons out there that this is a very interesting topic to think about, that why does not the partner or spouse of a patient have cancer simultaneously? I've yet to find one where both folks in a couple have oral cancer. A lot of this was brought into our existence by Dr. Carol Fakhri and our group, who had published this article about prognosis of HPV-associated cancer. And why I'm talking about this is going to become evident as we go through these next few slides. But basically, this particular study back in 2008 was looking at induction chemo in both HPV positive and negative patients. Median follow-up was about 40 months. And basically what we saw was that HPV positive tumors demonstrated a higher survival as compared to HPV negative tumors. So that means there was a positive prognosis if you had HPV versus not. 95% survival at 2 years versus 62%. And at the same time, oropharyngeal cancers of those which were HPV positive had a better response to chemo and primary chemo radiation than those with HPV negative tumors. The important thing to remember here is this was a primarily non-surgical trial, and it depends on what lessons you take from this. For most of us, it demonstrated that HPV positive tumors have a better prognosis. That's it. Then Dr. Ang et al. Published this another article in New England Journal of Medicine in 2010. So this is just giving you historical background about this. And they diagnosed that HPV-16 was an independent risk factor. And then they were looking at data extracted from the RTOG-0129 trial, which again was a non-surgical trial which compared accelerated fraction versus standard fraction radiation. And in that, they found that people who had HPV positive had a better 3-year survival versus those who were HPV negative, 80% versus about 60%. There was death within 30 days, which was about 3.3% versus 2%. There was a lot of toxicity in both arms in this group. The key thing was there was no comparison to surgery. And that's the important thing as we go through historically and as we discuss about why what we're talking about, de-intensification becomes important in HPV positive. These are just the figures that are from Dr. Ang's article. And bottom line is, if you're HPV negative disease, based on your HPV status, you have a worse overall survival than HPV positive. Now, HPV positive patients may have a survival as high as 80%, while HPV negative patients about 30 to 40%. And that was pretty much replicated in overall survival, progression-free survival. Then you looked at P16 expression, because in most, at least clinical department in the United States, I don't know how you guys do it in the UK, we look at P16 as a surrogate marker because it's readily available in our pathology labs versus doing an HPV derived test, which may be a send out test and may take longer and also cost more money. So we figured out that P16 is a good surrogate marker for HPV, and most of the institutions will use that. We did put out a study a few years ago looking at imaging characteristics of metastatic nodes and outcome by HPV status. And we had looked at about 88 patients. Nodal metastases were more common in HPV positive patients, which was statistically significant as compared to HPV negative. In addition, the HPV positive patients showed a higher prevalence of extracapsular spread. Again, statistically significant compared to HPV negative patients. But the recurrence was more common in HPV negative patients despite all this, and was independent of the presence of extracapsular spread in nodal metastases. So all in all, when we looked at this data of ours, we said, you know, you could be HPV positive, you could have some extra nodal extension, yet your survival is going to be better just by the fact that you have HPV positive. So basically what we are looking at this point in time, and there's many other articles out there and publications that says that HPV does have more N positive disease. You'll see more nodal metastases on your imaging studies, your PET scan, and so on and so forth. There may be a higher prevalence of extracapsular spread, but there's still a less chance of recurrence. So then we went on to look at the staging system. As you can see, the staging system has now changed on the American Joint Committee, Cancer Committee staging. There's a 7th edition, and then there's an 8th edition that came out of this. And basically, up until the 7th edition, we were saying that as soon as you became N positive, if you had a lymph node, you would automatically be a stage 3 and 4 disease. And most of these patients were automatically put into an arm of combined mortality treatment, usually chemoradiation followed by surgical salvage. Which had become a norm in our country. And then early stage disease, T1s and T2s, or stage 1 and stage 2 without N positive disease could be treated with single modality treatment. Obviously, the 8th edition changed all this, and because now we had a recognition of HPV positive disease, so there's a separate category now of P16 positive oropharyngeal cancer. And in this, basically, the T stage didn't really change much because it was based on size, but the N stage changed. So there's a clinical category, which you're seeing on the left side of the screen, and then you have a pathological category, which is on the right side of the screen. Obviously, pathological criteria is met after surgery. And so this demonstrated the recognition that surgical intervention could also give you more diagnostic data to help appropriately stage patients. But as you can see, if you had N1 disease, it was 1 or more ipsilateral nodes less than 6 centimeters. N2 was contralateral or bilateral nodes, and N3, which was a new, was always there, but lymph node greater than 6 centimeters. But when you went into the pathological staging, basically we started looking at the number of lymph nodes that are available. So N1 disease would be anything that less than or equal to 4 nodes, and N2 disease pathologically would be greater than 4 nodes, and a pathological N3 does not exist. So it all depends on your nodal yield. And again, there's a lot of articles out now, which we will not belabor over here. It is what is considered a therapeutic or a good quality neck dissection, where typically in our center, we say if you have to have at least 18 lymph nodes in a previously unoperated neck to be considered a high quality neck dissection, rather than super selective neck dissection where you may get a yield of 1 or 2 lymph nodes. Obviously, post-radiated patients, all bets are off because a lot of your lymphatic package is turned into scar tissue. And so it is understandable that your nodal yield will be less. And the clinical staging changed based on all this thing that's coming out with the data, where we now have up to a T3 N2 disease considered a stage 2. And then when you become N3 and you start going into T4s, that's when you start going into stage 3. And stage 4 is now considered anything with metastatic disease based on your imaging workup or other whatever modality you use to look for metastases. So this changed that now we had T3 up to a T3 N2 disease still being considered stage 2, because we've recognized over the last decade that oropharyngeal cancer, HPV related, has a better outcome. Same thing with the overall pathologic staging. In this, you can be a T4N1 and still be considered a stage 2 disease as compared to clinical staging. This is right here. And the next one is path. So this is obviously pathological staging is after the surgery. So again, shows that if you have a post-surgical pathological staging, you might still be able to improve or help with the staging system and see if the patient's appropriately staged or not. So really the question becomes, it's HPV positive with a favorable survival. Why are we still treating with aggressive treatments? When I was training, pretty much all of our oropharyngeal cancers did automatically get chemoradiation. And we saw all the toxicities and all that because everything used to get admitted to the head and neck unit. And we would deal with these patients, and a lot of them with no ability to swallow long term. There are indications for adjuvant therapy. I put in specifically adjuvant over here. This means post surgical. but it's extracapsular nodal spread, positive margins. If you have pathological T3 or T4 disease, which means really from the oropharynx, you're going into your pterygoid muscles or extending into your bone and stuff. N2 or N3 disease, obviously pathological N2 is METs in greater than 4 nodes. Nodal disease in level 4 or 5. So now we're looking at nodes coming into the lower part of the neck. Perinodal invasion is a soft call, at least in our center. So I don't know, it's all very center driven, how you folks work with your medical oncology and radiation oncology colleagues. These are the NCCN guidelines, and I just want to highlight this, that basically it has shown that if you have a P16 positive disease that's T1, T2, and no nodes, if you go through the schema of going through the surgical arm and there are no adverse features, which we just talked about, these people can be observed. And you're like, okay, it's an N negative disease. Okay, I get it. We take it out, we get negative margins, and we have a good outcome. We can save them radiation. But then the schema actually got updated this year, where even if you have N1 disease, which is a clinical N1, which is a single node less than 3 centimeters, and you go through the schema, and again, there are no adverse features, you can still watch them. So you can save them a whole modality of treatment. And the next schema is for if you have, again, a T2 N1, 2 or more ipsilateral nodes, or you can do a N2 disease or T3 N2 disease. You can, again, go down the surgical arm. They obviously have the choice at this point in time because they have multiple nodes to go through concurrent chemoradiation therapy. Or you can go into clinical trials if you want to send them, or you can go into the surgical arm, which is if it's a unilateral disease, lymph nodes, and you go in, resect the primary, you do the neck dissections. If it's bilateral neck nodes, you can do bilateral neck nodes. And if there's, again, no adverse features as far as bilateral neck nodes, you can, again, follow them up. You can see if you can save them the whole aspect of radiation or chemo. Again, this is a joint decision in our head and neck tumor boards with pathology review, med onc review, and radiation oncology review. This is not a decision we take in isolation as surgeons or anything like that. So a lot of things have to happen. But the reason I show this to you is that the NCCN, or the National Comprehensive Cancer Network, which is a conglomeration of nearly 25 major cancer centers in the United States, put out these guidelines that have their footprint in evidence-based medicine. And they have come up with, because of HPV positive disease, we can now, even with traditional surgery that we used to do and said, oh, you're going to go for chemoradiation, there is this whole arm of observation or not having to do adjuvant therapy. Similarly, if you go to really advanced disease now, HPV positive, you got N3 disease, or you have a T4 N3, here again, you can do concurrent chemoradiation. And again, with these advanced surgeries, and there's no adverse features, you can be fine. Again, reminding you guys about the adverse features: extranodal extension, any positive margins, pathologic T3 or T4, a pathologic, which is different than clinical, because you might see something, but once the pathology comes back, it may be smaller than what you were seeing. Multiple nodes, that's more than 4 basically, and then you go from there, and you can still be in an observation arm. Now, a lot of people say, well, you know, what if someone doesn't want to be in the observation arm and they need chemoradiation? What is the advantage of this? So early stage disease, you can equally treat patients with radiation or surgery. We know that there's plenty of articles out there. And stage 1 and 2 disease can be dealt with single modality treatment. I think the ability with surgery, you can, again, save radiation. This particular study came out of Europe in the GETIC study, which is a pretty famous study. It's now over a decade old. But you're able to save radiation in 72% of the patients. This is obviously the time before we had robotic surgery becoming so popular, but about the 3/4 of people could be saved given additional information from a surgery and neck dissection. This is a study which shows radiation is excellent with great local regional control, 5-year control rate of 85%, local regional control of over 80%, and disease-free survival of over 85%. So again, it's a great modality. You treat people to 66 gray, and people do fine. And then transoral resections were becoming popular in the early 2000s, where 5-year local control rate was of over 90%. So again, similar, but you can see there are trachs that had to go in, there are permanent G-tubes. Even with this, at least in the United States, we do quote a rate of permanent G-tube in non-surgically treated patients of about 3% or so. So I think it becomes helpful for those patients. Advanced stage disease, obviously, you do concurrent chemoradiation, salvage for residual disease, or you can do surgery up front with primary of the neck and post-op radiation. And then you can do induction chemo followed by chemoradiation, which is still a category 3 because we don't have good randomized controlled trials comparing induction chemo. Although there have been several studies, both from the US and from Europe now showing that induction chemo does not improve survival on the patients. So typically we reserve induction chemo for people with massive tumors, where we want to get some kind of a reduction in the size of the tumor to reassess and decide whether they're going to go into a surgery first arm or a chemoradiation arm, and then decide, go from there. There's another study which came from France, which was looking at radiation alone versus concomitant chemoradiation. And one arm had a radiation to 70 gray and 35 fraction, and the second arm had carboplatinum followed by radiation. And pretty much all this showed that if you had chemoradiation, you had a better overall survival, disease-free survival, and local regional control, but this was not a comparison to surgery. So really for advanced stage disease, we really don't have any randomized control trials. I think there's a lot of activity happening both in Europe and in the United States to come up with some kind of randomized trials to answer this question. This is a study looking at surgery and radiation versus chemoradiation, and basically showed that the overall survival was better in the surgery followed by radiation arm of about 70% versus 40%, and which was statistically significant, but not reaching statistical significance on local regional control or disease-specific survival, but hopefully they had a better outcome. Now, here's the bottom line, that if you operate on people first, why may it make a difference in the adjuvant therapy they may receive? So according to the NCCN, if you are giving definitive radiation therapy to a tonsil or a neck or any other site, you're really radiating these sites to 66 to 70 gray to the primary site and where the main lymph nodes are. And you can reduce the dose to 44 to 50 gray to lower intermediate risk sites. For example, for tonsil cancer, level 4 and 5 would be considered low risk, so you can do that. On the other hand, on post-operative radiation, you would go as high as 60 to 66 gray. So again, you're reducing the dose from 66 to 70 to a high-risk area of positive margins. If you don't have positive margins, our radiation oncologists are willing to even reduce this down to about 50 to 60 gray, which I think became more evident with the ECOG 3311 trial, which we'll talk about in just a few slides. And then you're going to go to 44 to 60 gray in low to intermediate sites of subclinical spread. And so the bottom line is surgery can help intensify treatment in oropharyngeal cancer. Can you guys hear me okay, Dr. Manik?
Yeah, absolutely.
Okay. All righty. So why does this all matter? Because of radiation effects, and dysphagia can happen as a long-term effect. And obviously, I'm not an expert on it, but there's plenty of people on this call that are experts on this. But we see the endpoint in our head and neck clinics is what is the effects of radiation. And patients treated with the radiation therapy, 78% with stage 3 and 4, about a quarter of them can end up with moderate to severe dysphagia. And this is a study that was done. That's a very beautiful study showing the steep dose effect relationship of dysphagia. And basically it says that you can have a worsening of dysphagia by about 20% for every 10 gray of radiation therapy. So someone who gets radiated primarily to the constrictors, particularly the superior and middle constrictors, which is the main area where the dysphagia kicks in. And for those who have operated on patients, you can see the constrictors are very wispy kind of muscle. It turns into scar tissue pretty quickly. There's a difference between someone who gets 70 gray of radiation versus someone who might get 50 gray. And so if you can go in with surgery and help reduce that radiation effect, I think that would be great. There are late swallowing effects. These are people that are followed out for more than 2 to 3 years, looking at the swallowing dysfunction after radiotherapy was completed. And again, you can see that about 83% of people had some form of dysphagia. My biggest question to my patients when they come to clinic, whether they've had surgery or chemoradiation or a combination of, is, are you comfortable eating in public? And I think that common question will answer a lot of questions, because then the patient may say, you know what, doc, when I go out, I just don't want to have food out there because I have to swallow multiple times to get that food down. And it's a big problem from a social perspective, or people having reduced sensitivity. They may have residue in your throat. They got to clear the throat a lot. And imagine you're sitting in a restaurant with your loved one. Obviously, COVID is gone by then. And you're going to clear your throat 10, 15 times, and it makes people uncomfortable. Aspiration and penetration, obviously, coughing and choking after eating becomes a big problem. So what we know so far is that most radiation studies have shown superiority of chemoradiation therapy over radiation. Minimally invasive and partial robotic approaches are becoming standard of care, and surgery plus chemoradiation has a better disease-specific survival for oropharyngeal cancer. And so therein comes robotic surgery, a good modality to do. And again, a lot of studies have been done, really pioneered, at least in this country, by Dr. Weinstein and Dr. O'Malley, who are at the University of Pennsylvania. We started a program in Boston back in 2007 and have grown from there. But basically, it showed that it had very good local, regional, and distant disease control. Obviously, you can see a lot of these studies from before we started recognizing the importance of HPV disease. And now that we know about it, I think it changes the game even more. There was also transoral robotic surgery for oropharyngeal carcinoma, its impact on quality of life, and it showed there was a positive impact on quality of life. And the whole goal was that even if you do surgery, and there's all these discussions about are we subjecting our people to triple modality treatment or not, and the counter argument to that is the patients are always in for triple modality treatment because salvage surgery is always lurking in the background. As head and neck surgeons, we're always evaluating the patient long term. And if we were not worried about chemoradiation failing, then I think all these surveillance paradigms that we have in different countries and different healthcare systems would be very different. It would be like you operate or you treat someone with chemoradiation and don't follow them out. But you still need a surgeon or someone to be able to follow these patients out longitudinally because we're worried about recurrence. And so, surgery is always there. I always tell my patients, you're always in for triple modality treatment, whether it happens now or it happens a year or so down the road or never happens, I don't know, but we got to keep an eye on you for at least 5 years. So surgery may help de-intensify therapy. I think someone needs to mute. So transoral resection of human papillomavirus, again, these are more studies that show that if you have HPV positive disease, if you did TORS on it plus neck dissection, you improve the disease-free survival, but there's no difference in disease-specific survival or overall survival when you do with or without adjuvant therapy. The E1308 trial was very interesting because we were looking at induction chemotherapy followed by radiation and weekly cetuximab. It was an ECOG-driven trial, and I think it's important to know this because these are the patients who had HPV-positive disease, underwent 3 cycles of induction chemo, and complete responders continued on to intensely modulated radiation plus weekly cetuximab. And if you had less than complete response, then you had a bigger dose of radiation therapy with weekly cetuximab. And it showed that the 2 years progression-free survival and overall survival was excellent in people who had HPV disease. And then you had this new risk group that came in, people who had greater than 10 pack years smoking versus less than or equal to 10 pack years smoking. And you saw that people who smoke less had a better progression-free survival than those who did not. And for favorable risk patient induction, the chemotherapy with reduced dose IMRT with cetuximab worthy of future study. The problem was that there was a release that came out shortly thereafter that people in the cetuximab arm were found to be inferior to standard treatment in HPV positive oropharyngeal cancer. I think this had been published further out, so I think it's something to discuss with our chemotherapy and radiation folks if not already been done. We've moved away from using cetuximab in our head and neck patients, but this is a very interesting finding that I put in here because a lot of the HPV positive patients in our community cancer centers get treated with cetuximab, and we're hoping that that paradigm will change. Obviously, no robotic surgery. A discussion will now be complete with the ORATOR trial that was completed in Canada and Australia under the leadership of Dr. Nichols up in Canada. And this was looking at radiotherapy versus transoral robotic surgery and neck dissection is a phase 2 randomized trial. They randomized early stage disease, T1, T2, and up to N2 disease, HV positive into either radiation, 70 gray, or TORS plus neck dissection with or without adjuvant therapy. And they were looking at the MDADI scores for swallowing at 1 year. 68 patients in this trial, and basically they concluded that the MDADI scores was statistically significant towards having a better outcome in a short follow-up of about 2 years in radiation patients versus TORS patients. Now, obviously, if you look at the schema of the ORATOR trial, pretty much all the patients ended up with tracheostomies who were in the surgical arm. A lot of us don't put tracheostomies in patients because they do fine, depending on how you do, as long as you clip the vessels. But the conclusion here was that we should be thoughtful about favoring TORS over radiotherapy as an initial modality treatment. But I think more studies need to be done to either prove or disprove the findings of this particular trial. But again, important piece of data, at least at this point in time in 2021. The ECOG 3311 trial that was done by Dr. Ferris obviously was a little different. It randomized people based on the risk factor they had after they had TORS and a neck dissection into low risk, intermediate risk. Intermediate risk was basically 2 different radiotherapy arms. One was 50 gray, the other was 60 gray. And the intermediate risk stratification was based on your smoking. If you did less than 10 packs or greater than 10 packs, based on the prior study I showed you. And then the high risk got standard fraction postoperative radiation therapy. And in this, obviously, the important thing was streamlining the credentialing of surgeons. We had to send in our surgical reports, how we were doing it, and about 520 cases were done. 350 eligible patients came out of it. And then Arm A had 37 patients, Arm B had 102, and Arm D had about 110. And then we stratified by risk stratification. Follow-up is about nearly 3 years, and it showed that arms A, B, and C, you had a 2-year disease progression-free survival of greater than 90% in all arms. And especially the important ones were looking at arm B and C, B being where you got 50 gray of postoperative radiation, and arm C being 60 gray. And basically it showed that you had even with and in low risk patients, they got observation, which is arm A, that you had a favorable treatment response. And so this tells us that with surgery, we were able to de-intensify treatment and give people a better outcome and reduce their morbidity and de-intensify treatment. So obviously we're here for robotic surgery. It is a balancing act of oncology, functional oncological outcome, functional speech and swallowing outcome, and morbidities and cosmesis. And that's where the robot comes in. The sites you can treat is pretty much all what you can access. Remember, the robot is a play on our traditional surgery with a headlight and electrocautery, with the added advantage of having a 3D camera, which comes in a 0-degree variety and a 30-degree variety, allowing you to look around corners, such as the corner around your base of tongue. So subsites you can work on is, your supraglottis, you can work on the base of tongue, you can work on the tonsil. There used to be a company that went out of business called Med Robotics that used to have a flexible telescope with which you could really look up into the nasopharynx as well. But right now we don't have a flexible telescopic option, but hopefully that'll be forthcoming in the future to take care of that. So these are the main 3 subsites that you can work on. Obviously the cartoons, you have the base of tongue area. We can take out the supraglottis. I've done a full supraglottic laryngectomy with these. We do base of tongue resections. I think it's become a good adjunct in the diagnosis of the unknown primary patient, where you may have to do bilateral lingual tonsillectomies. We do leave behind a strip of normal mucosa in the midline to prevent a complete deficit in the entire pharynx with both tonsils and both lingual tonsils gone. Which would create a stenotic, possibly a stenotic segment. But you can take these out. And really, the robot, again, there are many iterations of it. There's a new version of this coming out as well, which again, we're trying to reduce the size of this, because honestly, a transoral robotic surgery is a natural orifice surgery, as you can see. Both transoral robotic surgery and colon surgery comes through a natural orifice, unlike our partners in urology or general surgery, where they're insufflating an abdomen and operating through it. So basically, as I joke around, we really rely on people with big mouths and ideally with no teeth. Those will be the ideal candidate for this surgery. But you can fit in three arms in this. I think with the newer iteration of the new robots coming out, you can have 4 arms coming through a single arm, sort of spreads out like the legs of a spider, which will be very exciting to use. I have not used one of those, but enthusiastic about getting my hands on one of those. And really, the advantages of robotic surgery is superior exposure. You can do 360-degree movement of an arm. You can have your wrist motions magnified based on how you set your robot. Magnification, obviously, is like getting a microscope into the throat, allows you to really come up close and personal with the tumors and to see them. There's better illumination. And honestly, if you can take the tumor out of their mouth and not do traditional mandibulotomies or other procedures, then the patients will have a shorter outcome or recovery to swallowing. Disadvantage is obviously there's a learning curve. You got to learn how to use this. There's a big capital expenditure. I think the new iterations of some of these robots is $2 million or more. And there's disposables as well that you need to look at. It is difficult to manipulate for anterior lesions, so really want to use stuff in the back of the throat, such as tonsura fossa, base of tongue, supraglottis. But again, we always do a pre-TORS endoscopy where we just assess if the patient will be a candidate for the robot. I think this is also because we share the robot amongst multiple specialties. So it's just unfair for us to say, hey, we're going to use a robot and then go in, figure out, oh my God, this doesn't fit in there. You just prevented another service from using the robot that day. So I think in the interest of shared resources, we use that methodology to see if the patient would be a candidate for robotic surgery at the time of their staging endoscopy. When I first started this, we were doing this on an IRB protocol, which is obviously now long done. FDA approval was obtained in 2010. We did staging endoscopy for everyone. And then the TORS experience, our experience has been great. Our average length of stay is just over 3 days. Surgical time, once you get used to it, the docking and getting this done, you can get out a base of tongue or a tonsura fossa with some trained hands trained hands in under an hour. Blood loss is low, and the swallowing recovery is usually in 0 to 2 days. I typically feed my patients pretty much right after the surgery. We do keep them at least overnight or 2 days just to make sure they're doing okay and their airway is okay. We had done our initial study was looking at 2-year survival, and we saw that TORS dysfunction in our patients was about 30% of the TORS, and 47 or 50% people who underwent TORS with adjuvant therapy, because we were seeing at that time that we were saving people from getting adjuvant therapy at that point in time. Dr. Manik, are we on time, or do I need to? I'll be wrapping up pretty soon.
I got another 4 minutes. Yeah.
Okay, perfect. So we learned some important lessons, and if anyone's starting these TORS programs early on, I think you have to have a team. You have to have surgeons who are learning. I think learning together with another consultant surgeon is very, very helpful. Having a trainee team is important because that's the way forward to pass this on to the next group. But I cannot understress the importance of having OR staff that can work with you, because there's a lot of issues with logistics, who's going to set it up, initial setup, prepping, stuff like that, docking. I think having a really good nursing and OR tech team is very invaluable. And at the same time, they also become a great resource for training the next group of surgeons as well. Shorter length of stay. So really, in conclusion over here, HPV oropharyngeal cancer increasing, especially in the younger adult. They do have a better prognosis. It is a reduced recurrence despite extracapsular extension. And I think de-intensification therapy is needed to prevent long-term sequelae of traditional therapy. I think there's a lot of data out there now looking at, or actually it's more interest in data about the swallowing outcomes dating back to over a decade ago, and more recently with the ECOG 3311 trial and the Orator trial. So I would highly encourage people to read that data. Robotic surgery, like we said, through a lot of the data we've talked about, can de-intensify treatment. It does require appropriate training and credentialing programs. I think our speech language pathology folks, through their research, have shown that if we can reduce the amount of radiation to the constrictors, and a lot of studies was done by Dr. Susan Langmore, who was at Boston University, and prior to that at UCSF, in University of California in San Francisco, that if you can reduce the damage to the constrictors, it can have a huge long-term impact on the patient's functionality. I think more studies need to be done about functional outcomes of TORS versus radiation. I think the ORATOR trial, which is has opened our eyes, is towards the cure-all for everything. I think all information should be discussed in a multidisciplinary head and neck tumor board so that we can reach a consensus discussion. But I believe robotic surgery, just like other minimally invasive therapies, is here to stay. We should embrace it, see how we can apply it appropriately to our patients, be honest about outcomes, and then go from there. So I think that's about it. We wrote a whole book about robotic surgery of the head and neck. There's a lot of stuff in here if anyone wants to do, including how to set up a new program and so on and so forth. Really amazing co-authors on this particular book. This is our sprawling campus at Beth Israel Deaconess Medical Center at Harvard Medical School. I welcome anyone. I'm hoping travel is going to start soon because, I sure miss it. It'll be very much more fun to be sitting together, having lunch or something like that, or dinner with these meetings. But I think we missed that. But hopefully they'll come on soon. So I invite anyone to come and visit us once things open up. But thank you very much for this opportunity. Really thank the ENT Head and Neck entire committee that organized this summit, particularly Dr. Manik and Dr. Majumdar for inviting. Thank you very much. And I don't know, we take questions on chat, or how do we do that?
Brilliant. I think there's one question. Shahrukh, there's a fantastic evidence-based talk that's really good with lots of papers and research evidences. A question: before robotic surgery, do we need to do tracheostomy, or it depends?
It depends. I think our tracheostomy rate is extremely low. I think that's where I always say this surgical judgment and selection becomes important. Obviously, if someone's coming in with a T4 tumor invading into the pterygoid with trismus, that's not a person you're going to do for robotic surgery. But we have probably just done a handful of tracheostomies over the last 10, 15 years, since 2007. So whatever that is, nearly 15 years. But I think the patient selection is important. I think too many people early on, that's what I told you in the lessons learned, is early on we were doing stuff. And then when we look back, we're like, were we stupid to think about trying to get this done through a robotic surgery? Those are the people who probably need an open operation in which you would get a tracheostomy. So I think if you can come up with a paradigm on patient selection in your units or in your communities, I think it'll make life much, much better. So yeah, we do not do tracheostomies as a routine.
Good. How would you assess a potential extracapsular spread preoperatively? Is it by a gross late ECS clinical signs like fixation or skin changes, or radiologically, or both?
So that is a very good question, because historically, when you're on our tumor board and you talk to the the neuroradiologists, they would say, "Oh, I think there's extracapsular spread," and that's why the study I pointed out to, that really extracapsular spread, when you talk to a pathologist, is a post-surgical diagnosis. Although over years we had come to this conclusion that we can detect extracapsular spread. And we've seen with HPV disease that when you go in, and I'm pretty sure you guys have had this experience as well, that you go in, you take out something that was billed as extracapsular spread, and pathologically now there's nothing. And so that is a value of surgery. That's what the message I was trying to send in the earlier slides, that is a value of surgery to give a more accurate staging of patients. I think extracapsular and extranodal extension is a pathological finding, and by definition, that should be post-surgical. But there are plenty of people that we see who are sent to our center for salvage surgery, where when you go back in time, patient was labeled with this and that HPV positive disease, and they said there was extracapsular spread, and now they're suffering from the outcomes of high dose chemoradiation, because some of our community centers go to as high as 74 gray on the radiation for primary treatment. And then our laryngologists have to deal with them. So I think this is very important. It's actually a very important question. And I hope that with time, we come back to the pendulum that surgery is an excellent tool for improving our staging paradigm. I hope that answers that question.
That's absolutely right. I think some of my friend from Birmingham, the head and neck surgeon, they also kind of reiterated case selection is important, particularly considering the Pathos trial, which is actually run by Liverpool Group. That's really, really good. Thank you very much. That's absolutely a fantastic talk. Thank you very much for your valuable time, Shahrukh.
Thank you so much, Jay. If there's no other questions, have fun. Everyone stay safe. If you haven't been vaccinated, try to get vaccinated. Thank you, Sam.
Thanks. Thanks very much. Can I just quickly ask you one question? I love listening to your talks. You're like a walking encyclopedia, and I totally love it. But this radiation to constrictor muscles, and that that is a very, very important point. Is the outcome of swallowing dysfunction after radiotherapy is often very overlooked, and I'm so pleased you mentioned it out there.
Yes. So Sam, actually, another question, just to push that a little bit forward. I know you're short with time. Another question from the surgical standpoint, which I was actually discussing with my fellows and my residents last night, literally, we just did a robotic case, is the aggressive surgical, how aggressive people can get with poor surgery. And we have to keep that in mind. Is that aggressiveness worth is there any survival benefit? And I think we're going to start looking at that, because depending on what TORS courses you go to, there are TORS courses that say, absolutely, you have to cut down to the styloglossus, the palatoglossus, you got to expose it, you got to expose the glossopharyngeal nerve. In our unit, we have not seen that. We think as long as you can get through the constrictor, get a sliver of constrictor and peel it off, get into the parapharyngeal fat, people really do well. So that's something I think we're going to look at and see if that much aggression is truly needed. And I don't think anyone's answered that question. So if anyone on this wants to do maybe a multi-institutional trial, I would love to work with you guys, because I think there's an important question for us as surgeons to evolve in time, is how aggressive is too aggressive, or at some point you're doing the same as wide open surgery, are you helping them? But the constrictors, and Dr. Majumdar, they're very skinny, they're very flimsy.
Brilliant. That's good. Thank you very much.
All right, thank you guys. Carry on. Thanks for inviting.
Thank you.
I'm going to sign off.
Thank you, Shahrukh.
Bye-bye.
Thank you.
Thanks, everyone.
Bye-bye.
Okay, Mr. Nixon is going to give a next talk, and he has kindly pre-recorded the talk, but he's also available. Mr. Nixon is one of my good friends. He's a lead head and neck consultant from Edinburgh. Is very knowledgeable, and his practice are very much evidence-based, and his talk is more about parotid. It is actually very...
Okay, hi. My name's Ian Nixon. I am hopefully recording this lecture on parotidectomy. You might question, why am I going to talk about parotidectomy? And this is aimed largely at an ENT audience at a trainee level. And I just want to share with you my thoughts about how we approach parotid surgery. Because my opinion on it has changed quite a lot since I got to the last few years of my training. And I think it's worth thinking about if you're going to be a head and neck surgeon. And many people, you don't have to do malignant work, but parotidectomy is a nice operation, and many people will do this when they qualify whether or not they're a dedicated head and neck surgeon. So if I can get this to work. First, we maybe touch on why we do parotid surgery. Well, most people will be familiar with the most common indication, which is for benign disease. Very rarely it's done for inflammatory benign disease, but it's more commonly done for tumors. And of course, the most common of those is pleomorphic adenoma. But we also do it for malignant disease. We do it occasionally for lymph nodes and metastatic lymph nodes or lymphomatous lymph nodes, and also, of course, for primary parotid malignancies. And these are really the main indications for parotid surgery. Occasionally there's stone surgery, but that's pretty rare. Now, I think it would be sensible if you're going into the exam to be aware of the European Salivary Gland Society classification, 1 and 2 being the superficial inferior, superior and inferior lobes, 3 and 4 being the deep lobes, and 5 being an accessory lobe. And I think that's a reasonable classification to be aware of, at least going in. But I don't really want to labor on this because I think about parotid surgery rather differently. Now, you've probably been involved in parotidectomies, and surgeons may have called them extended total parotidectomies. That generally means that you take the parotid and surrounding structure, skin or masseter, or sometimes temporal bones and things like that. A so-called total parotidectomy generally refers to resection of superficial and deep lobes, although because the parotid doesn't really have a nice capsule, particularly on its deep aspect, there isn't really such a thing as a total parotidectomy. Nonetheless, that's what it tends to refer to. Deep lobe parotidectomy tends to mean that you mobilize the superficial lobe and take the deep lobe. Superficial parotidectomy tends to mean the opposite, that you mobilize the superficial lobe only. Then you'll hear people talk about partial superficial parotidectomy. That tends to be where you take part of the superficial gland, but not the entire superficial gland. And then there's this other term, extracapsular parotidectomy. And really, I'm going to talk about these different variations and how there's quite a lot of similarity despite the range of names that we use. So what are we doing when we do a parotidectomy? Well, we're obviously aiming to remove disease. And as we said, this is largely done for pleomorphic adenoma. And you want to minimize the chance that that comes back. But at the same time, you want to minimize the risk of injury. Now, we would all recognize that facial nerve injury is one of the risks of parotid surgery. But there's potential injury to sensory nerves that can leave people with chronic paresthesia or pain. There's the potential for Frey's syndrome. This is gustatory sweating because of the innervation of the sweat glands in the skin rather than the salivary glands in the resected lobe. And, perioperative complications like salivary collections and fistulae that can develop after surgery. Now, if we think about how we got to where we are now, I think this is a useful way to think about why we do what we do. Historically, before the era of reliable, safe anesthesia, in a time where there wasn't electrosurgical hemostasis, enucleation was the preferred way of getting tumors out of the parotid. Generally, surgeons would make an incision directly over, and often they would use something that looks like a tiny ice cream scoop to actually scoop out the tumor in order to debulk it fundamentally, trying really to stay on the capsule and do this enucleation. Unfortunately, that was associated with high rates of recurrence. It's quick, it's relatively easy, but there's no identification of the facial nerve. And in particular, there was this problem with high rates of recurrence. And so surgeons recognized that there was interest in the histology of the lumps that were being taken out. And of course, they were pleomorphic adenoma, exactly as they are today. Now, the understanding of pleomorphic adenoma has evolved over the last century. It's well recognized that this is a benign condition. Although there is an association with malignancy, we teach generally there's about a 1% per year risk. So if you leave it for a decade, there's a 10% risk of malignant conversion. That's probably an overestimate. It's often quoted, but it's not really based on much science. Data from Scandinavian registry suggests probably it's a bit lower than that. Maybe there's a 5 to 10% lifetime risk of conversion. And you should bear that in mind, particularly when you're counseling patients about the overall risk. I find that in a young person with difficult to resect recurrent disease, you've really got to think carefully. The risk of conversion is low, but it is present. But the reason that pleomorphic adenoma is locally recurrent is because of this so-called pseudopodia. So the tumor itself lacks a capsule. And as a result, the stroma of the tumor can come out through the holes in the capsule and create these little feet or pseudopodia. And when you slice through them, they sometimes look like satellite lesions. And I think there's disagreement about whether they are actually connected to the primary or whether they're separate little lesions separate to the primary lesion. So you can imagine if you just simply scoop the capsule out, then potentially you leave these little feet of tumor and they are in a position to recur. So as a response to the improved understanding of histology, and at a time where anesthesia was improving, understanding of anatomy was improving, and as we say, histology was better understood, surgeons changed their practice from the simple enucleation, and they were really tried to start maximizing the margin that they had on the tumor resection and prioritizing protection of the facial nerve. And the idea was to produce a procedure that could easily be taught, which helped minimize the risk of recurrence. And that led to the development of superficial parotidectomy. And this really has become the standard of care, and it's important that you know how to do this if you're training in ENT. It's a reliable and safe operation with excellent outcomes. So if you're thinking about doing a superficial parotidectomy, and I'm going to come back to this image a few times, this is roughly where the parotid is. The bulk of lesions will be just below the earlobe in this kind of area. And the incisions that we use, I personally use a modified Blair incision, which is like a kind of a lazy S or whatever, down pre-tragal. You can actually go behind the tragus if there's no crease, and up onto the mastoid and down into a skin crease. Although it is also possible to do this via a facelift incision, which is thought to be cosmetically superior, but very difficult to teach somebody that. They're retracting the flap and can't see really what you're doing, which makes it, I've never really done that. But these are the workhorse incisions for superficial parotidectomy. When you do this procedure, maybe I don't need to go through this, but you make your incision, you raise a subplatysmal neck flap, and then over the face, you lift the flap over the parotid fascia. I then, once I've raised the flap, I identify the anterior border of the sternomastoid, trace the anterior surface of the posterior belly of the digastric up the way. So that's really approaching the nerve from below. And from above, mobilize the gland off the tragal cartilage. And really you're looking for the main trunk of the facial nerve then. It's somewhere below the tragal cartilage and above the digastric, and it kind of subtends an angle between the tragal pointer and the digastric. And I always think this is quite a nice bit of a procedure. You slowly dissect the gland off the stylomastoid foramen until you come across the nerve, and you use these things, the tragal pointer, the digastric, and the tympanomastoid suture in order to identify the nerve. And that's a reliable, fairly easy way to do it. You need retraction on the gland, and you'll come across the main trunk of the facial nerve, which can then be followed out through the gland without rupturing the tumor. And then once the tumor is delivered, you achieve hemostasis, which you should have been maintaining throughout, really. Most people would use a drain. Obviously there's ways of doing it without drains and fibrin glues and compression and so on, but most people use a drain and then closure whatever way you like. So it's a good procedure. It's one that you should know. It's safe and it's reliable. And it's the standard of care for benign tumors of the superficial gland of the parotid. Now, if we look at the parotid gland anatomy as a kind of schematic here, on the lateral view, I think everyone's familiar with this. The tail of the parotid can be peeled off to find this main trunk. And then you have this branching structure where the so-called pes of the gland, the goose's foot splits in two, and then they further split in two and split in two. And you have these 5 branches, classic branches. When we look at it in an axial plane, you can't see it on a CT scan. Of course, the retromandibular vein is the marker on radiology, but it trends from deep to superficial as it courses through the parotid gland. And so therefore, this is what we're talking about. This is the superficial lobe of the parotid gland, and that's what you're trying to remove with a standard superficial parotidectomy. So permanent nerve injury is rare. It's not too difficult to find the nerve. But in fact, temporary nerve injury is very common. This is probably because of the traction injury, particularly on the marginal mandibular nerve, as you fold the skin edge forward and then you're tending to be retracting everything superiorly. And certainly in my hands, about a third of patients will have a temporary weakness of the lower lip. But what you do with this procedure is you maximize the margin. It's also a very easily teachable procedure because there's nice logical steps, there are landmarks, and these are the kind of things that make operations possible. Without these, very difficult to teach procedures. So that became the standard of care across really modern medicine and surgery. Superficial parotidectomy became the workhorse operation for benign tumors of the superficial gland, but not everyone agreed that it was the right approach. There are some significant downsides of superficial parotid surgery. It's disfiguring, and it's a difficult thing to explain to a patient, but you lose a significant bulk of tissue behind the mandible. You get a dent behind the mandible, between the mandible and mastoid, because you take quite a chunk of tissue out. There's this association with Frey's syndrome, where you get postganglion innervation of sweat glands. And depending on what you believe, almost 100% of people get some demonstrable evidence of that, although much lower rates of complaint about it. Maybe, I don't know, somewhere between 10 and 30% of patients will notice that after a full superficial parotidectomy. But what I really want to focus on is the question about whether the margins argument is valid. Because what you'll find if you do parotid surgery is the vast majority of tumors will abut the nerve at some point. And as a result, the positive margin rate in parotid surgery, if you look back through your parotid specimens, almost 100% will have a positive margin somewhere, and it will be where the tumor abuts the nerve. And so even though a large margin is taken, if you think of margins as binary, as positive or not, positive or negative, or even if you think of close positive or negative, then what you'll find is that the vast majority of parotid surgeries result in a positive margin. And so an alternative approach was championed by maxillofacial surgeons, and in particular coming from the Christie Hospital in Manchester. Now, again, I've drawn a schematic here of a parotid gland, and I've put the mythical nerve here, that's the plane of the nerve. So the normal tumor will be something like this. It will be a benign tumor within the parotid, and it will tend to abut one of the branches at least of the facial nerve. Now you can see here, if you do a superficial parotidectomy, you dissect along the nerve here on the red plane, and the entire superficial lobe is as a result excised, and you get a great margin here, you get a great margin here and here, but on the deep surface, you will tend to get a positive margin. You can see this is in contrast to enucleation, where you simply cut straight down and just scoop this thing out. But the Christie argued that there was another way to do this. And yet the extracapsular parotidectomy is not an enucleation. It's an attempt to excise the tumor with a narrow margin. The way you do this is you cut through the parotid fascia. Really, you raise it flat exactly the same way as you would do for a standard parotidectomy. You then cut through the parotid fascia down towards the tumor. And in fact, you make a cruciate incision in the parotid fascia, and you fold all four sides of that back. And then you're generally looking at the tumor encased in salivary tissue. You then gently dissect around the tumor, aiming not to see the tumor at all, but to leave a few millimeters of tissue all the way around. You dissect around both sides, and on the undersurface, you will tend then to find this positive margin abutting the nerve. When you start doing this, you think, I'll never be able to find the facial nerve. In practice, what you actually find is that you don't have to cut very much salivary tissue. It tends to fall apart on you. And as a result, you're hardly doing any sharp dissection at all. And when you come across the branches of the nerve, you will see them. And so this is an extracapsular dissection. And when you've removed that, the tumor goes off for histological analysis, and you're left with a cavity within the parotid. But in practice, you suture the parotid fascia back together, and it results in a much smaller specimen, much less cosmetic defect, and indeed, much less chance of Frey syndrome, because as the postganglionic salivary fibers enter the deep lobe and course up towards the surface, they hit the intact parotid fascia and can't get through. So yeah, as I said, what we tend to do, that's where the circle is slightly off here, but we raise a subplatysmal flap, raise the fascia, you palpate the mass. We tend to make mark a cruciate incision, which is 1 centimeter beyond in all 4 dimensions the mass itself. You make the incision, you hold the edges with clips, otherwise they tend to fall apart a bit, and you dissect through parotid around the tumor and remove it with a cuff of normal tissue. And if you stick to this rule, you never divide something you can't see through, fatty salivary tissue, you cannot see through nerve. And if you do that, you will not cut the nerve. You will identify it, and in the vast majority of cases, you'll end up following a branch for a centimeter or so as you take it off the tumor. And then, of course, you do your hemostasis, close the parotid fascia and the skin. So the arguments for extracapsular dissection are that you have significantly less tissue loss. You close the capsule following the resection, which reduces the Frey syndrome risk, and you don't expose the main trunk of the nerve. So there's a number of reasons that might be advantageous. Obviously, if you don't expose it, there's less potential to damage it. To be fair, damage to the main trunk of nerve is rare after standard superficial parotidectomy. But also, if you ever did need to go back for recurrence, it would mean that the main trunk remains virgin territory if you had to go back there, because we've not identified digastric, sternomastoid, tracheal pointer, nothing like that. You dissect straight down on the tumor. As a result, it's much less injurious a procedure. It's a shorter procedure, and the vast majority of these I would do as a day case procedure without a drain. And really, it's quite a minor procedure in comparison to superficial parotidectomy. There are, however, arguments against it, and it's said to be difficult to teach. I have to say, I'm not sure that's true. People say that, and they say it's only safe in the hands of an expert. I learned from a guy in London, and he was, I think, really, truly an expert in doing this. But even in my hands, I have not found this to be particularly challenging. You just take your time. If you list it for a superficial parotidectomy, you probably give yourself 3 hours, and I tell you, this takes you more like 90 minutes. And much of that is closing the wound at the end. So you've got plenty of time not to rush and slowly, carefully take it out with a small margin. Of course, you do get a smaller margin, and there is an argument that that's associated with higher rates of recurrence. There's also a question, what do you do if you got the diagnosis wrong in the first place and it comes back malignant? Because that makes an awkward MDT discussion. So I think patient selection is important. So I would tend to favor a superficial parotidectomy for larger tumors. Now in practice, if you've got a 3 or 4 centimeter tumor in the parotid, by the time you do an extracapsular and take a margin around it, you're going to be exposing most of the facial nerve, and I think it's probably safer and less controversial just to do that straight up superficial parotidectomy, find the main trunk and trace it out. Also, if there's any suspicion of malignancy, I think that's also the right thing to do. Or if for some reason margins are critical, and I normally have the conversation with patients if they're able to comprehend the level of complexity. There will be, for example, the parotid tumor found in workup of a breast cancer, and a patient will be very aware that in breast cancer margins are critical, and they will apply the same thought process to their parotid. And so I think you need to be careful in counseling your patients and making them aware that superficial parotidectomy really is the standard of care. I go back to this malignancy issue, that if you think that the tumor may be malignant, and there's a number of ways you might think that. Obviously, if you have metastatic diseases, there's no controversy. If you have a biopsy suggesting it's malignant, again, really no controversy. But occasionally you will get suspicion based on clinical findings. You know, if you think it's tethered, if you think it's pain, if the patient reports pain, or if the biopsy is not conclusive and it says we can't exclude a malignancy, something like that. If you end up with a malignant specimen and you go back to your MDT, the question, you will always have a positive margin because you always do whatever you do, you will have a positive margin. Remember that, because the MDT considers a margin binary. And the oncologist will say, is there any more you could do? And the truthful answer is you can do more. If you've done an extracapsular, you can do more. You can go back and do a superficial. That's really a painful thing to have to do without any evidence that there's benefit in that. But that's a difficult problem. And so as a result, I think if you're worried at all, superficial parotidectomy should be your go-to procedure for large or potentially malignant lesions. So I think an extracapsular dissection is best for smaller tumors, obviously, and those ones that are nice and mobile within the parotid, or if for some reason cosmetic outcome is critical, if reduced operative time is valuable. Now, actually thinking of patients who are comorbid, although we don't do many pleomorphics in patients who are critically unwell, or if for some reason minimal tissue trauma might be beneficial. And I've tended to recommend this, for example, in patients who have chronic pain. So I have operated on a few people with chronic pain syndromes. I guess they get more frequency of scans and you pick up benign things here and there. And I think because of the minimal tissue trauma, they're less likely to have a pain response, because I do have a few patients who've had superficial parotidectomy and really find a lot of discomfort post-operatively in the long term. So one of the reasons that you might say you don't want to do this is that in ENT, we say you can't. The extracapsular dissection is not an operation that's regularly taught in ENT. And I didn't even hear about this until well after my exams when I was doing fellowship training in London. But I'm going to make the argument that even though we say we don't do this, in practice, we kind of do. So if Prof says you can't, you don't necessarily need to listen to him. Because probably Prof does it himself, but doesn't admit to it. Because if you think about the fundamental difference, superficial parotidectomy is basically finding the main trunk and following it and excising the superficial lobe, whereas extracapsular, you make no attempt to find the main trunk, you simply excise the tumor. But I want to look at some examples of parotid tumors schematically and think about what we actually are going to do. So here's a central mass, right? And this might be the typical pleomorphic adenoma. And in this, really, you have these two options. This is the same diagram on its side that I showed you in the earlier slides. And you have these two options of going in and doing an extracapsular versus a superficial parotidectomy. So you choose what you think is reasonable. But superficial parotidectomy, let's remember, really the definition is that you remove the entire superficial lobe. Now, let's take this example. This is not uncommon to see a tumor hanging off the inferior border of the parotid. Often you wonder if these are actually submandibular. Now, there is almost nobody who would say that they would go and do a full-blown superficial parotidectomy. Because if you think about the practicalities here, if you make your modified Blair incision, as we said, you raise your flap and you go down and find your digastric. By the time you've found your digastric, this tumor is hanging in the wind and it's actually almost out. So the majority of people here wouldn't go for, it's hard to believe that removing the superior tip of the superficial lobe, what do we call that? Level 2 in the European classification. That does the margin at the top end of the parotid matter in this that's hanging off the bottom? Because you're not going to take, for example, even if it abuts this submandibular gland, you're not going to take the submandibular gland as part of this. You're going to accept a positive margin on the edge here. And most people would tend to make a submandibular incision, find the marginal mandibular anteriorly, trace it back, fold the tumor off, and say that that would be the retrograde approach to a low parotid mass. Even though when they lecture on it, they would say, oh, you always do superficial parotidectomy for superficial tumors. let's think about one that's hanging off the back of the gland. And when you do these operations, again, we think of our modified Blair incision, and then you're trying to get down to the sternomastoid. And in doing so, if this is superficial to the sternomastoid, as the tail of the parotid is here, again, the tumor's out before you've dissected anything. And so this concept that you're going to go down and find the main trunk, most people wouldn't do that because the tumor's already out. We're not going to sacrifice sternomastoid for a margin. So why would we sacrifice the rest of the gland? And although that's neither of these are classic fascial opening extracapsular parotids and closing, we are not found the main trunk of the nerve, despite the fact that people who do this will often say they would not do an extracapsular approach because you have to find the main trunk. Now, what about the very anterior? So again, this is a kind of controversial thing, but you're not going to take masseter. Nobody takes masseter. You're not going to do an outer rim mandibulectomy for a pleomorphic adenoma. What you're actually going to do is you're going to raise the flap here. You're going to follow it anteriorly. And probably you're actually going to look for the buccal branch at the anterior aspect, and you're going to dissect this thing off the buccal branch, because it is hard, again, to believe that sacrificing a huge chunk of parotid for what is really an accessory parotid tumor here is worthwhile. And so, of course, we also see these deep lobe tumors. Now, people have different opinions about this, but here we're going to follow the nerve, we're going to fold the superficial lobe forward, and then you're left with a tumor in the deep lobe, which abuts the nerve. Inevitably, the nerve is dissected off it, the tumor is delivered, you get very little, if any, margin on the deep aspect of the parotid, and then you're left with the question, what do you do about the superficial lobe? And many people will fold this back in the belief that that will reduce Frey's syndrome and minimize cosmetic defect, and you're already got a positive margin on the nerve and on the deep aspect of the deep lobe. So the reason I show these is that I think that although if we go back to this standard one, there is this in some ways is the most contentious one, because you could do either a superficial parotidectomy or an extracapsular dissection. But in practice, what most people will do is they won't do a full-blown superficial anymore. They'll find the main trunk of the nerve if they're going to do a kind of facial nerve approach to this tumor, and they will trace it. And generally, you'll find this will be on the upper or lower, normally lower branch of the facial nerve, and you'll be able to sacrifice only one subsection of the parotid in doing a partial superficial parotidectomy. And that's largely what the standard of care has now become, excision of part of the superficial lobe. So surgeons are already accepting that you don't need these huge wide margins, even though superficial parotidectomy in the textbooks is the standard of care for benign parotid disease. So my approach to this has changed, and it changed really because I was introduced to this concept of the extracapsular dissection. My colleagues tell me that whoever takes over my job when I retire will be taking out my recurrences, and we'll see if that's true. But certainly the Christie published 1,000 consecutive cases with no higher recurrence rates. Recurrence rates are very low, less than 5% over the next 20 or 30 years. And really there's no evidence to suggest that superficial parotidectomy, it reduces that. There's bias in series and so on, as I've discussed. But I think at least if you're going to embark on a career in parotid surgery, you should be aware of this as a technique, and we don't particularly teach it well in ENT. And so, well, as I come to summarize, and I know we'll take some questions, that the approach to parotid surgery has evolved, and it's evolved partly in line with anesthetic improvements and electrosurgical improvements, but also with our understanding of histology. I think if you're going to approach parotidectomy, you need to be adaptable. There are conservative operations like extracapsular dissection, retrograde approaches to the nerve in inferior and anterior tumors. You might even accept not identifying the nerve in small tail tumors. There are standard approaches The superficial parotidectomy is a great operation, gives you a great margin, and it's very difficult to be criticized for it. You can be radical when you need to, doing extended parotidectomies and so on, but we didn't really want to talk about that today. I just wanted to talk about the standard approach to parotidectomy. We need to be aware that there are risks to the facial nerve, risk of phase syndrome, cosmetic problems, numbness and pain can be a problem post-operatively, and these in some ways relate to how you approach the parotid surgery in the first place. And we aim overall to minimize the risk of complication, but also minimize the chance of recurrence by doing a good parotidectomy.
Thank you very much, Ian. That's really a fantastic lecture. I really liked your schematic diagram. I think it's a very artistic lecture, that's what I would say. Even parotid surgery, I consider is a kind of a design surgery. You need to tailor your approach or operation according to the patient and disease. I have no objection for extracapsular dissection. I think there is a lot of evidence there. There are some questions in.
Sure, I see that one coming up about whether there are risk factors for formation of silacele. Right. Yeah, you see that? I think something like 10% of patients develop a salivary collection after surgery, and that can become a fistula. And I don't know offhand if there are known risk factors, but I think this is one of the things I'm starting to see with extracapsulars is that you leave a lot of parotid tissue behind because you take a lot less out. You know, if you do a radical parotidectomy, a patient's never going to get a silacele because there's no salivary tissue left. Whereas if you do a large, if you do a small resection and leave a large part of the native parotid there, then I think you're actually at higher risk. I think the worst one I've ever had was I did with Panos actually. And I think we may have tied off the parotid duct. And I think one of the reasons you get silacels is that within the parotid, you get edema following the surgery. And that forces close the salivary ducts. And then gradually, as the edema settles, the ducts open, and then it can flow again. So everyone gets a bit of a collection, but it doesn't. As long as you've got a decent drain. Do you remember that one, Panos?
Yeah.
I think that's probably one of the reasons. But the good thing about silacels is they always eventually give up and settle spontaneously. Is Jenny going to tell us the answer?
No, Ian, I think we're at cross purposes here. Sorry, Jai, I never got the Zoom meeting link, so I'm piggybacked on information from Jenny. All I was going to do was firstly congratulate Ian and his COVID haircut. Good effort.
Thank you very much.
And then secondly to say, secondly to say, I guess we've been doing it for about 6 years now. I think it's immediately prior to coming to the QE, and I haven't had any problems with long-term silacele in my personal practice. And then I guess I know that you had said that your successors would, in the view of their critics, carry on taking out recurrences, etc., after your retirement. But I mean, my point is that we don't know what causes benign parotid tumours, do we? And if you leave pretty much 100% of the parotid behind, which is good for the individual in terms of lessening the impact on quality of life and contour of the face is better, chances of facial nerve injury are reduced, that they've still got lots of parotid in which to get another tumour. And it's surprising maybe that the incidence of second benign parotid tumours isn't higher. It's really encouraging that it's not. But I think there's a perfectly fair answer there, and it's not related to your surgical technique at all.
Sure. And there's a very well recognized recurrence rate after superficial parotidectomy anyway. And I think when you when you've done a few, you start to get a feel for just how much less morbid these are. And they're not suitable for big or suspicious tumors, but for small tumors and selected patients, I think they do have a role. Do we have any more questions? Yeah.
Can I ask a question? When sometimes you have a pretty big cavity there and you bring the fascia forward to close it, and do you ever put any kind of cloth or anything to kind of make the cavity, to reduce the dead space, to prevent sialosyl or any synthetic materials? Does anybody ever use that, or try to suture the parotid together? Because it's quite flimsy to suture the parotid together underneath the fascia. The actual parenchyma, I find it very, very flimsy.
After a superficial?
After an ACD, an extracapsular dissection.
Well, I try to leave the capsule intact and suture that back together. And I make this kind of cruciate incision and then put an artery clip on each corner, really just so at the end you can go back and find them. Otherwise, they disappear. I personally haven't used fibrin glues and so on. I know someone who's a big fan of them, just slightly to the north of me, who probably has something to say on the use of fibrin glue in parotid surgery.
That's true. I absolutely allow the fibrin glue. Not only me, there is a systematic evidence review as well as meta-analysis clearly shows there's a lot of benefit. It's cost effective and with a high patient satisfaction, and it enhances more day-case surgery. And for Pana's question, sometimes I do make a split incision in the sternocleidomastoid and just pull it medially probably to the cavity. So that it works. But there are reports you could divide the lateral head of the digastric, detach it, and just make it kind of rotate it on one flap. But I don't find it that's very useful, and patients don't mind from our centers. I'm not really sure about other areas. Brilliant. So that's great. Thank you. So we'll have a short break, 10 minutes coffee break. Then after that, we have 3 more talks, including my talk and Jennings, as well as Shine. Thank you.
It's going to be a long day, Jay.
They're catching up to a few minutes.
Are you running a bit late, are you?
Yeah, we are just trying to, we are shorten the coffee break for 10 minutes.
Yeah, it's difficult, isn't it? Because I have been in Shahrukh a few times and he could talk forever. And he has so much to share.
Jenny, are you around?
Yes, I am. Can you hear me?
Great. Do you want to try and share your screen?
Yes, I will try my best. Okay. Share my screen. So is that okay?
Not yet.
Oh. So I've got an option of desktop 1, whiteboard.
Just go for a desktop 1.
Desktop 1, okay.
You can see your screen.
Can you see my slides?
And we need to just put slide or slideshow.
Slideshow. How's that?
Perfect. It works.
Is that okay?
Fine. Do you have any movies or voice? I think it works well. That's fine.
Sorry, I didn't catch what you said there.
Do you have any kind of movies inside as well?
I've got one video.
That's fine. Is it with the voice?
No voice. It's a silent one.
That's fine. That's good.
Perfect. Thank you.
Stop sharing the screen. Yeah.
So I'll stop sharing just now.
I think after my talk, yours talk, I think.
What do I press stop video?
It's Don't worry, I'll disable because I'm going to.
Can you disable me? Stop share. Oh, sorry. I just saw the button there.
I've done it for you.
Thank you.
Welcome back. So I'm going to talk about management of early laryngeal cancer with a particular focus on laser surgery. So here we're going to discuss about some management options for early laryngeal cancer and techniques of laser surgery and some evidence. Why it is important, transferal laser surgery or laryngeal cancer? Nearly 2,400 patients diagnosed with laryngeal cancer every year in UK. 800 patients die of the disease per annum in UK alone. So laryngeal cancer is one of the disease burden for head and neck. As we can see, there is a clear distinction between early laryngeal cancer and advanced laryngeal cancer. We have discussed about the glottic cancer staging. The clear distinction is T1, it's involving one vocal cord, or maybe one, but it can be both vocal cords, that's T1B. T2, it's easy, a little bit going above and below, subglottis or supraglottis. And T3 is important because it's vocal cord fixation, radiologically a paraglottic space invasion, or inner cortex of the thyroid cartilage. That's again, it's important finding. T4 is advanced with particular extension to the strap muscles and cricoid cartilage or thyroid cartilage through and through. So we have three distinct management options for early laryngeal cancer. So the bottom one is actually in Lanzarote is a natural volcanic oven, which is helps with to kind of roast the chicken within 20 minutes. This is electric, and this is Scottish wooden frying or roasting. But laser surgery is economical, convenient. You can repeat as many as time. It needs a unique skill set, but it can provide a superb outcome. Radiotherapy is equally good, but it is a one shot. It's long, like 5 to 6 weeks duration, and the side effects are still there. And partial laryngectomy, it is again unique skills with a particular focus in some centers, and eventual laryngeal preservation also high. The viewpoint is very important. I feel sad sometimes why we are not doing enough laser surgery for early laryngeal cancer. Why are we pushing too many patients into radiotherapy? Particularly, I'm interested in this because laser is one of the important tools, whether it is developed or developing countries. The viewpoint is very important. So let's talk about a few things. I mean, I'm just going to initiate some polls and to see whether you can answer this poll. You can answer the poll by just clicking the button, just to make it more interactive. You can press the button. What stage do you think? Is it T1 or T2? I think that's the kind of main question. So that's good. So pretty much people are answering. The results showed it is actually majority of them said T1. Some of them said T2. Some of them said T3. Actually, all of them are T1 cancer. For example, this is actually diffuse T1 lesion, but slightly bulky. This is very focused, and this is again kind of superficial. All of them are particularly T1 cancer. And this is actually pretty much Still it's a T1, but particularly it's involving the anterior commissure. See, it's a varying degree. It's very superficial, it's very diffuse, and this is actually bilateral lesion. This is actually anterior commissure, and this is proper anterior commissure. This is actually superficial. There are different types of anterior commissure lesions. So this is actually slightly bigger lesion. It's involving more than one subsite. You can see the anterior commissure a little bit, and this is ventricle, and sometimes it's a cerebral subglottis. So this is clearly immobile cards, bilateral lesion. This is actually T3, particularly on the right-hand side, which is actually is a radiorecurrent T3 tumor. This is actually a large lesion, T4. Okay, so let's talk about laser anesthesia. There are different way of giving anesthesia for laser surgery. The whole point is having a good anesthetic team with a clear goals and understanding is crucial for successful laser surgery. You can provide laser surgery with a tubeless field. As you know, laser can cause fire, which is actually a dangerous thing. And so you must provide laser service by giving laser safe endotracheal tubes. And also it can damage your eye, and also it actually damages patient's eye as well. So you have to use appropriate eye protection, depends upon the laser. CO2 laser is the kind of still as a gold standard laser for transoral laser surgery. And for anesthetic, you could use a tubeless field, for example, Hand-Sacker catheters or a tubeless field with some other type of catheters can be used as well. There is options like OptiFlow, which is debatable, but we have successfully used for our transoral laser procedure as well. And we will just go through a few cases and we'll make it more interactive. So this case actually, you can see the patient is undergoing surgery. On the right-hand side, the biopsy-proven carcinoma in situ. The left side, modified moderate dysplasia. So this case actually treated by, you could offer a radiotherapy for this patient as well, but we have treated with carbon dioxide laser. Use actually accublate a setting, which is actually it's a straight line, probably 2 millimeter length. I prefer that because it provides a scarless surgery without charring. Because the accublate setting, designed the laser runs between the straight line. So if it is acute spot, you may have to kind of move it to avoid damages to the deeper structure. You can also rotate the angle. That makes it like a kind of vertical cut, and that gives you a better ergodynamic angle to do the operation as well. So it does take 10 to 15 minutes, day case procedure. And this case, we used laser safe laryngeal tube, and no damage, no scarring. This is actually type 1 cordectomy, but sometimes on that side, type 2 cordectomy. So it does give a best voice outcome. European classification, it is a basic and also easy classification. Type 1 cordectomy involving epithelium. Type 2 is a little bit deeper in the Rinke space. Type 3, part of the ocalis muscle. Type 4, probably full ocalis muscle. Type 5, if you extend to the anterior commissure or subglottis or arytenoid, it's called type 5 cordectomy. This is example of type 1 cordectomy. You're taking the superficial lesion, and you can see how it heals up in 6 weeks or 8 weeks time. It heals up like with a normal tissue. because that's why the techniques and also the laser machines are very important. If you do gentle scarless surgery, the vocal cord heals beautifully. This is type 2 cordectomy. You can start seeing the muscle, but I haven't taken the muscle off. This is type 2 cordectomy. This is actually type 3 cordectomy. You can see that. Even though I say type 3, but actually I started here as a type 1, then progressed to type 2, then gone into type 3 here. So you can't just say I've done type 3 throughout. So it's a kind of cutting as a shallow. And it's actually, even though it looks bad on the anterior commissure, you can see how it heals up. If you preserve the mucosa on either side, it heals beautifully. And I can bet that even after radiotherapy, because nobody looks at these things after radiotherapy as a surgeon. So you don't really see how they're kind of post-operative, post-radiotherapy laryngology pictures. This is case 2. The treatment options are, again, transoral laser surgery or radiotherapy. I feel, but most of the people actually would prefer radiotherapy. Maybe we'll ask what the others' opinion. How do you treat that case? People are voting. Sorry. Sorry, I lost my. And share the results. Actually, most of them said transoral laser surgery, and some of them said radiotherapy as well. Yes, that's good. I'll stop sharing. Okay, that's good. So what did I do? This case, I did a transoral laser surgery. You can see clearly, starting the type 1, type 2, here type 3, went all the way up to the anterior commissure. And that's how it healed up after 6 weeks. But to be honest, even after radiotherapy, probably you'll get the similar results as well.
For my voice box, and I'm able to talk all right, and no problems at all with it. Very happy with it, in fact.
So transoral laser surgery, especially for early glottic cancer, it can provide a good oncological outcomes. The anterior commissure is always a debatable area. I probably disagree with the general consensus about the anterior commissure. I always feel the anterior commissure is actually a bigger area. It's a larger area. It has got a 5 to kind of 8 millimeter. Are we talking about full entire length of the anterior commissure or entire depth of the anterior commissure? That lot matters. Just some blind blanket things, anterior commissure involvement, I personally don't agree with that. And this one is case 3. It's a bulky T1 lesion. You can see I did transoral laser surgery. I'm just describing the technique. It's this sort of cases, CO2 laser can give you a better outcome. You can see this lesion involving the superior, medial, and inferior surface as well. And the palpation of the lesion is very important. That gives you a good feel how much you have to resect. While doing these operations under microscopes, you can actually clearly see the tumor areas and non-tumor areas. Or sometimes, even when you cut with the laser, if that cuts through like a kind of butter without charring, that itself tells you you're not in the tumor area. If you're cutting through the tumor, that charts because of the CO2 interactions with the tumor. So it actually gives you, you can see that after removal of the lesion, we've done the 6 weeks post-op look, but I don't routinely do the 6 weeks post-op look for most of the cases. But if I think this tumor is a little bit tricky or large, then I will try and do the 6 weeks post-op look.
I feel fine, yes.
Is your voice?
It's still a wee bit gruff, but it's...
it's fine.
It's fine, yes.
Okay. Your swallowing is all right?
Yes.
Okay. So this is another case 4. We were discussing the front first. This is actually type 2/type.
I've been here for my operation in July, I think it was the 20th, and I had the laser op done and the lump removed, and then back in again for the second look just to see what's there, and then later on about another 6 weeks I think I'm back in again for another look, and I think that's it. Yeah, we're fine. Yeah.
At the end of the procedure, but actually when you look back, look after 6 weeks or 8 weeks, it does heal beautifully. In fact, especially for elderly patients, it just tends the cord, and actually it is a treatment for first biophonia, to be honest. Their voice actually becomes more stronger. This is actually a tricky case. It's a diffuse dysplasia, and that's where we have some guidelines. And still, even these cases could be treated with transoral laser surgery and risk reduction. But radiotherapy is actually tricky if it is for severe dysplasia. Or carcinoma in situ is okay, but mild and moderate dysplasia, risk reduction is a key treatment. After laser surgery, we use a cucumber specimen. It actually helps to find the margins. For example, if the tumors are involving this area, then you can go back and remove that part. That actually helps to preserve the vocal cord and the function as well. So understanding the margins about the laser, I don't believe the margins. And also there was a nice talk in the back. Laser surgery margins doesn't matter because the laser surgery principles are different. This is the cutting point of the laser, you can see it creates a V-shaped defect because the laser coagulates. So the margins, even if it is positive, still we are talking about 2 to 3 millimeter, you're away, those tissues are charred. So second look is most preferable, or patient side biopsy is more kind of reliable. So this is actually multiple spots. You could argue that this patient could be treated with radiotherapy. Actually, yes, that's one of the options, but actually this is treated by transoral laser surgery with type 1 cordectomy. You can see, just use your butter knife and slice it and it heals up. And this is the second look. You got something in the scarring that was actually a granulation tissue, and then we excised it. That's where we are getting more and more difficult cases. This is actually NBI, sometimes useful for this type of cases. You can see the corkscrew appearance. And this lesion actually starting from here and going all the way and going along the medial part of the vocal cord on the right-hand side. And there is something on the left-hand side as well. So this case, actually, I did do laser surgery. Then we did it in the 2 stages on one side, and then I went back and removed that one on the other side. Again, you can see that that's the first operation, then come back. This is for the second operation, and we have taken some biopsy from the scar tissue. It does produce this webbing sometimes. Yes, actually, there was a lesion 2 years down the lane underneath the webbing. That's a difficult thing to correct it. Then that lesion was excised.
So this is my 4th operation to deal with precancerous growth in my voice box. I've decided against radiotherapy. I prefer to have the potential laser treatment, and my voice has plateaued over the last 6 months. Hasn't gotten any worse. It probably hasn't improved any either. So that's where I am just now.
This is my fourth.
So after that, actually, I have excised that and divided the scar tissue with a cold steel. And then after that, his voice is a lot better, but I haven't got his post-op voice. This is case 8. Probably how to ask some polling for this particular case. What do they think about treating this patient? Shall we give radiotherapy or laser, or should we do laryngectomy for this patient? It's staged as actually T2. So interesting. So people are still voting. Right, okay, I'll we'll share the results. You can see the results. Majority voted for radiotherapy. Some of them voted for laser. Actually, a few of them voted for laryngectomy. That's too much, definitely. This case actually, it's almost kind of a little bit deeply infiltrating in the entire cord, anterior commissure. You can see the dynamic view, but there's no subglottic involvement. This is actually treated by transfer laser surgery. This is actually a close-up view. If you look at this very carefully, and I have preserved the mucosa here, and I have partly cut the ocalis muscle here. Still, there are muscles left underneath. Again, same here. And even I went back to the other side of the card, and this is what I talk about anterior commissure. It is a large area. It is not a small area, and it is a 3-dimensional area. Unless you understand this principle, you always kind of hesitant to work in the anterior commissure area. I always explain or tell everyone, you have to use your otological principle while doing laryngeal surgery. You need to have 3-dimensional knowledge. So it does look bad, isn't it? This is what actually 8 weeks post-op for this patient. You can, that's a pre-op picture, how it heals up. It does heal up beautifully. That's his actually.
Just been in for a scope to check my voice. 12 months after the last one. Voice is going really well. I work in the gas industry, also a football coach. Voice has improved greatly with that, and I enjoy coaching again.
So that's the best voice you can give, and I can compare that with the radiotherapy as well. In fact, I can doubt that radiotherapy can do that kind of voice in that area. So this is another case. What we have discussed earlier. I'm just showing all the cases. This is anterior commissure lesion growth. Someone kind of biopsied it and first sent it to me. And I did this after. Sometimes you get kind of more confidence. You started doing cutting the corners, like instead of doing 2-stage procedure, I started doing 1-stage procedure. Why should I bring this 92-year-old man twice? So yes, it causes stenosis. You can see the length of the anterior commissure become longer.
Transmission unit. The materials that I got for the clutches were faulty, and I had to repair the whole thing myself out of reusable material which was lying in my workshop.
Wow, that's nice.
So there you go, you see.
Are you happy with your voice now?
Yes, I'm happy enough with it now. I've lived a long, long time, and I've shouted a lot in my day.
Uh-huh.
But maybe time that I didn't shout so much, perhaps.
Okay.
What about that then?
Great. Brilliant.
That's why I don't trust this the webs. Are we treating the photos? Or are we kind of actually looking for the voice quality and the other cancer removal? But if you worry about the web, it is actually, but actually it doesn't really affect the patient by outcome measures. this is another proper anterior commissure case. I'm sure half of the people would want to give radiotherapy, but again, I offered both, but patients actually preferred a laser surgery. And this is actually, again, in one go, I started resecting both with anterior commissure on both sides. And actually,
I have been diagnosed with cancer in the voice box. Today I had my first laser operation to remove one side and the middle part. To me it's been very, very successful, although I shall return in 6 weeks' time to do the second part. I feel good. I feel my voice is returning already, and I'm glad I have done this.
But having said that, I don't advise actually voice rest. In fact, I encourage them to speak immediately after the operation. I have a feeling there is a myth involvement in like a voice rest for 48 hours or 2 weeks. I just encourage them to drink plenty of water and normal speech. Sometimes I give anti-reflex medications as well. And he's...
Afternoon, hello. I am back here again at Nine Wells Hospital, looking forward to my second part of my laser treatment.
So that's what has happened. We resected it. That's actually, then there is some kind of tissue there, and I re-resected it. It went on like that for 3 years. Then there was something going on again. Then I did resect. I thought of sending him for a radiotherapy. But actually we resected with the laser as well, and that looks really bad, isn't it? So then he went back again. Then actually that was actually granulation tissue. So what is the research evidence for a T1B cancer? The T1B cancer, there's not much evidence, only the Canadian study, which clearly shows actually T1B cancer, that is anterior commissure involvement, it gives a better voice outcome. With the laser surgery can give a better voice outcome and also good curative things. And this is a recent systematic review and meta-analysis of the T1 glottic cancer outcomes, which clearly shows TLM is superior modality in terms of overall survival, disease-specific survival, and laryngeal preservation. It contains 1,200 patients. That's one of the best evidence. So even the ENT UK recent guidelines for a T1 cancer, there's a push towards offering transoral laser surgery, not offering radiotherapy. And because based on this cost. So let's ask the poll people which one they think, which one is expensive, which one is cost effective. You could answer the poll. So who thinks laser surgery is cost effective? That's brilliant. Okay, I think I'm glad I got the right answer. Laser is certainly cost effective, and 95% people said it is cost effective. So it's clearly, it's a 623 from UK standard, and so radiotherapy is nearly 2,600 pounds. So it's almost all the cases can be treated with a laser, whether it is a bulky lesion or it is a non-bulky lesion. You could argue this is a bulky lesion. The bulk is because due to exfoliative growth, but the vocal cord is still there. So it doesn't mean you're kind of removing too much. And this case was actually removed by laser. Once you remove that, still you see the vocalis muscle underneath. So it is not actually a bulky lesion. When you're, that is the point. See, you can see underneath, and there is a nice cleavage between and the tumor phase. Okay, so this is the case I think we discussed in the morning about management of salvage cancers like T1 or T3 recurrence. This is actually a 92-year-old lady who had a T1 tumor treated by radiotherapy, then came back 2 years down the lane. It's actually T3 tumor. This is 92, wheelchair bound, and the options are, I think it's not showing up for some reason, but that's okay. So that case actually, it's a shame it's not showing up for some reason. It was actually treated by transoral laser surgery, which is a type 5 cordectomy. The other option is total laryngectomy, but still that doesn't suit in terms of rehabilitation for a 92-year-old wheelchair bound. Yeah. Okay, so we're coming to the end of the talk. For a transoral laser surgery, you need to have a good team, particularly good anesthetic team, laser safety officer, and you have to develop unique skills. For that, you probably need to go for some training and some cadaveric courses and the laser safety courses. And those are the important basic things to do the laser surgery. So we do run a laser course in Dundee. I think probably this year, certainly we will do that one. I think I come to the end of the talk. Any questions? I'm happy to answer. Good. I think I've caught up some time, so good. There's one question is from Maya. Do you think there's a room for further laser technique advancement to deal with more complex cases in near future? Yes, that is certainly it is possible, even for T2 and to some extent T3 cancers. In some countries, they do treat with a T3, and I would strongly advocate. But in UK, is T3 cancers are still treated with radiotherapy mainly. But there is a role for these cases, especially for a salvage cancer setup. I certainly agree with that. T3 cancers, the voice quality is not as good as the radiotherapy. But you have to think about the laryngeal preservation as well. Brilliant. Okay. Thank you. That's great. I think we will move on to Jenny's talk. Jenny, do you want to share your screen? Brilliant.
Hi, I hope that's okay and you can see my screen.
Absolutely fine. And the next speaker is Dr. Jenny Colery. She's one of the dynamic ENT head and neck surgeon who actively promotes outpatient interventional work, which is actually very important in this part of pandemic when there is active reduction in the operating theaters because of increased proven mortality and morbidity due to the COVID and also acquired nosocomial infections. Thank you very much, Jenny, for your time and effort.
Oh, thanks, Jay. Thanks for asking me to talk. And it's lovely to be able to speak to you all about outpatient biopsy in head and neck cancer. So I know we're getting towards the end of the day. and I'll try and keep this as brief as we can. So this will be the outline of the presentation. We'll start with the rationale for outpatient biopsy. We can discuss intraoral biopsies because we really need to start somewhere with this. Then we move on to outpatient endoscopic biopsies, how we can improve our hit rate with those. Then we can look at cancer pathways. I'm very keen on trying to improve cancer pathways, and we can look at the impact upon waiting times. And then we can look at any sort of future or next steps. So if we look at the guidelines available for taking an outpatient biopsy for head and neck cancer as opposed to doing a general anaesthetic panendoscopy, there are two sort of main documents in circulation, and those are the ENT UK guidelines in 2016 and the BANO standards document, which was produced just last year. And neither of these documents are particularly didactic in saying that you must have a general anaesthetic panendoscopy to diagnose your head and neck cancer. And then in the UK guidelines from 2016, it really just suggests that panendoscopy is only for symptomatic patients or those with a significant risk of a second primary tumour. And the BANO standards document suggests that there should be the facility for all patients to undergo EUA. And there's many cancers that are traditionally biopsied in outpatients. For example, oral cancer is mainly biopsied by local anaesthetic biopsies, but we're interested in other biopsies. We're interested in looking at tonsil biopsies, tongue-based biopsies, supraglottic, glottic and hypopharyngeal biopsies, these ones that traditionally were associated with panendoscopy. So the next document to mention is quite an important document, the Scottish Health Technology Group. And this was published in 2018, and it asked the important clinical question: what is the clinical and cost effectiveness of outpatient biopsy for diagnosis of suspicious lesions of the larynx, pharynx and tongue base? And at the time, the Scottish Health Technology Group did a very robust evidence review looking into this, and they also did a type of cost analysis called a budget impact analysis, and that suggested that this was a very safe, good way to diagnose patients, and it could also be cost effective. So I suppose at this point in time, I'd like to give a disclaimer that I'm not completely opposed to panendoscopy, and in fact I'll do this several times, and there's certain areas that I think a panendoscopy is always going to be necessary and is a very important diagnostic tool. And although this isn't the best picture, it's quite a bulky laryngeal surface of epiglottis picture, that area is very difficult to get to with flexible biopsy forceps. And this is a true glottic lesion. But again, I quite like to have a look at these under general anaesthetic because it's good to be able to truly assess those before you attempt laser resection, as Jay's already covered. So when you begin taking outpatient biopsies, I think a good place to start is the tonsil. You don't need any endoscopic special biopsy kit to do this. You can just get them to open their mouth and have a pair of forceps. So this is the easiest way to start to biopsy patients in the outpatient clinic. How I do this and how we do this at our clinic is we use chlorphenolcaine spray and then use a dental needle and syringe to infiltrate the area once it's been sprayed up. And it really helps to have a good pair of oral biopsy forceps. And these pictures show a disposable pair of oral biopsy forceps that we have at our clinic, and they're made by Chef Med, and the outpatient staff can just order them, and they take good little biopsies from the tonsils, and we've got a very good hit rate with those. Endoscopic biopsy is probably the next step in this pathway, and you can see our stack that we use in clinic. And it's really an excellent stack. And if you can see my arrow, this is the stack, and you can see the tiny little light box that we had before. So the stack for us has been a massive step up in how we can both visualize and biopsy patients and outpatients. And obviously in the post-COVID world, you've got to do all this with your PPE on, but it's still entirely possible to do this. And I do think there's a difficulty gradient when you're taking out patient biopsies. So I think it's easiest to start with the tonsil and then move on to the tongue base, because we're starting to bring in endoscopic equipment for this, supraglottis, and then getting into the true glottis and the hypopharynx can sometimes be a little bit trickier using the scope. And one of the main things that I really have to highlight is getting patients comfortable before you begin. And I use normally chlorphenolquine spray into a patient's nose before we begin, and sometimes into their mouth as well. But after doing that, I would use 4% lignocaine. And this is the same strength of anaesthetic that's used by anaesthetists when they're doing a weak fibre optic intubation. And you can also see this atomization device. Again, it's quite cheap and easy to order at outpatients. But the good thing about this is it's entirely malleable. So you can draw up the local anaesthetic in the syringe, and you can bend that into to either their tongue base area or their glottis, and really get the local anaesthetic over that area. And it helps just to do that before you start to scope them and the patient's already very comfortable. And you might wonder, well, the endoscopic channel of the laryngoscope has a channel that you can squirt anaesthetic down, but I actually prefer to use this beforehand, because when you squirt anaesthetic down and then you put your biopsy forceps through, you sometimes just continue to push little bubbles of fluid out of the scope, and that can just impair your view a little bit. So I try to get them as comfortable as they can before they begin. Just to go back to another set of biopsies that I think are really easy to do without using any fancy equipment. You can biopsy nasopharynx tumours very, very easily at outpatients, and you can borrow some laryngeal biopsy forceps from theatre. You don't need anything endoscopic for that. You can use a rigid nasendoscope and just use a pair of long forceps. Or if you're very keen, you can use the endoscopic biopsy channel endoscope to pass the flexible wire biopsies along, but it's very easy to do that without any extra special sort of fancy kit. So if we want to do an endoscopic biopsy, really the main thing I have to hammer home is you must ensure that the patient's really comfortable, and it's good just to do that before you begin. Another thing is at clinic, you need 2 people to do an endoscopic biopsy. So one person to navigate the scope and the other person to feed down the flexible forceps. And before your assistant begins, I usually, depending on who it is, get the person to open and close the forceps a few times and just make sure that they are happy opening and closing them. I usually inform the patient that we need 4 to 5 samples. Because sometimes you can just catch a superficial part of the tumour, but you really need to get into it quite deeply to ensure that you get a malignant diagnosis from it. And I tend to try and biopsy the same area repeatedly as well. So if you take off the surface of a lesion, just keep biopsying down the same hole as much as you can, because then you'll really get hopefully a diagnosis from that sample, and you won't need to arrange any repeat biopsying. When you take out the wire forceps from the endoscope, it's really helpful to have a needle nearby to get the sample out of the forceps, because as you know, it's really only a 2 millimeter biopsy forceps that we can fit down the endoscope. So you really want to be able to have a needle to scrape the sample out of the biopsy forceps. And very importantly as well, have a bowl and a drink of water for your patient, because they're going to want to spit out afterwards and they need to do some gargling and things like that. So I hope this video will work. So this is one that took at clinic yesterday, and you can just see down here that there's a tumour in the tongue base here, and it's got this sort of central kind of, if I ever hold the camera still, sorry, there's a sort of central of necrotic area. Now, I don't really want to biopsy that, because that's just necrotic slough, and I don't think that will get me a diagnosis. So then we get the biopsy forceps coming in, and I'm still looking about for something at the edge of the tumour that I can get that will hopefully give me a diagnosis. And this area here looks like more viable tumour than the sort of central necrotic area. And I just keep the forceps close to the endoscope so that I can really drive that into the tumour. And for areas in the tongue base, I try to drive the endoscope into the tumour. And I think that's the best and easiest way to get a good sample. For areas on the glottis or the epiglottis and the undersurface, I sometimes will advance the biopsy forceps further because you can't really drive the whole endoscope into that lesion, because you'll make the patient cough a lot and maybe even be sick. So that's really best avoided. So, but if you can, just try and put the endoscope into the tumour as much as you can so that you get a nice deep sample from it. So moving on, do patients tolerate outpatient biopsy? Well, our experience in Glasgow certainly is that yes, they do. They tolerate it very, very well. And if you look at the literature, the abandonment rate of the procedure is less than 1%. If we consider safety, the complication rate is also less than 1%, and this is in 19 published studies. And if we look at complications, most of them are quite self-limiting in the outpatient clinic. Diagnostic hit rate is very important, and sensitivity of taking outpatient biopsies is reported between 64 and 97%, and specificity between 87 and 100%. And you might wonder, what do you do if your biopsy just, for example, shows carcinoma in situ? Well, it depends really how sort of comfortable you are as the next step. And sometimes I know that if we can take a deeper biopsy, I will just go for that again in outpatients. But in other patients, I will bring them in for a GA if I'm worried that it's very deep or submucosal. But I'd also like to point out that just because you're doing a general anaesthetic biopsy of a patient, it doesn't ensure that you will get a cancerous diagnosis the first time. And in fact, one patient that springs to mind quite recently had a tongue-based tumour that was mainly submucosal, and I got carcinoma in situ from the endoscopic biopsy. I brought them into theatre, took biopsies and removed 2 cubic centimetres of tongue base, and there was no cancer in that. And it was only on the second panendoscopy. So these patients that have tumours that are difficult to biopsy generally tend to be difficult to diagnose anyway, I find. So can we look at the effects on the cancer pathway? Well, if we look at the literature, there are 4 studies published that focus on this. And this is all quite recent in the past few years. But the days saved on the cancer pathway are very interesting. So really, in the reported literature, the days saved are between 2 to 24 days, with a mean of almost really 2 weeks. And that's a very good reduction in sort of cancer pathway time. We've looked at this just with our experience, and since we've had our stacks, which we got in around July 2019, and since then we've put through about 500 odd patients with head and neck cancer, and in the pathway we have 244 that went through a local anaesthetic pathway and 287 that went through a general anaesthetic pathway. And if we look at these figures, well, one thing that I'd like to point out from a cancer pathway time is that we don't meet the 14-day criteria for seeing our patients quickly enough. And this is something that we're working very hard to improve, but it's very difficult with the sort of resources that we have and the amount of referrals that we receive. But this is something that we really need to work on. If we look at the mean days from clinic to biopsy, if we consider the local anaesthetic biopsy pathway, we're looking at 12.5 days for a biopsy. But for general anaesthetic, we're looking at 26 days. So when we come to consider our mean days from the USOC or urgent suspicion of cancer referral to the treatment decision, which in cancer pathway times is the 31-day target, which is laid out by the Scottish Government. So that's the time from which the GP refers the patient for you being able to make a treatment decision. In the local anaesthetic pathway, we're looking at almost 50 days for that, which again is still not very good. That should be 31 days or less. But the general anaesthetic pathway is 68 days, and that's a significant difference. But we're saving about 18 days from the pathway by biopsying them in outpatients. So if we consider safety, that's very important. There are 19 published studies that report on safety, and 14 studies don't report any complications. The ones that do report on complications look at things like vasovagal reactions, epistaxis, vocal cord hematoma, one more serious case of laryngeal edema, which led to a tracheostomy the next day in a patient that had a large transglottic carcinoma. And I think that obviously that is a concern, but you need to pick your case selection quite carefully. And in a patient with a transglottic carcinoma, you know, if there's bleeding into that airway, or that an airway is lost, then you would think if it was a real emergency, they would have to go to theatre that same day. So it may just be that, you know, that was quite a big tumour to be biopsying in outpatients. But it's interesting that author Wellenstein, in the same paper published, that state that anticoagulation is not a contraindication to local anaesthetic biopsy. Now, that's probably a slightly more complicated area, and certainly in our clinic we're a bit more cautious about anticoagulated patients. So if they're on aspirin or clopidogrel, we'll carry on and biopsy them. But if there's, for example, if they're on warfarinized or the DOAC agents, we would normally, especially if it was in the airway, we might stop or reduce the warfarin until their INR comes down a little bit. But the DOAC agents, we would normally withdraw them for a few days before taking biopsies. And it's interesting that these safety studies don't report any comparison with general anaesthetic panendoscopy. And I think that's quite an important omission, because if you look at general anaesthetic panendoscopy, there's not one of us that would say that procedure's without complication. And we can look at things like dental trauma, bleeding, conversion of marginal airways to tracheostomies, you know, perforation. There are serious complications that can result from general anaesthetic or panendoscopy, but they don't tend to be reported in the same sort of category. So that's something that needs to be looked into. So to round up, and you might be pleased we're getting towards the end of this, but the future, I think we really need to look at more studies on patient experience. This area is kind of sadly lacking. There's one or two studies that actually report that patients tolerate it very well. And anecdotally, that would be my opinion as well, that patients do tolerate it well, as long as you get those patients comfortable before you begin. I think the question we need to ask ourselves really for the future is that should outpatient biopsy be the first line diagnostic strategy wherever possible? Because when you look at the literature and look at our experience, I think we can safely say it's a safe process, and we can say that it can effectively shorten the cancer pathway. So those are my take-home messages, and that's all I would really like to say. So thank you very much for listening, and I'll take any questions.
That's a great lecture, Jenny. I totally agree with you. I think that the way forward is both outpatient intervention. It's not only because of the pandemic, but it is clearly shows it's cost effective, it's fast, and it speeds up the treatment process. It's well tolerated procedure. And one more thing I want to just point out, I know when your slide showed the sensitivity is 64 to 90%. I read the 19 studies because Jenny and myself involved in the systematic review. It's just about to be kind of submitted as well, the one gone for review. And the earlier scopes studies, which was published in Korea and America, they were using old fiber endoscopes. The old fiber endoscopes has got some disadvantages, but the newer ones actually called the chip in the tip, and that has got a 4K quality, HD quality, and actually it dramatically increases the sensitivity and specificity. Especially the working channel from the endoscopes are much superior,
and the biopsy forceps are also good. So the recent studies actually quoting the sensitivity and specificity is much, much higher. In fact, they're very close to 95%. If you exclude the earlier studies, which was published 10 years ago, actually it's a 10 years old technique, but we are popularizing it now. I think there is a question from our trainee, Rashad. Jenny, can you able to see the question, or do you want?
I'm just trying to see how I can see that.
In Q&A.
Q&A, sorry about that.
That's okay, I can read it.
Anesthetics are done pre-imaging. Yeah, so you're quite right, Rashad, that yes, they are done pre-imaging. But what you can, I don't have any major concerns about upstaging a tumour on imaging, and that's certainly not anything that's been reported in the literature. As Jay says, we've done very extensive reviews into the literature lately. But the biopsies that we're generally taking are a lot smaller. So we're not creating any new big cavities in a tumour that it could potentially create a lot of surrounding edema. And that is that's one of the good things about it, is it's a relatively atraumatic procedure compared to big chunky biopsy forceps. And that has a knock-on effect for pathology. And I had to discuss this with our pathologists when we started doing this. Were they happy with the biopsies? Were they able to process them? And they are, because this is the size of biopsies they get from other specialties like urology and upper GI. So there's not really been any problem with us sort of from a pathological effect or from upstaging on imaging. But thanks, good question. And then there's a question about xylocaine spray. And yes, you're right. So I think, although that says exclamation 0, you can use 10% spray as well. We use 4%. That's just what we use in our hospital, and it works very, very well. But yes, you can use 10%. Xylocaine lozenges, yep, you could also use that. We looked into that with our pharmacy, and I think basically what they came down to was what was cheaper, and the 4% seems to be the most cost-effective thing for us. Michael Hopkins asks, do you bring suitable patients back to a specialist biopsy clinic, or can you do them at the initial clinic appointment? Well, yeah, you can see that because our median day to biopsy is, for local anaesthetic biopsies, is 12 days. So if the patient comes to our diagnostic clinic, we can biopsy them same day. But a lot of our patients with cancer will come from our colleagues that refer them to us for outpatient biopsy. So you can bring them back. But usually that's just another patient that's referred in, but usually we'll biopsy these on the same day. So specially angulated biopsy forceps, there are not at present, but actually we're working with a company to make a slightly angled one that I find is quite good for biopsying tongue-based lesions. And it's just like a slightly longer, more angled version of the oral biopsy forceps. And the difference is that the biopsy forceps actually side opening, because what you want to do is open the jaws of the forceps and push that down on top of the tumour to biopsy these sort of like close to the sort of anterior tongue-based tumours. And the reason that I'm doing that is purely just for speed. So I can take 1 or 2 little samples from those patients and they're way out the door. But if I'm using my endoscope, I want to take 4 or 5. So it's just purely to make that that easier. KH asked, do we attempt transnasal esophagoscopy? No. You can see that we are struggling to maintain any sort of cancer pathway targets, and we don't do esophagoscopy routinely in these patients because when you're assessing head and neck cancer, we only really need to assess their esophagus if we're suspecting a second primary. And imaging is good enough such now that we can rely on imaging to upstage a tumour or highlight us to a second primary. So we're not routinely screening the esophagus in these patients. And that's a step away from older practice, but that's I think more modern practice. I think that might be all the questions.
Yep, that's brilliant. So a lot of questions I think we have answered since morning, so more than 48 questions. That's great. I think it's become very interactive.
I think Stuart, sorry, Mr. Murray, Dr. Murray wants to say something.
Yeah, sorry, I was just going to support Jenny and say that she had touched on anticoagulation and antiplatelet treatment. I suppose we've got 5 years worth of data for outpatient biopsy in one of our peripheral hospitals. So it'll be 400 patients, and allowing patients to stop a DOAC the day before, or accepting patients on warfarin with an INR of up to 2.5, which would cover pretty much all atrial fibrillation or PE related indications for anticoagulation, that we've had no complications from that. So I would think that the future would be reasonably rosy for adapting the pathway slightly to be able to accommodate patients with anticoagulation.
Yeah, and I think that's a very good point, Murray. So there's a document produced by the sort of national dental surgeons that look at anticoagulation and dental extraction, and they recommend that you can continue sort of performing dental extractions in patients that are actively warfarinized up to 3. So I think if you can take out a tooth, you can take a small sample from their tongue. So yeah, thank you. Good point.
Brilliant. Thank you very much. I think we come to the last part, but not the least one. Shine is one of our trainee who is going to make it more interactive, but she's going to touch base some basic anatomical kind of questions, as well as the treatment questions, just to answer some of the exam-based, but it is not a true representation, but it is just stimulating your knowledge and enhancing your lateral thinking. That's what I would put it. Okay. And this one.
Can you see my screen?
Perfectly. And I stopped the recording as well.
Can you see my screen?
Yeah, I can see your screen.
Okay. Thank you, Jay, for the invitation to talk on our study day, which is an honor. Unlike our previous Perth study day, where we are able to meet in person, and this is now going online. And I also want to say I certainly enjoyed the presentation throughout the day, and it was a really excellent coverage and certainly mapping to our study syllabus. And for those that who don't know me or haven't met, my name is Shane Hay, and I'm currently a registrar in Edinburgh, working on my final stage of training. So before I proceed, I just want to declare there's no conflict of interest to disclose, and all images used here are available from open resources from Google. So when I was discussing this talk with Jay, he's keen for me to share my experience of sitting the Part 1 exam. And for me, this was just before the pandemic. So after passing the exam, the pandemic obviously hit in March time, and given our exam sitting seems to always be in sync with the national COVID cycle, we had to have our Part 2 postponed from April to November last year, which was carried out successfully, but in a contactless and minimal patient setting. But the focus today will be mainly Part 1 of the FRCS, which is set as the final academic hurdle before the award of CCT can be made. So for trainees currently in the UK training program, you can apply for sitting the exam once you have an ERCP outcome 1 at ST6 level. And for those who are not in training program, you have to develop equivalent competency. You will then require 3 referees who are ready to testify. You will be ready for day 1 consultant level of knowledge, one of which will be your TPD, and another one will be your current educational supervisor. Following that, you will need to provide your up-to-date CV and e-logbook to show that your competency is commensurate to your level of training. And most importantly, you then need to have your payment card ready, as you will need to pay it all up front, and which at the latest count, when I set it, it was about £1,900. So the exam runs twice a year, and you can find the exact date from the JCIU website. There's a January and a July sitting, And be minded that the closing date is usually 3 months before the actual date. And so it is important to have your paperwork ready beforehand. So for those who are not familiar with their exam yet, so part 1 exam is a written exam, and the format has been revised in January this year, and it is now going to be 2 single best answer papers, and we will have a test of that later on. So it is held simultaneously across the country, and in the UK and Ireland, it is mostly at the Pearson VUE driving centres. As it is a driving centre, you may well be the only person sitting the FRCS exam while you check in, and you see some young person checking the same time as you while they're just there to sit their driving test. So there are 2 papers on the same day. They're all computer-based. I think for practical tips wise, you don't have to sit the exam in your deanery. You can choose anywhere in the country that's closer to you. And it is useful to get advice from the centre to see the noise level, as it can sometimes aid your choice of venues if you have more than one available to choose from. I personally didn't ask for it, but I'm aware some centres may offer private rooms if you write to them in advance. So my experience in Edinburgh was a very big room when I set the exam, and there were computers just on all 4 walls. I was put in one corner, and there are people coming in and out most of the time as they sit other exam, for example, a driving test. But they are very well supported in a way that they will try not to interrupt you. So there will be 1 paper in the morning, followed by a lunch break of around an hour. Lunch is not provided, and then followed by the second paper. So in total, there are 120 questions in each paper. There's no negative marking, so it is useful to attempt all questions. And having spoken to others who set the exams too, time is often limited, so it is important to keep up the pace. As you can see, for 2 hours, 50 minutes, each question is work out about one minute or so. So it is also something to focus during your revision as well, to develop the mental stamina required to face 240 questions all on the same day. So without say, it is curriculum based and aiming to cover the breadth and depth of the syllabus, which you can find on the JCIE website as well as the ISCP website. The pass mark, it varies, and this is dependent on the difficulty of the exam and will be subject to standard setting process that happened after the exam. So once you enroll yourself into the exam, you have 4 chances to pass part 1 in 2 years' time. So it is no doubt that prepping for the exam is a potentially stressful time for most, as you will be nearing the end of training, and there's always multiple aspects of both work and family life competing for your time. And you also be developing surgical competency, potentially staying late at work, and young children at home. So, I mean, the time to start revising varies. I started properly revising actually on the day I paid £1,900 because I felt the financial pinch. So the MCQ, as you would imagine, is actually more textbook knowledge based. So everyone I talked to before the exam has a slightly different approach, ranging from, reading Scott Brown, which at the time of my sitting was a 3-volume set textbooks, and the paper copy certainly weighs about 7.5 kilograms. I use it as a reference if it's useful, and there are also on the market other textbooks which are more exam targeted, and they are all very good. And there are certainly materials and questions that go around, and when you come to the exam time, you'll probably have your senior handing you this mysterious pen drive or a folder that have all of them in. And having used them, they are useful, but they don't necessarily represent the actual exam. But what I find they are very good for is actually the practice and reading around the question to see what the scope of the exam usually cover. And they also help consolidate the knowledge as I go along. So as per Jay's request, I have prepared a series of 12 mock questions that we go through in the form of an interactive poll. Some of the questions are quite lengthy, and it is actually the same thing in the exam too. So sometimes reading the question takes up your 1 minute per question, but they are actually quite clinically orientated. So the way I'm going to do it, we're going to leave the question up for about 20-30 seconds for everyone to vote, and then followed by some short slides to explain. for them. So before we start, I just want to let everyone know the votings are anonymous, so even panelists can't see what your individual choice is. So in case you are worried of, being judged, so do try and take part and as we go along. So let me see, we can get the poll up. Okay, so the poll will come up and there will be A to E answers, and you can choose the single best answer, okay? Sorry, this is a bit clunky, so I have to put it up first. Okay. This is the first question. A 65-year-old man, 1 month after radical neck dissection, has reported numbness over the lateral surface of the ipsilateral upper arm. Which of the following is likely to be affected? So we can see the answers are coming in, and I'm going to leave it for a bit longer before we close the poll. So have your answer as you go along. Okay, we've got half of the participants voted already. So I think once we hit about 60 to 70% of vote, we're going to close the poll. Okay, so I'm going to share the results, and I'll have to close this so that we can move on to the next slides. So the answer is C5, and this is a question that is not uncommonly encountered, testing your knowledge on the dermatome of your upper limb. This is a very rare occasion available in case report when I encounter this kind of question, and C5, as one do radical neck dissection, can sometimes get injured by the nerve root if you're not careful. So that's the first one. So this is the second question. Okay, so what is the primary blood supply to the deltoid pectoral flap? Answers are coming in. And we're going to leave it up for another 15 seconds before we close it, which will be about a minute. Okay, so we're going to end the poll here, and we're going to share the results. Okay, so it looks like the audience is quite divided on these, and I'm going to stop sharing the outcome so that we can see the results. Okay, so the answer is actually C, the internal mammary arteries. Okay, and what I'm going to then show you is a table that is often very handy, as the exam revision Pearl textbook will tell you. So these are the common flaps and the common blood supplied. Pec major is the pectoral branch of the thoracoacromial. Radio forearm is radio, it's quite easy. And lat dorsi, thoracodorsal. Sternocleidomastoid is also a common exam question where it is segmental, and it depends whether it's upper, middle, or lower. And the upper is occipital, middle third is actually superior thyroid, or could be branches of the external carotid, whereas the lower third is thoracocervical trunk, and more than 80% come from suprascapular. So for the dectopectoral flap, it is the fasciocutaneous flap, and the fascia comes from the pec major itself, doesn't involve muscle. And textbook normally say it involves the first 4 perforators of the internal mammary artery, but the second one is usually the largest. It has its pros and cons. It's probably less commonly used these days, but it has got a very reliable blood supplied, large amount of tissue available, although on the distal tip can have a necrotic effect. And it depends how you're going to close it, but normally primary closure is aimed for, but often you require a split skin graft for donor site, and you may need second stage for detachment as well. It is commonly relegated, although at the very beginning of its invention, it was very popular, is currently being more relegated to closing a large cutaneous neck defect. Okay, so we're going to go on to the next question now. Okay, so a 55-year-old lady who has primary Sjogren's syndrome, concerned with a parotid swelling that is painless and does not settle. What is the commonest malignancy associated with her Sjogren's syndrome? Okay, can leave it for another 15 minutes to make it for 1 minute. Sorry, 15 seconds for 1 minute. Okay. So it looks like the majority has voted for non-Hodgkin lymphoma. And yes, indeed, the answer is actually non-Hodgkin lymphoma. And if you look up the British Society of Rheumatology guideline, the management of adults with primary Sjogren's, lymphoma is a big risk for this patient. So just to recap, Sjogren can be divided into primary or secondary being those associated with any connective tissue disorder, for example, rheumatoid arthritis. So the risk of lymphoma in primary Sjogren's, based on the guideline, is about 3% in first 5 years, and it can go up to 10% in the first 15 years. And it's actually 40 times the population risk, and the majority of them is mucosal-associated lymphoid tissue, hence they are non-Hodgkin lymphoma. And compared to the in general patients who have got Sjogren diagnosis, if they do develop lymphoma, the median time is about 7 years after the Sjogren disease being diagnosed. And the recommendation for this patient, the answer is actually regular clinical assessment, although I'm aware some units scan them on a regular interval. But it's important to warn patients to report firm painless swelling that doesn't go away. And in this group of patients, it is actually not uncommon for them to get intermittent parotid swelling, but most of them can settle. And certainly the ones that don't go away will need further assessment. Okay, and so we're going to go on to the next question now. You review a 52-year-old female in clinic, and she was referred for recurrent blisters on the mouth and throat that weep easily and rub on the teeth. What is the most likely diagnosis? Okay, we're going to leave another 10 seconds. Okay. So looks like it is divided between Behçet's disease or bullous pemphigoid. And I must say these are the things that I didn't know very much about prior to sitting the exam, but certainly they are very popular. And if you look up the syllabus, they are actually in there. So it can be a valid exam question, essentially. So the answer is actually pemphigus, and we will talk about this part of the autoimmune oral condition. And so this is basically the picture down here on the left side is pemphigus, and this is pemphigoid. The way I remember it is pemphigus as an S, so it's superficial, and D is for deep. So they are slightly different in their presentation. So coming to the oral lesion part, oral lesion is actually much more common in pemphigus and is actually rare on pemphigoid. And the reason for that is because of the biochemical part, where the autoantibodies in the pemphigus actually attack the intracellular bridge, which is a gap junction protein within the desmoglein 1 and 3. So compared to the pemphigoid, it is attacking the basement membrane. So because of that, it gives you a different character of the blisters, where in the pemphigus, the more superficial one is within the dermal layer, the epithelial layer. So the blister is actually much more superficial and is very flaccid and is easily ruptured. Whereas the one in pemphigoid, because it's deeper, attacking the basement membrane, you have your entire epithelial clefting. So your epithelial swells up and the whole blister become very tense and firm and can often be hemorrhagic in appearance as well. Minkowski sign is also something very commonly asked and in the exam. So basically it is a sign that just on rubbing or having any trauma on the uninvolved mucosa can produce an ulcer. And as you can imagine, of the biochemical property in pemphigus, this is going to be more likely. Okay, so we're going to go on to the next question now, relaunching the poll again. So which of the following statements regarding the superior parathyroid is true? And okay, answers are coming in. And we're going to leave for another 15 seconds to have a minute in total. Okay. Just going to leave it a bit longer as answers are still coming in. Okay. So looks like the majority has gone for B, where, okay, so the answer is actually C. It lies in the dorsal plane to the inferior parathyroid gland. I will go through these, and I must say questioned courtesy of Mr. Nixon. So if you go through each of them, and we can see what why they are not true. Okay, so just a quick recap on the superior parathyroid gland. It is actually of the fourth pharyngeal pouch origin and not cleft. Okay. And this is a common thing you'll find in exam, where there's this kind of minute thing that you have to pay a lot of attention on. So coming up to its positioned, because of its embryological origin, it's positioned is actually less favorable than that of the inferior parathyroid gland, which originates from the third pharyngeal pouch. It does lie in the position normally superior and posterior to the inferior thyroid artery, as compared to the inferior parathyroid, where it is located inferior and posterior to the artery. I'll show you a picture later on to better understand this, because words often is very difficult to describe them. Its normal positioned is actually not true, because they can lie dorsal to the esophagus, but they are quite rare. And they don't normally have a fixed relation to the superior laryngeal nerve. Okay. And this is what we were talking about earlier. And you can see this is the inferior thyroid artery, that's recurrent laryngeal nerve. And this is the inferior thyroid gland, which obviously these are anatomical descriptions, and position can often vary, but these are the common situation you will find the glands in. And superior thyroid gland is normally posterior and superior to the inferior thyroid artery, and also with the recurrent laryngeal nerve as well. And this is a slightly different view with a retraction of the carotid and juc, and you can see the inferior thyroid artery coming out here, and that's your upper and lower, superior and inferior parathyroid glands. Okay. So I'll just move on to the next one then. So we now have question 6, and start the question now. So a 59-year-old male, performance status score 0, undergone laryngectomy, neck dissection, PT3, N2A, laryngeal SCC. Excision margins negative, nodal disease confirmed in a single ipsilateral, less than 3 centimeter, and ENE positive. What is the likely recommended management, you think, for this patient at the MDT? Going to give another 5 to 10 more seconds. Okay, so it looks like the audience is divided between adjuvant radiotherapy and adjuvant chemotherapy. Okay, so I need to stop sharing the results for us to move on. So I put it answer as adjuvant chemoradiotherapy. And if we go back to this question, and the actual clincher is actually the extranodal extension. And this is talking about the chemoradiotherapy in head and neck SCC. There's 2 main indications really. One is in the organ preservation setting, as many other speakers have talked about today, where they are using in stage 3 and 4 disease as a curative intent, and whereas in adjuvant setting in a high-risk patient, there are 2 main criteria that are used. Patient will be given chemoradiotherapy or recommended for them in your MDT if they have got the following 2 features, which is positive margins and extracapsular spread. And talking about the use of chemoradiotherapy, there are 2 landmark papers that are commonly quoted in the exam, and started with Pignon et al. In 2009 and subsequently updated by Blanchard et al. In 2016. So is the MAC-HC study. So the latest study has got 100 randomized controlled trial, close to 19,000 patients. So the conclusion is that the addition of concurrent chemotherapy to radiotherapy confers an overall 5-year survival advantage of 6.5%. And the survival benefit is proven in patients up to 70-year-old, but without, given concurrent treatment with chemo or radio, certainly increase the toxicity. However, it does have the survival advantage. So back to our patient earlier, if we're thinking about it, this is T3 N2A disease, but there is extranodal spread despite the node isn't very extensive. So this is the reason why chemoradiotherapy will be given in this setting. Okay, moving on to the next question. What is the most appropriate treatment for a T1 N2B SEC of lateralized tongue, assuming the patient has no contraindication to any curative treatment? Okay, we'll leave for another 15 seconds. Okay, so it looks like the majority has gone for surgery and adjuvant therapy. And that is indeed the case. And the reference come from Barno guideline, which was mentioned earlier in Dr. Montgomery's slide. So the standard treatment for a lateralized oral tongue cancer is primary surgery followed by adjuvant therapy as dictated by pathologic risk factors. And that patient, if you remember, is T1N2B. So it's a stage 4 disease. And so you will require dual modality as the minimum, but primary radiation therapy is not commonly given in oral tongue cancer simply because of the high side effect profile, and surgery is often the mainstay of treatment, followed by adjuvant therapy. Okay. So coming to the next set of questions. In the mechanism of swallowing, which of the following is not part of the pharyngeal phase? Okay, another 15 seconds. Okay. So it looks like a majority has gone for C, which is pushing of the foot bolus into the oral pharynx. And that is correct answer for that. And in the pharyngeal phase, the aim is to get the food down from your pharynx into your upper esophagus. So swallowing phases, very popular exam questions, even in part 1, even in part 2. So just to go through them very quickly, in the pharyngeal phase, after your oral preparatory phase and oral actual phase, which is conversion mainly of solid food and making them into the bolus, and then put them at the back of your tongue, pushing them into the pharynx, where all these last pharyngeal phase lasts for seconds, but it's a very busy stage where you will want to make sure everything goes further down. That involves sealing of the soft palate with closure of the nasopharynx, superior constrictor come together, squeeze food, and then you need to protect the larynx in this case, where there are a few things that need to happen, including stopping breathing. Larynx comes up, epiglottis fold downwards so that food can fly over it, going downwards into the esophagus, and there's layer of closure, steps of closure of your larynx step by step before the upper esophageal sphincter open up to relax. And then that's your esophageal space phase that's triggered following that with peristalsis. Okay. So let's move on to the next one. So 37-year-old discussed at MDT post-op, curative surgery for right oropharyngeal malignancy, pathology confirmed 1.8 centimeter tonsillar HPV positive SCC, four involved nodes, largest 4.5 centimeter, margin clear, no distant mets. What is the pathological staging for this patient? Okay. So we're going to leave it for another 15 seconds, as we are now past 1 minute. Okay. So it looks like we have a small majority going for A, which is T1, N1, M0, and which is the correct answer. And the key part here is, sorry. The key part here is HPV positive. And I'm sure there are, this is touched on a few talks earlier, where HPV positive on the 8 addition has got a new staging system on its own. And the caveat here is also the 4 nodes involved, and we'll come to look at it later. So having a bit of revision here for HPV positive patients, there is a clinical nodal staging system as well as pathological nodal staging system. And this is different to the other head and neck SCC and also HPV negative SCC nodal staging. So patient has got 4 positive nodes, and in the P-nodal staging, there is only N1 and 2, okay? And it's equal or less than 4 nodes, that will be it. And if you remember, the primary was 1.8 centimeter, so that's T1, and it will be T1, N1, okay? And if you look at the T staging as well, this is slightly different. And in the T2, which stays the same, T3 is also the same, but T4 compared to HPV negative oropharyngeal, there's no T4A or T4B anymore. And certainly in the clinical nodal staging, there is no further breakdown within N2, between N2A to N2C, whereas they're all grouped into N2, which is generally representing the consensus of downgrading the system in TNM staging for HPV positive disease because of a better prognosis. Okay. And this is a 10 question we have here. 70-year-old man, smooth painless swelling, medial displacement of right tonsillar fossa, tonsils removed as a child, no visible lump in the neck, solitary mass in post-thyroid compartment. What is the least likely diagnosis? Okay. Answers are still coming in. Just going to leave you for another 5 more seconds. Okay, looks like audience is quite divided on this one. And so this question requires the knowledge of your understanding of parapharyngeal space, whereas pre and post styloid compartment, and each of them has got a different content. So the answer is actually liposarcoma, which has got its origin in fatty tissue coming from lipoma. And this is parapharyngeal space anatomy for a refresher. So if you think about it, this is medial lateral aspect, and there's the top, bottom, and a skull base on the superior edge, and it's inverted triangle, basically, inverted pyramid, ends on the hyoid side. So on medially, you have soft palate, superior constrictor tonsils, and anteriorly is the pterygomandibular raphe. Laterally, you have your deep lobe parotid, and depending on the level, you've got your ramus of mandible as well. So the content of pre and post styloid is popular, not just in part 1, but part 2 as well. So you have all the, in post styloid compartment, the predominantly vascular and neurogenic tumor because of the content in there. So you have your internal carotid, IJV, lower cranial nerve, sympathetic chain, lymph nodes. So lymphoma can actually happen in both because they are in both pre and post styloid space. Whereas in pre-styloid space, they have fat, parotid, plexus, V3, which is your trigeminal schwannoma, which can come up sometimes. And so if you go back to the question earlier, the least likely diagnosis will be liposarcoma, which is a fatty content that is predominantly localized in pre-styloid parapharyngeal space. Okay. Moving on to the second last question. Which of the following statements, the following are true of angioedema, except which one? Shit. Okay. Okay, another 5 more seconds. Okay, so the majority gone for A, and I'm sorry, there was a glitch in my slide earlier as my phone fell down to the power button. And okay, so angioedema is also a question that is very popular in part 1 exam, and the correct answer is indeed autosomal recessive. It is actually an autosomal dominant pattern of a congenital form of angioedema, and that's why it's very important to ask patients about their family history. And also talking about other types of angioedema, and ACE inhibitor-induced angioedema, which we commonly encountered, is actually due to bradykinin excess, and that is true. And simply because angioedema is a condition where there's leaky fluids coming out, causing swelling of the soft tissue. So bradykinin is a very potent vasodilator, and that's why ACE inhibitor is used to lower the blood pressure. So in ACE inhibitor, because it prevents the degradation of bradykinin, so resulting in excess, and that can then result in angioedema. And interestingly, it can happen at any time during the commencement of therapy, and certainly after stopping the medication, it can also happen. Hereditary form, the congenital form, is actually mediated by C1 esterase inhibitors deficiency. There are various subtype of them, and some of them is actually due to dysfunctional of your C1 esterase. Whereas in acquired angioedema, the pathway is slightly different. It's no longer bradykinin or C1 esterase inhibitor relevant. It's actually mediated by histamine. And certainly without, say, going for a more severe case, you will need to think about airway management. So this is where we have here. And certainly also important to remember that ACE inhibitor-induced ones are much more common in Black patient, women or smokers. Okay. Now this is last question. In medullary thyroid carcinoma, all of the following are true except which one? Okay, I'm going to have another 15 seconds. Okay, so we have audience going for C as the popular answer here. And the answer is indeed C. Okay, and as Mr. Hilmy's talked earlier, medullary thyroid carcinoma is a much more aggressive disease and is slightly different to other differentiated thyroid carcinoma. Predominantly, they are non-familial type. 75% is sporadic, only 25% is familial, and in the familial type, there is MEN2A and MEN2B, which have got worse prognosis in M2B, and they are both associated with red proto-oncogene. And also, as Mr. Hilmy described earlier, radioactive iodine has no role in this treatment because it does not take up iodine. And this is where we can see here. So parafollicular C cell in origin produce calcitonin. That's why it's useful as a marker in surveillance. And with red proto-oncogenes, it is chromosome 10. And I just have a recap on the men's syndrome. So 2A and 2B, they both can give rise to MTC, whereas FIO as well is also common. And the differentiating features is parathyroid hyperplasia in M2A, whereas the mucosal neuroma and marfanoid symptoms are actually in M2B. So that brings us to the end of this series of interactive poll. And I just want to say thank you for listening and thank you for your participation. I hope this has been useful. And if you have any question, then obviously I'm happy to help.
Thank you very much, Shami. That's absolutely wonderful.
Jay, are you muted? I can't quite hear you.
Can you hear me now?
Oh.
Great. Yeah, can you hear me now?
Yes, yes.
That's great. Thank you very much. It's been wonderful. Thanks a lot for sharing. It was a really mind-blowing type of mind-stimulating presentation, actually. I openly admit that I only passed only 50% actually last. So thank God I'm not taking any exams. But it underpins you have to read anatomy and also understand the management plan, and also you need to be a little bit smart in reading and the questions as well. And that's great. But we're coming to the end of this program. I'm very grateful to all the faculties and also all the Scottish trainees who has given me the opportunity to kind of lead this day. And in fact, actually, from various free channels we opened, nearly more than 400 people attended this event. Actually, you may not realize that, in addition to this one channel. And that's what my analytics shows in my computer. That's great. I think
one of my exit plan from the head and neck cancer treatment is teaching and research in addition to botany and cycling. Well, I'll continue to arrange some programs similar to this one. I think we have one coming up in the Scottish Radiology ENT virtual course. It's also completely free. I think it's already 300 people already registered for this event in 12th of April. I think after that, we have a Scottish Head and Neck conference as well in September, as usual. I think that's it, really. I'll make sure this recordings, except Shane's one, is available for you to watch later, because there's too much information one day that is also by virtual medium. But that's the advantage. We can record it and we can allow you to watch later at some point or whenever you need. Okay, thank you very much indeed. I hope you enjoyed today, and thanks a lot. I'll close the meeting.
Thank you, Jai, for all your hard work.
Thanks a lot, all the faculties and Shaki.
Thank you. See you later.
Thank you, Jai. Bye-bye.